to the console. All the doctors who have come for the paper presentation, kindly upload their papers. सभी डॉक्टर जो पेपर प्रेजेंट करने के लिए आए हैं उनसे अनुरोध है कि अपने पेपर का जो अपलोड है वो आगे कंसोल पे करवाएं, जिससे हम प्रोग्राम जल्दी से चालू करना चाहें. पता लगेगा यार, उन्होंने 4-5 पेपर भेजे, उनने आए तुम. हाँ, तुमको अपलोड करेंगे, चालू करेंगे फिर. तो कम आए तो बढ़िया.
ज्यादा ना मेरे तरफ पीछे ही नजरों से मत देखा.
गुड मॉर्निंग, नमस्कार, डॉक्टर सूद सर, सबको लुवाले जनता से वी आर स्टार्टिंग द प्रेजेंटेशन नाउ. Welcome for this annual Habit Conference, 9th annual Habit Conference of North Delhi Fishery Forum. So straight away, before wasting time, we start the poster presentation. So the chief coordinator for this is Dr. Suresh Kumar. He is the principal of Baba Saheb Ambedkar Hospital. Dr. Suresh Kumar sir, please come on the dais. Dr. Suresh Kumar sir. And the judges are Dr. Ajit Singh, sir, please come on the dais. Dr. J.K. Sharma, very well-known figure. Dr. Hanish Gupta, leading gynecologist in Delhi. Dr. Dipesh Sood, he is a consultant physician. And Dr. Rakesh Sood, our past president of North Delhi Fishery Forum, please come on the dais. Now I request Dr. Suresh Kumar to start the proceedings. Thank you.
A very good morning to all of you. First of all, congratulations to Team North Delhi Physician Forum for organizing such a wonderful conference. In the morning session, we have a elite panelist, and each paper presentation would be given 6 to 7 minutes. And at the end of paper presentation, 1 or 2 questions are invited. And with the permission of Dr. Chavda and his team, we are now starting this CME program. Thank you. We can have the first paper. Meanwhile, at the opening ceremony and opening comment, I would like to have a few words from my co-panelist. You can say a few words about the conference.
Good morning, friends. This is really heartening to see that this early morning session also good number of participants are here, and this conference has been happening for last 13 years. I think this is the 13th conference this year, and this North Delhi Physician Forum is not any political party. It is a group of like-minded physicians, close-knit family doing all academic activities. And we can say that every member of this forum is a leader in himself. So I extend my heartfelt thanks for inviting me here, though I'm also a member of this forum. And now we are going to start. The first paper is by Dr. Mansi. The time allotted is, sir, 6 minutes? 7 minutes. So please finish in 7 minutes. Thank you very much.
Good morning, respected moderators, panelists, judges, and the distinguished faculties and my dear colleagues. I am Dr. Mansi Sharma from Jaipur Gadal Hospital, and today I am here to present a case when safe correction of hyponatremia was not safe and the patient developed osmotic demyelination syndrome. Why this case matters? Because it highlights the devastating consequences of overcorrection of chronic hyponatremia, and it explores a rare psychiatric presentation of beer potomania in a young chronic alcoholic user and emphasizes the importance of understanding pathophysiology and safe correction principles. And it stresses on the prevention strategies to avoid iatrogenic neurological injury. So, a clinical lesson that sometimes the treatment can be more dangerous than the disease itself. Beer potomania is a syndrome of hyponatremia that occurs due to excessive consumption of low solute fluid in the setting of poor dietary intake of protein and salt. So, we had a 23-year-old male who used to drink regularly chronic country liquor used for 6 years, and he was binge drinking for last 6 days and last intake on the night prior to admission. As per patient's family, there was 0 calorie intake from food for 5 days prior to admission. He refused dal, rice, and roti, subsisting entirely on the alcohol and water. Patient was apparently well 6 days back, and then he developed altered behavior, irrelevant talks, hallucinations, and persecuted delusions for the 5 days. And he had a very poor intake for 5 days prior to admission. Firstly, we thought that it is just acute psychosis, and we thought of admitting the patient in the psychiatric ward. And there was no history of trauma, infections, and any toxic metabolite, and there was no chest pain, no palpitation, and no shortness of breath, excluding the cardiopulmonary cause. On general examination, the person was disheveled, unkempt, and there was smell of the alcohol. GCS score was 12 by 15. Their pulse rate was 102 beats per minute. BP was normal. There was no orthostatic hypotension, and patient was tachypneic, afebrile, 98% saturation on room air, and CNX examination was grossly normal, but the reflexes were normal and bilaterally flexor plantar, which raised the suspicion of some neurological problem. And the musculoskeletal system examination showed the wasting of temporalis muscle. Abdomen cardiovascular examination, respiratory system grossly normal. And the lab investigations revealed a major severe symptomatic hyponatremia, that is sodium was 102 millimole per liter, potassium was 3, and phosphate was 2.1. Other electrolytes were grossly normal. Muscle markers were elevated, suggestive of muscle injury. And CBC showed mild leukocytosis, and toxicological screening showed the serum ethanol elevated, and methanol and antifreeze the ethylene glycol negative. CSF analysis normal. LFT showed mildly elevated pattern, suggestive of alcoholic pattern, and the endocrine and radiology scans, everything was normal. So we started sodium correction, and on day 0, that was 102, and patient was having altered behavior, hallucinations. On day 1, patient became more alert, and serum sodium was 107. And then day 2, 113, day 3, 118, day 4, 123. Till that, patient was improving in sensorium, and we were thinking that the patient is improving, and we were thinking that the patient will be discharged in the coming 2 or 3 days. But on day 5, patient suddenly deteriorated. There was sudden dysarthria, dysphagia, spastic quadriparesis. Then we suspected osmotic demyelination syndrome, and the serum sodium was 134. And 2 days prior, we stopped the 3% saline. Then we thought that it might be due to autocorrection, because the alcoholic patients, starved patients, malnourished patients, their brain is more sensitive, and they are more prone to osmotic demyelination syndrome. And after day 5, we started supportive management and PEG feeding, physiotherapy, and rehabilitation. And on day 6, we got the MRI done, and it showed the central pontine myelinosis and also extrapontine myelinosis. So we aimed at relowering the sodium with D5 infusion and desmopressin, and also we gave baclofen 10 mg thrice daily and tizandine. So patient was managed with nutritional support. Due to dysphagia, PEG feeding initiated on day 6. High protein, high calorie diet by PEG was given, and physiotherapy and rehabilitation done. Spasticity management by baclofen and tizandine, as I told earlier, and monitoring daily neurological assessment. Serum sodium monitoring every 6 to 8 hours initially, then 12 hourly. Electrolytes monitored and corrected as needed. And this is the outcome of the patient. Sodium maintained at 125 to 130 after overcorrection with D5 and desmopressin. Neurological status was initially weak, but it improved with course of the time. And on follow-up, he was advised strict alcohol abstinence, nutritional rehab, and regular follow-up. On discharge, the power of the patient was approx 3/5 in all 4 limbs. Dysphagia improved, and he was accepting orally. And with course of time, he improved, but some weakness persisted for permanent. So the take-home message is that in beer, country liquor, potomania, the danger is not just the low sodium, but its rapid correction. So recognize early, correct slowly, and monitor closely to prevent irreversible neurological damage. So every electrolyte tells a story. Some stories change the practice forever. Thank you.
Dr. Mansi, very good presentation, but you did not have a single report of urine osmolality or a single report of urine sodium.
Sir, we had, but due to time restrictions,
But that is a very
Sorry,
vital
sir.
thing. If we have to differentiate between hypotonic, hypervolemic, or euvolumic dilutional hyponatremia, then urine osmolality and urine sodium plays a very important part.
So-
The other thing that I would like to point out is that everybody knows about central pontine myelinosis and how overcorrection. Don't you feel it is not just the correction, but the overcorrection and the quicker correction that leads to these kinds of effects, neurological damage? So the emphasis is on the quicker correction and overcorrection. It is not about correction. You can go slow and you can go low, but the very fast correction or overcorrection in a matter of hours is what that leads to neurologic injury. That is the old adage and old learning about hyponatremia. Do you agree?
Yes, sir.
Okay. Thank you.
Dr. Bhatia, welcome.
डॉक्टर मानसी इट वाज अ वेरी गुड प्रेजेंटेशन वेरी केस इतनी अच्छी ओपनिंग हुई है कॉन्फ्रेंस की तो कॉन्फ्रेंस बहुत ही बढ़िया जाएगी शी डिजर्व्स अ बिग राउंड ऑफ अप्लॉज
Any other comment?
Sir, generally we estimate around 8 to 10 microgram per liter sodium correction over the 24 hours. The patient was alcoholic, and we thought that the patient was more prone to osmotic demyelination syndrome due to overcorrection. We aimed at 5 to 6 millimole per liter in 24 hours, and we achieved the same. But in spite of that safe correction, the patient developed osmotic demyelination syndrome. So
can use
overcorrection for that patient, not according to the guidelines, and it varies patient to patient. But the patient, in our clinical scenario, he developed that.
Please provide mic. You can speak on mic so that all other participants can listen. Mic आप उधर दे दीजिए.
Dr. Mansi,
We can move to the next. Thank you.
just a second. What is the specific about this case that we are presenting it here? Because it is a non-entity, it's a non-complication of the rapid correction and overcorrection. So what is specific about this case that here you are presenting?
Sir, the specific about this case is that we should not target about the actual normal sodium levels. We have to just protect the brain from the cerebral edema. So we have to rise the sodium very slowly. And
At what rate you gave the sodium correction? Just
Thank you, Dr. Mansi. We can have the second case. Dr. Suraj, go ahead with your case presentation.
Good morning to all of you. I am presenting a case of pulmonary actinomycosis. Myself, Dr. Suraj Rajput. My moderator is Dr. Ram Babu sir, senior faculty at Jaipur Golden Hospital. Case history, a 66-year-old female having these complaints for 4 to 5 days, high-grade fever with chills, with cough, with shortness of breath, and pain abdomen, generalized increased frequency of urination, and generalized weakness with reduced oral intake. On examination, patient was cooperative, conscious, and well-oriented to time, place, and person. On local examination, there is a round ulcerated lesion with central necrosis with surrounding erythema on left side of chest. Vitals, pulse rate was 112 per minute, regular. BP was 90/60 in right arm in supine position. Respiratory rate was 24 per minute. Temperature was 102.8 degree Fahrenheit. Mild pallor present. On respiratory system examination, bilateral air entry diminished at base with fine crepes. On abdominal examination, soft with mild epigastric tenderness. On investigation, TLC was 13,900 with USG whole abdomen show cystitis, dengue serology, typhoid O, TEMP serology, all are negative, viral marker are negative, 2D echo show mild concentric LVH with grade 1 diastolic dysfunction with EF of 58%. Montox was also negative. Chest X-ray show bilateral CP angle blunting and haziness. Clinical course and management, urine on 1/8/2025, urine culture came out to be positive for E. coli, blood culture was sterile. Based on culture and sensitivity report, antibiotic change according to the culture report and started on injection meropenem 1 gram IV 8 hourly. Despite all effort and continuous IV antibiotic therapy, patient still not improved and show clinical feature of high-grade fever with cough. So further investigation sent like chest CT, COVID RT-PCR, H1N1 sent, and respiratory reference was taken. CCT chest show nodular opacity in right upper zone with ill-defined haziness and mild right pleural effusion present. Subcentimetric mild enlarged mediastinal lymph node of 17x8 mm and discrete left axillary lymph node. Atelectic band seen in bilateral lower lobe, right middle lobe, and bilateral upper lobe. Respiratory physician did video bronchoscopy and ball sample sent for AFB smear, fungal smear, malignant cell, gene expert, along with lymph node biopsy for histopathological examination. Serum ACE level was slightly raised, 125. Ball histopathological examination show positive for actinomycosis. Histopathology show alveoli filled with pink eosinophilic pus positive radiating filaments surrounding by neutrophil and lymphocyte and histiocyte. Ball sample also came out to be negative for AFB, fungal smear, gene expert, malignant cell, but came out to be positive for Candida albicans. So we started on injection fluconazole and injection ampicillin 2 gram QID was started along with injection doxycycline 100 mg BD because family is not willing for use of injection penicillin after explaining adverse effect of penicillin. Repeated blood culture, urine culture was sent and found to be sterile. Platelet was high, 5.72 lakh per cubic meter. So reactive thrombocytosis. Number of fever spike reduced after starting injection ampicillin. Injection doxy and fluconazole were stopped, but injection ampicillin continued for 2 weeks. Patient shifted on oral doxycycline and fluconazole, and patient was discharged on injection ampicillin, tablet doxy, tab fluconazole in clinically better condition. On follow-up, patient came to follow-up after 1 week of discharge. Patient condition significantly improved with decreased fever spike. Injectable were stopped after 2 weeks of discharge, and patient shifted on capsule ampicillin 1 gram QID and capsule doxycycline 100 mg BD, and chest rehabilitation was advised. On follow-up, CT thorax after 2 months saw slight mosaic attenuation in both lung along with minimal cylindrical bronchiectasis in both lung in place. In comparison to previous CT filmed on 2/8/2025, there is a regression of bilateral pleural effusion. Now the patient is shifted on tablet augmentin duo 1 gram BD and capsule doxy 100 BD, and now patient is asymptomatic. Actinomycosis is a rare chronic granulomatous infection caused by a bacterial species, Actinomyces. Actinomyces is a gram-positive, non-spore forming, anaerobic branching filamentous bacilli. The infection was first reported in 1877 by pathologist Otto Bollinger and was characterized by suppurative granulomatous inflammation with sinus tract formation and discharging surface granule. There are 4 subtypes of actinomycosis infection: cervico-oral 60%, abdominal, pulmonary, and pelvic. Actinomyces israeli and generaceae are the most common cause of actinomyces out of 30 species. Actinomyces species are identified to reside in the soil and human microflora. Actinomyces are commensal in oropharynx, gastrointestinal tract, and genital tract. These species become pathological in immunocompromised patient or when crossing tissue plane being introduced to a new environment. Pulmonary actinomycosis is a rare bacterial infection caused by Actinomyces israeli and also known as thoracic actinomycosis. It is non-contagious but fatal if undiagnosed and left untreated.
Thank you, Dr. Suraj, for a very excellent presentation. Any comment from the judges?
Dr. Suraj, can you go back to the presentation where you started with the examination? Where is the previous slide for history? Do you have a slide for history where you took the history whether the patient is diabetic, non-diabetic, had a previous exposure, what is the
Sir,
dental?
वो slide ज़्यादा हो रही थी तो वो
अच्छा,
less
तो history ली थी ना?
Yes, sir.
That's what
Negative.
I wanted. So you, मतलब we would be interested to know in a patient like this that whether the patient is diabetic or not.
Yeah.
What is the dental
Non-
hygiene?
non-diabetic, non-hypertensive,
Has the patient
no
taken
any
alcohol?
chronic
Because
illness.
this kind of an infection usually occurs in patients who are type of immunocompromised.
No, sir.
Yeah.
All not known.
Definitely. What was the reason of that ulcerative lesion and how you have diagnosed from that actinomycosis?
क्या sir?
This ulcerated lesion which you have shown in this picture.
Sir, we did biopsy, but that came out to be negative for anything.
So what was the importance of that?
Sir, we think about scrub typhus infection or rickettsial infection. That's why we...
Any question from the floor audience? If any question, clarification? Yes.
One question before you go, just tell me what is the hallmark in pathology for actinomyces?
suppurative, sir, sulfur granule.
Yes, sulfur granules.
Yes, sir.
Okay.
That is very important. The appearance and the gold standard is sulfur granules, and the treatment you have already discussed, and I think this is a very good presentation. Now we can go to the next case.
Thank you, sir.
Thank you, Dr. Suraj. Dr. Sethi have two case presentation, two case presentation. Okay. So, Dr. Sethi, only one case presentation is allowed.
Only one. Is there any audio?
Go ahead. We welcome eminent physician of Delhi, Dr. Richa Diwan, ex-HOD and Director, LNJP Hospital. Dr. Richa Diwan is here. Thank you, madam, for coming.
नहीं ये नहीं ये मैं खोल देता हूँ ठीक है
Yes, Dr. Sethi, go ahead.
Good morning, everyone. Good morning, panelists and my fellow colleagues. So, I am presenting a case report regarding dengue fever. As monsoon is currently hitting the city, current scenario of dengue fever, we all know dengue is a menace that bites the capital every monsoon season. So, I'll be presenting a challenging case of dengue shock syndrome, which presented to us with secondary HLH. I am Dr. Sehat Singh Sethi from Action Balaji Hospital. So this is a case presentation of a 38-year-old male who presented to us with complaints of fever. The associated symptoms were joint pains, myalgia, abdominal pain, per-rectal bleeding, red-colored urine, and hematuria. This patient was referred to us from an outside hospital with a provisional diagnosis of dengue hemorrhagic fever and was transferred for management of complications. Patient had received some transfusions for thrombocytopenia and coagulopathy. 1 unit of SGP and 2 units of FFP was transfused. When we looked at the reports the patient had done at the other hospital, there was a 3-day analysis of CBC. The hemoglobin of the patient was initially 17.4, PCV was 46, and platelets were 30,000. Subsequently, on 7th and 8th, the hemoglobin dropped to 11, platelets dropped to 17,000, and subsequently in the next 24 hours, the hemoglobin fell critically low. It was around 7 and platelets was 29,000. It was at this juncture when the patient was referred to us at our hospital and we admitted this patient. Baseline LFT, SGOT, SGPT levels were raised. On taking we took the past history. There was no significant past medical history, no comorbidities, no diabetes, hypertension, no prior dengue infection. On physical examination, the vitals of the patient were normal. BP was 110/70, pulse was normal. The general survey, mild icterus was present. Rest, there was no pallor, no cyanosis, clubbing, lymphadenopathy. CNS, CVS examinations were normal. On auscultation, there was bilaterally decreased air entry, and on per abdomen examination, the abdomen was distended and there was splenomegaly present, and there was diffuse tenderness present. Bowel sounds were present. When we did our lab analysis, the CBC revealed critically low hemoglobin. It was 6.3, subsequently 7.6 after transfusion. The TLC count at our hospital initially was 8.56 and it rose next day to 13.5. PCV was 18.8, next day 22, and platelets were around 52 and 79,000. Serology, NS1 and dengue IgM both were positive. We did a procalcitonin to rule out sepsis. It was normal, and the INR was also normal. The liver function test revealed SGOT, SGPT levels further degraded, and the KFT revealed serum creatinine raised. It was 1.5, while the electrolytes was normal. Additionally, we ordered a peripheral smear which showed normocytic normochromic RBCs with thrombocytopenia and leukocytosis, no evidence of hemolysis. The LDH of the patient was 5900, which was very much raised. The corrected retics were 0.5, viral markers were negative. X-ray showed bilateral CP angle blunting. We managed the patient initially with 1 unit of PRBC, IV antibiotics, fluids, and supportive care. We also took gastroenterology and hemat references. Now, there was a diagnostic dilemma in this patient because there was rapid anemia in this patient. We expect relative polycythemia, but at our hospital, the PCV was 17 and 18, this range. We also did investigations to rule out hemolysis. There was no schistocytes. G6PD levels were also normal, but only LDH was raised. Also, this patient had increased white blood cells, which is a contrast in dengue. The TLC count of this patient was rising. The rationale for suspecting HLH in this patient was disproportionate anemia, which the patient had. The hemoglobin subsequently dropped from 17 to 7 in 48 hours. There was unexpected leukocytosis, and a combination of fever, cytopenias, and liver dysfunction hinted at the possibility of HLH, prompting further evaluation. The day 2 labs again revealed low hemoglobin, 5.9, 5.8. TLC count rose further. PCV was around 17 and platelets were rising. We recurrently transfused PRBCs to this patient. SGOT, SGPT levels recovered. Serum creatinine dropped down to 1.2. Electrolytes were normal. Now, for HLH, we suspected HLH in this patient and we did serum ferritin level, and the serum ferritin level came out to be more than 5,000. We did triglycerides, it was elevated 314. B12s were 921. We took a gastroenterology reference to rule out upper GI bleed, and hemat reference for bone marrow to rule out HLH, and transfused 1 unit PRBC for management as the HB was low. Subsequently, on day 3, the HB remained low. TLC rised further. Platelets were recovering. SGOT, SGPT levels were recovering. Serum creatinine was same 1.2. We did multiple transfusions. In view of HLH, we did a bone marrow first and then initiated pulse therapy of methylprednisolone 1 gram IVOD for 3 days. And there was massive improvement subsequently on the evening sample only. The HB, which was on morning sample 5.7, improved to 7.5. TLC count dropped down from 17,000 to 12.4. And the PCV also stabilized from 17 to 23. There were subsequent clinical improvement on day 4 of assessment. The HB rose further to 7.8. TLC was stable. Platelets were rising. Hemolysis probably stopped. Serum creatinine normalized. This is day 5 trend analysis. Similar values, everything was improving. This was the bone marrow report, which showed normocellular to hypercellular marrow with evidence of hemophagocytosis. So the core concepts of HLH is that there is a cytokine storm involved in HLH. There is fatal hyperinflammatory response. The pathogenesis included dengue fever, which caused immune dysregulation, leading to uncontrolled activation of macrophages, which led to a cytokine storm, release of INF, interferon gamma, interleukin 6, TNF alpha, which subsequently leads to hemophagocytosis and multi-organ dysfunction. This was a typical case of secondary HLH. There is primary HLH also, in which there are certain gene defects which cause HLH. Also, this case is important for internists like us because this mimics sepsis. There is a very high mortality associated with HLH, and the timing is also very important because early diagnosis will lead to a life-saving treatment.
Thank you, Dr. Sethi. We can have a few comments from judges.
Dr. Sethi, good presentation. I just want to, you said that it mimics sepsis, but actually it mimics bleeding. Because all the time the patient is having hemoglobin which is going down.
Yes.
And we are always suspecting in our clinic that the patient is probably having a bleeding, and that's why it is happening, but we are not able to find out the cause of bleeding.
Yes, sir.
What I want to understand from you that once you had actually got to the diagnosis of HLH, did you go for serum ferritin levels or PT-INR or other things which could have led us to believe that there is hemophagocytosis happening here?
Yes, sir. Sir, the HLH criteria is this. So we have to prove 5 out of 8 points in this. So the patient had fever. The patient had splenomegaly. I mentioned on the clinical examination. There was cytopenias involving more than 2 lineages. There was thrombocytopenia and anemia. We could not document hypofibrinogenemia. There was hypertriglyceridemia. Our case had 314 triglyceride levels, and there was evidence of hemophagocytosis on bone marrow. Also, the serum ferritin in our case was more than 5,000, while the guidelines suggest it should be more than 500. So we had more than 5 points to say that this was HLH, and also we calculate an H score based on this, and H score was more than 169, which is the cutoff for HLH.
On the clinical examination, did you find the spleen of this patient, and was the fever ongoing, continuous fever?
Yes, sir. I mentioned the spleen in the examination. Yeah.
It was
The patient
normal.
had approximately a history of 7 days of fever, which was recurrent every day.
Any question from the floor of house?
Fever.
If no question, then we can, carry on.
Fever beyond 5 days, very high ferritin levels, and persistently low pancytopenia.
Yes,
What
sir.
was the need for doing bone marrow in this patient?
Sir?
We should have given steroids and patient respond in 3 days.
Sir,
Why do you do the bone marrow, take the risk of bone marrow in this patient? Thinking
Sir, we suspected HLH, although we took the sample of bone marrow. The report came in 2 or 3 days, but we gave the patient a pulse therapy of MPS. Also, the definitive management is etoposide in secondary HLH, but we managed this patient with steroids only. Bone marrow was done for a definitive diagnosis in this patient because there were other DDs also which we had in our mind.
Thank you, Dr. Syed Sethi,
Thank you.
for a wonderful presentation. So if there are no more questions, we can have a next paper presentation. Any more paper? If there are no more papers, then we can, one paper is there. The last, I think this is the last one. Go ahead.
Hello, good morning, everyone. Myself, Dr. Shashank Sadhwani. Let's directly go into the case proper without wasting any time. A 61-year-old woman with stable rheumatoid arthritis, control for years on immunosuppressive therapy, presented with an unexpected crisis, that is sudden severe headache, acute hypertension, and progressive confusion. Initial concern was whether it is stroke or encephalitis, but the imaging told a different story. Recognizing this rare diagnosis within hours prevented permanent neurological disability and transformed a potential tragedy into complete recovery. Clinical significance. Why this case is unique? Why this case deserves your attention? PRES from leflunomide. PRES is posterior reversible encephalopathy syndrome from leflunomide, which is an immunosuppressive agent, is exceptionally rare. Fewer than a handful number of cases in the literature are published. Complete recovery after drug withdrawal is remarkable and clinically significant. Rechallenging at a lower dose without recurrence is rarely documented, suggesting reversibility when recognized early. This case demonstrates that every rare drug-induced neurological emergency can be completely reversed with timely recognition and intervention. The clinical unfolding, a patient in crisis. Patient was stable, years of controlled rheumatoid arthritis treatment on tablet leflunomide, 20 milligram once a day, and tablet hydroxychloroquine, 200 milligram twice a day. Presented with pruritus. Pruritus was progressing from weeks with urticarial plaques, which emerged with dermatological guided treatment, but soon during the course of hospitalization developed headache and hypertension. Patient was not hypertensive before. There was sudden severe headache, marked BP elevation. BP was 160/90. Antihypertensive drugs and analgesics were added. Despite adding antihypertensive drug, BP was in control, but headache persisted. On next day, patient was confused even, which developed a suspicion of acute encephalopathy. The clinical picture darkens when NCCT head was ordered and fundoscopy was done. Fundoscopy was normal, but NCCT head made the door open for an urgent MRI, which actually solved the mystery. The diagnostic crossroad between PRES versus stroke. At the bedside, the question was urgent. Is this stroke or something else? The imaging pattern provided the answer. There is a comparison which serves as a clinical reasoning tool that guide to the diagnosis, highlighting the features that favors PRES over acute ischemic stroke in this patient. So this is a table which demonstrates stroke versus PRES. A stroke in distribution is usually unilateral. PRES is typically bilateral. Imaging pattern, diffuse restriction image is well known. In PRES, there is vasogenic edema. Stroke will have persistent deficit if it's not TIA. PRES will have reversible, PRES is usually reversible with treatment. There is focal arterial territory in strokes where there is posterior symmetric pattern in PRES. Prognosis often permanent injury if not treated during the window or just outside the window. PRES will have a good prognosis with prompt recognition and drug withdrawal. The diagnostic timeline from crisis to clarity. On day one, actually patient presented to us with urticaria. Urticaria was managed well, but this severe headache where BP was just 160/90, BP was controlled with antihypertensive, but headache still persisted. So on day two, patient was confused. Ophthalmoscopy was done for refractive error also, and for fundoscopy also. Fundus was normal. NCCT head was ordered, which raised the suspicion for an MRI. MRI confirmed the diagnosis to be as PRES. We have already controlled BP by that time, so we just removed an immunosuppressive agent, that is leflunomide. We give pulse therapy of steroid after neurologist guided treatment, and headache improved over 5 days. Repeat MRI was done after 2 weeks, which showed radiological recovery as well. CT head finding. On day two, imaging provided the first crucial clue. CT had revealed bilateral ill-defined white matter hypodensities in the occipital lobe, a finding that pointed towards posterior pathology but lacked the specificity to confirm PRES. This prompted for urgent MRI for definitive diagnosis. Bilateral occipital white matter hypodensities were present. They were ill-defined. In posterior predominance, in parietal and occipital lobes were involved. There was no acute infarction or hemorrhage. Findings were suggestive, but not diagnostic of PRES. This finding prompted an urgent MRI for a definitive diagnosis. KFT and Surgipack were sent. I will answer it at the end why KFT and Surgipack were sent. The diagnostic revelation, MRI confirmed the finding to be as a PRES. MRI provided the definitive answer. The imaging pattern were unmistakable, classic for PRES. Bilateral, symmetrical, parieto-occipital hyperintensity, vasogenic edema, central white matter sparing, ventricle preserves. The path to recovery, that is intervention and resolution. Once PRES was confirmed, the treatment was decisive. The offending agent was removed. Blood pressure were carefully optimized. We actually optimized it before also, but patient showed no clinical improvement in headache and even developed confusion. So we directly go for high dose corticosteroid therapy along with removal of the offending agent, which was supposed to be leflunomide. The result was remarkable. Leflunomide was withdrawn, blood pressure was optimized, pulse steroid therapy was given for 5 days. Timeline 1 to 7, patient showed remarkable clinical improvement. Confusion and headache resolved completely. NCCT head was ordered after 7 days, which was normalized. While leflunomide was considered the most likely trigger in this page. Why did we conclude that leflunomide was the culprit? The evidence converged from 3 directions, each pointing decisively towards the same conclusion. The temporal relation. Leflunomide was for months. Neurologic symptoms began just acutely while taking it. Exclusion of alternatives like stroke, vasculitis, encephalitis were ruled out. MRI findings supported PRES rather than another cause. Evidence of causality, that is complete recovery followed by leflunomide withdrawal. No recurrence occurred on cautious rechallenge. Clinical decision making, how we reasoned through this case. First, stroke concern. I just explained why it was not stroke. CT was inconclusive. In LFT and KFTs were also normal. KFT we have sent because patient developed confusion. If
Dr. Shashank, just conclude. Your time is up. Just conclude. What is the carry home message from your presentation?
So the carry home messages, PRES is reversible, but only if clinician think it before irreversible brain injury occurs.
Okay, thank you, Dr. Shashank. Any question from panelists?
Comparative table with acute stroke, and you said in the last slide that through MRI findings to find out that whether it was autoimmune encephalitis or CNS vasculitis or stroke, we were able to rule that out. How did you rule out demyelinating disorders in this? Because demyelinating disorders would also respond to corticosteroids. And the presentation in rheumatoid arthritis for demyelinating disorders is going to be very high.
Sir, the MRI picture was very typical for the posterior involvement. The parieto-occipital lobes were very classically involved, bilaterally symmetrical, and there was no other history of any focal neurological deficit prior to the case as
But demyelinating disorders can present at any point of time, and it is not necessary that they should have an antecedent history. And any patient of rheumatoid arthritis, but the thing was, the trigger was that you find out that the medicine was given, leflunomide was given, and after withdrawal, the patient improved.
Patient clinically improved.
Any other comment from the house? Question? Please use mic. We are unable to listen to your question. You come forward.
Which other drugs cause PRES?
Yes, sir. Sir, just at the end, I have two tables. This table are taken from NEGM, that is New England Journal of Medicine. press because of hypertension is very common and we are treating it since ages actually. And there was a crossroad that press is just a different name for hypertensive encephalopathy. But soon they found that this table 2, there are certain drugs and toxic agents which are related to press. Chemotherapeutic drugs like bevacizumab, tyrokinase inhibitor, bortezomib, cytarabine, gemcitabine, T-aspergillus, methotrexate. Methotrexate was even a causative agent we found in this particular patient, but that was withheld way back because of some other side effect. Vincristine and cisplatin, immune modifying drugs like tacrolimus, sirolimus, cyclosporin A, rituximab, interleukin, TNF alpha antagonist, interferon alpha, pharmacological agents like erythropoietin, granulocyte colony stimulating factor, voriconazole.
Long list is there, Dr. Sank. You have already visible in your slide. Any other question?
These are
with
certain
this,
other syndromes.
we close this session, and you all agree that high quality paper presentation were there, and congratulations to all the students who have presented all clinically relevant high quality papers here. And thank you panelists for your comments and your mark which you have provided to me. We will declare the result in the lunch time. Thank you once again. Thank you.
Thank you all the chairpersons and the faculty for doing a wonderful job, and all the young doctors for their paper presentation. So I request all the chairpersons to please come on that presentation dais on the right side to see the award. The two announcements are there. As Dr. Suresh Kumar has said, result will be declared after the next session of quiz, and the prize will be distributed before the lunch. And the awards are: first prize is 3,100, second prize is 2,100, third prize is 1,100 rupees, and along with that, certificate of participation. So we are moved to the, yes, please. I request Dr. Chabra and Dr. Mundra to honor the chairpersons. So next is the quiz, and the quiz masters, as usual, is Dr. Mukesh Bhatia. He is a director of Bhatia Medical Institute, and ये हमारे सिद्धार्थ बासु हैं, the best quiz master. And the chairpersons are Dr. Pritam Gupta, I think Dr. Pritam Gupta, I think is supposed. Dr. Sunil Khetarpal, Dr. IPS Kala, sir, please come on the dais, sir. Dr. Gulati is also not there. Dr. Chuk, please come for the quiz. Dr. Sureka, please come for the quiz. So I request the chairpersons to start the proceedings. Thank you.
Bhatia, welcome as always, but I think you will have a limited time. You have got a lot of questions, but once you are explaining the answer of the question, please go slow. That is why we can pick it up very well, and that's very useful, even if you have to control your questions.
Thank you very much, sir. Well, without wasting time, as time is limited, so because I have only 30 minutes have been given to me. उससे पहले कितने पोस्ट ग्रेजुएट्स हैं? How many post graduates? Please come in the front. I'll request senior faculties to just go back. या अच्छा वहीं कितने PGs हैं? How many PGs? बस 3 लोग ही हैं. यहाँ आ जाओ. बाकी लोग कहाँ हैं? डॉक्टर बाबू कहाँ हैं? अब तो कह रहे बहुत सारे लोग हैं. और तीन ही हैं. बाहर क्या करें? पकोड़े खा रहे हैं. यहाँ आ जाओ. चलो, as there are Not many of the participants will go. जो लोग बैठे हैं, question are mainly for PGs. आ जाओ जितने भी आगे लोग हैं, यहाँ इधर आ जाओ. So we will not have team system. We'll have चलिए जी. Question are only for postgraduate, not for senior consultant. From all the senior people, we need your blessings. तो टीम नहीं है तो आप लोग ओनली पीजी अपने हाथ खड़े करेंगे जब मैं पूछूं तो. चलिए क्वेश्चन 1. Yeah. Which of the following changes in strong ion differences is most likely to produce metabolic acidosis? ये नीट का क्वेश्चन है. Increase SID due to loss of chloride, increase SID due to sodium gain, decrease in SID due to chloride infusion, due to acetate or due to lactate clearance. चलिए ओनली पीजीज हाथ खड़े करेंगे. ऑडियंस की हमें ब्लेसिंग और सीनियर की हमें ब्लेसिंग चाहिए. वेल पीजीज कितने लोग ए पे जा रहे हैं? ऐसे हाथ खड़ा करो यार. बी वाले, सी वाले, डी वाले, ई वाले. वेल राइट आंसर इज सी. डिक्रीज इन एसआई ड्यू टू क्लोराइड इन्फ्यूजन. है नहीं, टीम बने नहीं गई ना सर. नहीं सर, एक मिनट, टाइम मेरे पास खाली 25 मिनट है. ओके, वी हैव टू लर्न, नॉट द टीम. चलिए लेट्स लर्न द बेसिक कंसेप्ट. ये क्या चीज है? स्ट्रॉन्ग आयन डिफरेंस, sum of strong cation minus sum of strong anion. This includes sodium, potassium, calcium, magnesium cation, chloride, lactate, anion. Point to be noted, इसके अंदर बाइकार्ब नहीं है. ओके, उसके बाद a decrease in SID causes metabolic acidosis, while increased SID causes metabolic alkalosis. Large volume normal saline infusion administered increases plasma chloride disproportionately. ये चीज कैसे होती है देखेंगे. नॉर्मल सीरम के अंदर सोडियम 140, क्लोराइड का 100 एवरेज. व्हेन वी गिव सलाइन 154 सोडियम 154 क्लोराइड, तो क्लोराइड का लेवल बहुत ज्यादा बढ़ता है. जाहिर है क्लोराइड बढ़ेगा तो बाइकार्ब कम होगा. बाइकार्ब लीड मेटाबॉलिक एसिडोसिस. गॉट इट? तो ये चीज पहला कैरी होम मैसेज फॉर पोस्ट ग्रेजुएट. व्हेन वी इन्फ्यूज लार्ज वॉल्यूम saline, it can induce metabolic acidosis. अभी एक हैरिसन में नया चेंज आया है. इवन फॉर डीके द फर्स्ट लाइन ऑफ ट्रीटमेंट शुड बी रिंगर लैक्टेट, नॉट saline. चलिए क्वेश्चन 2 अगेन फॉर पोस्ट ग्रेजुएट्स. In a patient with high anion gap metabolic acidosis, which of the following condition is most likely associated with markedly elevated osmolar gap? ये ionizity का क्वेश्चन है. पांचवा ऑप्शन जान के डाला गया टू मेक इट मोर टफ. हाँ जी, कितने लोग ए वाले हैं, बी वाले, सी वाले, डी वाले, ई वाले? सो अगेन आंसर मिथेनॉल पॉइजनिंग है. शॉर्ट डिस्कशन. Osmolar gap is measured osmolality minus calculated osmolality. Normal is less than 10. Elevated osmolar gap suggests presence of unmeasured osmol like toxic alcohol, methanol. Methanol and ethylene glycol are the classical cause of high osmolar gap. In our country, the commonest cause happen to be methanol, so-called kachi sharab. Well, you can see my lecture on acid based. मेरे उसमें डला हुआ है पूरा डिटेल. You can see there. Okay, मेरे जो एक ऐप है उसमें देख लेंगे. Question 3.
1 minute. What is the difference between measured and calculated?
Say it again.
They said measured and calculated.
दोनों अलग अलग हैं. Okay, बात वही है, टाइम नहीं है सर, इसलिए मैंने कहा कि डिटेल you can see, क्योंकि अगर मैं पढ़ाऊंगा तो आधा घंटा इसमें निकल जाएगा. Well, एक और again for postgraduate. Delta gap of -4 is most likely seen in which of the following conditions? Option आपके सामने है. It's a beautiful question. या कितने लोग ए वाले हैं, बी वाले, सी वाले, डी वाले, ई वाले? चलिए, राइट आंसर इज सी, डी के विद RTA. Let's learn the basic concept. When HAGMA, high anion gap metabolic acidosis, together with NAGMA, normal anion gap, the delta gap is reduced. Let's learn the basic, how we calculate delta gap. Delta gap is delta Ag minus delta bicarb. That means delta gap Ag minus 12 minus 24 minus bicarb. So now interpretation. If delta gap is minus 2 to plus 2, pure HAGMA, plus more than plus 2, HAGMA plus metabolic alkalosis, or HAGMA with chronic respiratory acidosis, negative 2, the less than 2 is the HAGMA plus NAGMA like DK and RTA in this case. यहाँ पे high anion gap होता है और यहाँ पे normal anion gap होता है. Okay? Well, again, you can see lecture मेरा उसमें है detail. Question 4 only for PGs. Yeah. A patient of pheochromocytoma was treated with surgery to remove the tumor, which will happen to BP soon after surgery. BP will rise mildly, fall mildly, remain normal, rise very high, and fall drastically. It's a beautiful question. ये सवाल आपको आपके एग्जाम में जरूर आएगा. यस, पोस्ट ग्रेजुएट कितने लोग ए वाले हैं, बी वाले, सी वाले, डी वाले, ई वाले? वेल, ये डी इज द मोस्ट कॉमन रॉन्ग आंसर. क्यों? द आंसर गिवन टू इज, जब इसको कट करेंगे तो कुछ कैटेकोलामीन जाएगा एंड दैट विल पॉसिबल हाइपरटेंशन. इट्स द मोस्ट कॉमन रॉन्ग आंसर. इसमें कभी ब्लड, बिकॉज इट इज ए हाईली वास्कुलर ट्यूमर, तो सर्जन को लाइगेट करे पूरा तरी कट करेगा. आंसर इज ई, बीपी विल फॉल ड्रास्टिकली. This you will never understand unless you know the basic physiology. Let's learn the basic physiology of BP. BP depends on 3 parameters: cardiac output, peripheral resistance, blood volume. जब भी बॉडी में बीपी बढ़ेगा, body always try to control BP, but body doesn't have an effective method to control cardiac output, not an effective method to control peripheral resistance, but body can control blood volume. That's why यहाँ पे BP high रहता है because of catecholamine, but volume is reduced. They are वॉल्यूम, इंट्रावेस्कुलर वॉल्यूम कम होता है. इसका क्लिनिकल अप्लाइड किया है. इन फीवर देयर इज हाइपरटेंशन, बट देयर इज आल्सो एसोसिएटेड पोस्टल हाइपोटेंशन. एक गुरु मंत्र याद रखो, एनी कंडीशन विच विल लीड टू रिड्यूस इंट्रावेस्कुलर वॉल्यूम विल लीड टू पोस्टल हाइपोटेंशन. ठीक है. वेल, तो इसमें द मोमेंट यू रिमूव कैटेकोलामीन सोर्स, बॉडी इज डिहाइड्रेटेड, द बीपी विल फॉल ड्रास्टिकली. थोड़ी सी और फिजियोलॉजी. BP is cardiac output, peripheral resistance. Cardiac output, heart rate, stroke volume. BP, heart rate, stroke volume, peripheral resistance. ये गुरु मंत्र याद कर लो. 3 ही पैरामीटर है बीपी कंट्रोल करने के. अगर आपको ये बेसिक कंसेप्ट आते हैं, यू कैन हैंडल एनी क्वेश्चन. सो हार्ट रेट को रिड्यूस के लिए ये दवाइयाँ हैं, मैं नहीं पढ़ूंगा, टाइम की कमी है. ड्रग विद रिड्यूस स्ट्रोक वॉल्यूम एंड ड्रग विद रिड्यूस पेरिफेरल रेजिस्टेंस. अगेन शॉर्टेज ऑफ टाइम, बट यू कैन सी माई फुल लेक्चर ऑफ हाइपरटेंशन मेरी ऐप में है, वो देख लेंगे. Question 5 only for postgraduate. Most specific eye sign seen in Graves' disease. कौन सा है? White staining appearance, upper lip retraction, lid lag, decreased blinking, and corneal ulcer. Postgraduates only. जिसको इसका जवाब आता है पोस्ट ग्रेजुएट, आपको थायराइड आता है, नहीं आता तो गो एंड रीड थायराइड. कितने लोग ए वाले हैं, बी वाले पोस्ट ग्रेजुएट, सी, डी, ई? आंसर ई है इसका. ई सर क्या पढ़ा रहे हो, बचपन से पढ़ते आ रहे हैं. लिड लैग, लिड रिट्रैक्शन, लोल. लेट्स लर्न. तो लेट्स टॉक अबाउट बेसिक कंसेप्ट. थायरोटॉक्सिकोसिस, जो हाइपरथायराइड भी कहते हैं, ग्रेव डिजीज भी कहते हैं. ठीक है. यस इज द मोस्ट कॉमन रॉन्ग आंसर. ये सब अलग अलग है, सब अलग अलग है. फिर भी क्विकली, 2 तरीके के आई साइन होते हैं थायरोटॉक्सिकोसिस में. ये होते हैं आई साइन सीन इन ऑल केस ऑफ थायरोटॉक्सिकोसिस. ये नाम है, नहीं पढ़ूंगा, टाइम नहीं है. लेकिन कुछ ऑटोइम्यून आई साइंस होते हैं, which are seen only in grave disease. Grave disease is a type of thyrotoxicosis, but all thyrotoxicosis are not grave disease. ये बेसिक फंडामेंटल है. ओके, सो ये जो साइंस हैं लिखे पड़े हैं, दे आर सीन इन ग्रेव डिजीज. ये रहा पप्टोसिस, कीमोसिस, ये सारे आई साइंस हैं जो ग्रेव डिजीज में होते हैं. अगेन यू कैन सी, पूरे थायराइड के 5 घंटे का लेक्चर है मेरा. यू कैन सी, कोई दिक्कत हो यू कैन टेक द नंबर, आई विल गिव यू कैन सी फ्री ऑफ कॉस्ट. क्वेश्चन 6 ओनली फॉर पोस्ट ग्रेजुएट्स, ये वाला लवली क्वेश्चन. ये सवाल आपसे वाइवा में पूछेंगे. आपकी बहुत सारे एग्जामिनर यही बैठे हुए हैं, दे आर गोइंग टू आस्क यू क्वेश्चन दिस थिंग. ब्यूटीफुल क्वेश्चन. 2 लोग दारू पीते हैं, एक का लिवर खराब होता है, दूसरे का नहीं होता, उसका रीजन क्या है? हाँ जी, कितने लोग ए वाले पोस्ट ग्रेजुएट, कितने लोग ए वाले हैं, बी वाले, सी वाले, डी वाले, ई वाले? आंसर है इसका बी, PNPLA. It is the most important genetic variant associated with susceptibility to alcohol-related liver disease and fatty liver. इसमें I148M polymorphism in this gene impairs normal lipid metabolism within hepatocyte, and that's why triglyceride इकट्ठा होता है liver के अंदर. Okay, so 2 individuals consume similar alcohol, but a marked difference outcome because of genetic susceptibility. क्वेश्चन 7 ओनली फॉर PGs. ये नई दवाई आई है, प्रोस्पेक्टिव न्यू क्वेश्चन है. ये नाम हैरिसन में भी नहीं है, 22nd एडिशन में हैरिसन में नहीं है. ये सवाल आपके एग्जाम में जरूर आएगा, नीट PG और नीट SS में. मैं आपका पेपर लीक कर रहा हूँ लेकिन ईमानदारी से. ओके, ये क्या है, कौन सी जुर्म है? या पोस्ट ग्रेजुएट कितने लोग ए वाले हैं, बी वाले, सी वाले, डी वाले, ई वाले? Well, answer is hemophilia. Again, quick brief. ये एक monoclonal antibody है, recombinant activated factor 7 है ये. It used in the hemophilia. It used mainly when inhibitor of factor 8 or factor 9 are present. It direct activation of factor 10 that is to thrombin generation. तो ये factor 8 को bypass कर जाते हैं. Question 8 only for का, हाँ जी ये वाला. एवरीबॉडी शो प्रोस्पेक्टिव न्यू क्वेश्चन. ये सवाल भी आपको जरूर आएगा, थ्योरी वाइवा प्रैक्टिकल में आपके MD DNB में पूछेंगे. नया वैक्सीन है. यस, पोस्ट ग्रेजुएट कितने लोग ए वाले हैं? सभी लोग हाथ खड़ा करेंगे. पोस्ट ग्रेजुएट आंसर सही है, अच्छी बात है. गलत है तो और भी अच्छी बात है. गलती एक बार होती है, दोबारा नहीं होती. गलती यही कर लो. A, B, C, D, E. ये सवाल मैंने कम से कम अब तक 1000 PG से पूछा है, yet to get answer. Everybody goes for malaria, लेकिन आंसर TB है. हर जगह पूरे ICP के पूरे कंट्री में मेडिसिन क्विज मैं ही कर रहा हूं. ओके, और एवरीबॉडी गो फॉर मलेरिया. चलिए ब्रीफली न्यू वैक्सीन ये वाला है. यूज फॉर एडल्ट विद लेटेंट TB इन्फेक्शन टू प्रिवेंट प्रोग्रेशन टू एक्टिव डिजीज. टाइम शॉर्टेज. क्वेश्चन 9 पोस्ट ग्रेजुएट. ब्यूटीफुल क्वेश्चन. इसके लिए आई विल गिव यू लिटिल मोर टाइम. Yeah. Real good question. If you know the answer of this with reasoning, you know acid-base disturbance. Yes, postgraduates. क्या आंसर है? Quickly. कितने लोग ए वाले हैं पोस्ट ग्रेजुएट्स? बी वाले, सी वाले, डी वाले, ई वाले? वेल द राइट आंसर इज नन ऑफ द अबव. मैंने क्या कहा था जिसको उसका जवाब एनीवे. नोबडी, डोंट वरी, लेट्स हैव अ क्विक डिसीजन. यहाँ पे सारी रिपोर्ट नॉर्मल है, सोडियम क्लोराइड बाइकार पीएच सब आर नॉर्मल एक्सेप्ट एनाइन गैप विच इज इंक्रीज. हाउ वी कैलकुलेट एनाइन गैप? सोडियम माइनस क्लोराइड प्लस बाइकार. अभी थोड़ी देर पहले मैंने बात की थी, व्हेन वी इन्फ्यूज नॉर्मल सलाइन बहुत ज्यादा, तो क्लोराइड का लेवल बढ़ा था, तो ये कम हो जाएगा. एंड दैट्स व्हाई मैसिव इन्फ्यूजन ऑफ नॉर्मल सलाइन विल इंड्यूस मेटाबॉलिक एसिडोसिस. ये उसका बेसिक आंसर है. अब यहाँ पर जो हमारे सवाल में इफ यू कैलकुलेट एनाइन गैप 140 95 25, ये क्लोराइड है, बाइकार 20, एनाइन गैप इज इंक्रीज. नॉर्मल एनाइन गैप की वैल्यू में भी पंगा है. कहीं किसी किताब में 8 से 12 लिखा है, किसी किताब में 12 प्लस माने 4 भी लिखा है, तो थोड़ा वेरिएशन है. ओके, हाउएवर यहाँ पर डेफिनेटली मोर देन दैट. तो यहाँ पे ऑल रिपोर्ट इन नॉर्मल एनाइन गैप इंक्रीज. दिस इज द मेटाबॉलिक एसिडोसिस एंड मेटाबॉलिक एल्कोसिस एट द सेम टाइम. एक पेशेंट में एक ही टाइम में मेटाबॉलिक एसिडोसिस भी है, मेटाबॉलिक एल्कोसिस भी है, जिससे पीएच नॉर्मल हो जाता है. एंड दैट्स द वन. Okay, so up audience question is only for postgraduate. Anybody can answer, not for senior faculty. कोई भी सवाल सीनियर फैकल्टी के नहीं है, हमें आपका आशीर्वाद चाहिए. ओके, चलिए, टेल मी एनी कंडीशन वेयर वी कैन से दिस. किसी एक ही पेशेंट में मेटाबॉलिक एसिडोसिस भी है और मेटाबॉलिक एल्कोसिस भी है. क्विकली आंसर है CRF, वॉमिटिंग, डायरिया. वॉमिटिंग, डायरिया में मेटाबॉलिक एसिडोसिस, और वॉमिटिंग में तो एल्कोसिस होता ही होता है. ठीक है. और एक चीज और जिसके बारे में 90% को कंफ्यूजन है, हम ये कहते हैं कि वॉमिटिंग के अंदर HCl लॉस होता है, दैट इज टू एल्कोसिस. ये ठीक है, बट इससे भी बड़ा कंट्रीब्यूशन किडनी का भी होता है, विच इंड्यूस. सो वॉमिटिंग इंड्यूस एल्कोसिस में किडनी का रोल भी है. अगेन बिग लेक्चर यू कैन सी इन माई लेक्चर. वेल, अगेन यू कैन सी द फुल लेक्चर का इन पूरा डिटेल दिया हुआ उसके बारे में. क्वेश्चन 10 ओनली फॉर पोस्ट ग्रेजुएट. इन ए पेशेंट विद नॉर्मल एनाइन गैप मेटाबॉलिक एसिडोसिस, ए नेगेटिव यूरिन एनाइन गैप सजेस्ट व्हिच ऑफ द फॉलोइंग? Who says A, B, C, D, E? आंसर डायरिया इंड्यूस्ड बाइकार्बोनेट लॉस. अभी मैंने बात की थी डायरिया के अंदर लॉस ऑफ बाइकार्बोनेट लीड टू मेटाबॉलिक एसिडोसिस होता है. वेल, शॉर्ट डिस्कशन ओनली. यूरिन एनाइन गैप इज यूरिन सोडियम प्लस पोटेशियम क्लोराइड. पॉइंट टू बी नोटेड, जब हम सीरम एनाइन गैप करते हैं तो सोडियम क्लोराइड बाइकार, यहाँ पे बाइकार नहीं है, यहाँ पे पोटेशियम है. It indirectly reflects urinary ammonium excretion. Negative UAG, high ammonium, and that intact renal acidification. Ammonium occurs at the level of PCT. Seen in extrarenal causes like diarrhea. Positive UAG, impaired ammonium excretion, and renal cause like renal tubular acidosis. Normally we have RTA 1, 2 and 4. किस में हाइपरकैलेमिया होता है?
4 में.
टाइप 4 में हाइपरकैलेमिया होता है. और स्टोन किस में बनते हैं? टाइप 1 के अंदर बनते हैं. और फेनकोनिक सिंड्रोम किस में होता है? टाइप 2 के अंदर होता है. ओके, अगेन पूरा लेक्चर है. अगेन फॉर क्वेश्चन फॉर PGs. Edema feet is a feature of primary hyperaldosteronism. It's not a feature, but feature of secondary hyper. Tell me any cause of secondary hyperaldosteronism without edema feet. Secondary without edema feet. This is a gold medal question है. जब वाइवा में दोगे दो आप, तो examiner will give you gold medal. Yeah. Quickly. Well, the answer is gastroenteritis, Bartter and Gittman syndrome are the 3 causes where we have a secondary hyperaldosteronism without edema feet. Question 11. बहुत ही आसान सवाल है, बहुत ही आसान सवाल है. हाईएस्ट ग्लाइसेमिक इंडेक्स किसमें होता है? कितने लोग ए वाले हैं, बी वाले, सी वाले, डी वाले, ई वाले। अच्छा चलो, अगेन पोस्ट ग्रेजुएट, लोएस्ट ग्लाइसेमिक इंडेक्स किस में है? हाईएस्ट तो बता दिया आपने, लोएस्ट किसका होगा? है पीनट। सॉरी, दोनों आंसर गलत है। हाईएस्ट वाटरमेलन, लोएस्ट बटर। बटर में तो 0 है, बटर तो फैट है, तो 0 हो गया नहीं हो गया? डेफिनेटली लवली क्वेश्चन। तो दोस्तों वाटरमेलन इज द वन। इसका ग्लाइसेमिक इंडेक्स हाई है लेकिन ग्लाइसेमिक लोड कम है। ठीक है, चलिए अगेन आई विल स्किप, इतना टाइम नहीं होगा। क्वेश्चन 12, हाँ जी, पैराडॉक्सिकल ब्रेडिकार्डिया इज सीन इन विच कंडीशन? पैराडॉक्सिकल ब्रेडिकार्डिया इज सीन इन विच कंडीशन? क्विकली, अच्छा पीजी, ए, बी, सी, डी, ई। ये सवाल मैंने कम से कम 2000 लोगों से पूछा है पोस्ट ग्रेजुएट से। येट टू गेट आंसर।
ऑप्शन बी।
आंसर पल्मोनरी एम्बोलिज्म। पल्मोनरी एम्बोलिज्म सर क्या बता रहे हो? इसमें टैकीकार्डिया होता है? यस, टैकीकार्डिया इज द मोस्ट कॉमन फाइंडिंग और S1, Q3, T3 इज द कैरेक्टरिस्टिक। लेकिन कुछ पेशेंट में ब्रेडिकार्डिया होता है, दे आर कॉल्ड पैराडॉक्सिकल ब्रेडिकार्डिया। डिटेल यू कैन सी इन माय लेक्चर, इन माय ऐप। पैराडॉक्सिकल मतलब है कि अनएक्सपेक्टेड। ओके, अगेन क्वेश्चन फॉर पीजी, ये आपका रोज का सवाल है, रोज आप इमरजेंसी में काम करते हैं। कौन सा बेस्ट रिप्लेसमेंट फ्लूइड है इसके लिए? क्विकली, रोज का काम है आपका। कितने लोग ए वाले हैं? ए नहीं, कितने लोग ए? हाथ खड़ा करेंगे। ए, बी, सी, डी। वेल आंसर है नन ऑफ द अबव। ब्लड फॉर ब्लड, खून का बदला खून से। उसने बेस्ट पूछा है, उसने फर्स्ट नहीं पूछा। फर्स्ट कभी नहीं पूछेगा, यहां मार खा गए। कैन यू अफोर्ड टू लूज दिस क्वेश्चन इन द एग्जाम? सभी लोग लिखेंगे, आपके 4 होंगे प्लस उनके -5, 5 का फर्क आ गया। चलिए, एक एडवाइस ऑल पीजीज के लिए, आप सभी को MRCP करनी चाहिए, घर बैठे बैठे अभी हो जाएगी। और MRCP इज इंटरनेशनल रिकॉग्नाइज्ड डिग्री, जबकि MD-DM नहीं है। ओके, कोई गाइडेंस चाहिए मैं कर सकता हूँ। और जो मेरे ऑडियंस में दोस्त बैठे हुए हैं जिन्होंने कंसल्टेंट बनना है, मैं घर बैठे बैठे आपको MRCP करा दूंगा, ये मेरा वादा रहा। तो एनी फॉर एनीवन, ओनली रिक्वायरमेंट इज इंटर्नशिप, जो सबने कर रखी है। ये सब एडवाइस है। ओके, अच्छा नेक्स्ट क्वेश्चन, ये लेटेस्ट ड्रग है, PNQ पर्सपेक्टिव न्यू क्वेश्चन। जल्दी से, 3 मिनट रह गया मेरे पास। पोस्ट ग्रेजुएट ओनली। ए वाले कितने? अरे ऐसे हाथ खड़े करो। ए, बी, सी, डी, ई। आंसर है PD-1 रिसेप्टर। आप क्या कहते हैं? या इट्स अ मोनोक्लोनल एंटीबॉडी, इट ब्लॉक PD-1 प्रोटीन ऑन T cell. It prevents cancer cell from evading the immune system. It enables the body's immune response to attack tumor. ये checkpoint inhibitor है ये वाला। Question 14. Beautiful question. जिसको इसका जवाब आता है उसको नेफ्रॉन पता है इसके बाद। रिवर्स ऑफ गॉर्डन सिंड्रोम। कितने लोग पीजीज, कितने ए वाले हैं, बी वाले, सी वाले, डी वाले, ई वाले? वेल द राइट आंसर इज जिटलमैन सिंड्रोम। इनफैक्ट प्रॉक्सिमल पार्ट ऑफ डीसीटी में सोडियम एब्जॉर्ब होता है, वाटर एब्जॉर्ब नहीं होता। थायराइड एक्ट हियर, प्रॉक्सिमल पार्ट ऑफ डीसीटी, और दैट्स व्हाई सोडियम एब्जॉर्ब नहीं होगा तो डायरेक्टिक का काम करेगा। When we talk about Gentleman syndrome, you need to overactivation of NAS sodium chloride co-transport in proximal part of DCT, और Gentleman में डिफेक्टिव, यहाँ पे डिफेक्टिव होता है। ये दोनों रिवर्स हैं, तो दैट्स व्हाई Gentleman syndrome और गॉर्डन सिंड्रोम दोनों के अंदर सेम साइट ऑफ इंजरी बट इज ऑल रिवर्स। ओके, यू कैन सी द लेक्चर ऑन गॉर्डन सिंड्रोम, मेरे ऐप में है। स्मार्ट मेडिसिन। चलिए, अब अगला एक मेडिसिन क्विज भी है, ये अगले हफ्ते है और एबी उस्मान में, करकड़डूमा में। वो घंटे का टाइम होगा, मोर क्वेश्चन डिस्कस, लेकिन ये वाले क्वेश्चन नहीं होंगे, दूसरे होंगे. ओके, थैंक यू वेरी मच. और सर देखिए मैंने टाइम से पहले खत्म कर दिया है.
Very good.
एक मिनट. सो थैंक यू वेरी मच टू द ऑर्गेनाइजिंग टीम, थैंक यू वेरी मच फॉर ऑल द चेयरपर्सन एंड थैंक यू टू ऑल ऑफ यू. और सबसे अच्छी बात है कोई भी अपनी जगह से हिला भी नहीं. दैट इज अ ग्रेट ऑनर फॉर मी. Thank you very much. Thank you very much to all the stalwarts sitting in the audience. So we need your blessing all the time. Thank you very much, sir. Thank you very much.
So first, second, third decide कर लिया सर?
First है ही नहीं, तो टीम बनी नहीं है, क्या करें?
हाँ?
सभी को दे दो ना यार, 7 तो लोग हैं, सभी को दे दो ना कुछ कुछ ना कुछ. सभी आए हैं, टीम बनी नहीं.
चलो टीम नहीं बनी?
टीम कहाँ बनी है?
अच्छा विल डिसाइड.
हाँ,
ओके.
मेरा ये मानना है ये जितने पीजी बैठे हुए 4 और 2 6 बैठे हुए हैं, 3 को क्या 6 को कर दो यार. चलो एनीवे मेरा
चलो. Thank you, Dr. Mukesh Bhatia and our chairpersons. All are you are all requested to come for the facilitated dice. आइए डॉक्टर सुरेखा, डॉक्टर काला सर, डॉक्टर कृपाल, and I respect Dr. Ram Babu, Dr. Rakesh Sood to honor our faculty. Dr. Sood, sir. So, quiz we have also got prizes. We have certificate participation. I think 6 candidates हैं, तो I think we'll give 1, 2, 3 तो हुआ नहीं, तो at least we give 1100 to each candidates. So, जो 6 हैं उनको 1100 करके देंगे plus certificate participation. And award will be given before the lunch. So there is a one announcement. जो भी पोस्टर प्रेजेंटेशन के लिए हैं वो प्लीज टी सेंटर के पास चले जाएं, जो टी स्टॉल है उसके पास चले जाएं अपना पेन ड्राइव लेके और वहाँ पे जो भी पोस्टर प्रेजेंटेशन के लिए हैं. और आई रिक्वेस्ट डॉक्टर एस के मुंद्रा, आवर जनरल सेक्रेटरी, टू टेक ओवर द स्टेज. डॉक्टर मुंद्रा प्लीज.
Good morning, friends, my seniors and colleagues. Now we are moving to our academic sessions, and first we'll be going in cardiology. And for this, we have an eminent speaker. And the topic is worsening heart failure in OPD. Nowadays, we have realized that heart failure is coming up in a big way because of uncontrolled diabetes, hypertension, old age. So we are seeing more and more patients of heart failure, and management of heart failure, as you know, is not very rewarding. Almost 50% mortality, 1-year mortality, 5-year survival is very less. So for this, I invite Dr. Praveen Chandra, who is DM and Chairman of Interventional Cardiology and Cardiac Care at Medanta, the Medicity, Gurugram. Dr. Praveen Chandra, please. It doesn't otherwise require an introduction. Please. And the chairpersons for the session are Dr. Pankaj Goyal, Dr. Rohit Singla, Dr. Nikhil Gupta, Dr. Paras Pasi, and Dr. Mohit Saxena. Dr. Nikhil Dr. Sood, Dr. Sunil Attri, please come for chairpersons.
Okay, so first of all, good morning to all of you, and it is a pleasure to be back again with some old colleagues, which we see very rarely, but it's nice in anyhow. And it was a fantastic session. I was just attending the postgraduate quiz, which was also quite interesting. So now let me take you to some new, innovations. And heart failure, as was already introduced by our secretary, that heart failure is a common problem which is happening to many patients who have CAD, who have hypertension, who have diabetes, and many times it is very difficult to control them in the OPD basis also. Sometimes they are unwell and then they come back to you again and again. So what are the options? So today, what I'm going to do is just discuss it with you, what is the medical therapy of heart failure in patients who are getting recurrent symptoms and how to investigate them, and what is the new drug which has come up. And this drug is known as vericiguat. So I don't know how many of you know about vericiguat. Can I just know, because it just came back from the PG class, so how many people know about the vericiguat drug? So at least 3-4 people definitely know about it, which is very good. So let me take you through this. So this is a patient history. A patient who is diagnosed with heart failure, she is put on medications, and the usual medications is diuretics, spironolactone, which we know that is a disease-modifying agent, sacubitril valsartan, which is neprilysin inhibitor, beta blocker is these. So these are 4 drugs, and then there is SGLT2 inhibitors like dapagliflozin or so these drugs are very important. These are the pillars of heart failure therapy today. But beyond that, if the patient still has heart failure or is getting increased dose of diuretics, that means there is some problem. So this is a typical patient who has, as you will see here, who has dilated cardiomyopathy and has a recurrent hospitalization and is increasing. She's breathless all the time, getting cough, chest, hemoptysis sometimes. So which means she is going into heart failure. So what is the investigation to know whether she is a respiratory disease or she has increasing heart failure? So the basic investigation in this is to do the NT-proBNP levels. So NT-proBNP levels are important, and in this patient, NT-proBNP level was done, it was 3,234, which means it is very high. This patient is suffering from recurrent heart failure. So now what to do? So as I already said that, now we have made a diagnosis that this is worsening heart failure, and we have identified, we have to risk stratify and then intensify the treatment. So these are the steps. Why it is important? Because worsening heart failure patients do not do well. One day she will not be able to come out of this heart failure, and this shows that there is an increased mortality. Every event of heart failure leads to increased mortality. So if a patient of heart failure has an NT-proBNP level of constantly about less than 500, that means it is a good patient. But if the NT-proBNP is not getting below 1000 or not getting below 2000 or 3000, that means this patient is not going to go too far. You have to do something more. So this is a very good test today, that you do a NT-proBNP level when this patient comes to on an OPD basis. This is one of the very important investigations today to know what is the status, what is the prognosis of this patient. So it is not subjective now anymore, it is objective. So we can now know that this patient is going to need more therapy. And these are the definitions. So there are definitions for worsening heart failure from ESC, which is European Society of Cardiology, and also of the Indian consensus, as you see here. So whenever you see doubling of dose or the patient is having increased NT-proBNP levels and are needing more and more dose of torsemide or diuretics, that means he's a worsening heart failure patient, and this patient has poor prognosis. So you know in your OPD, this is a patient who needs to be prognosed. Prognosis has to be told to this family. Now, I already told you these are the 4 pillars of this therapy. The neprilysin inhibitors, which is ARNI, beta blockers, SGLT2 inhibitors, then MRAs, which is aldactone or eplerenone, and then the new therapy is vericiguat, which works on the SGC pathway, which means whenever there is a heart failure, body itself produces nitric oxide. Then it releases, it increases the vasodilatation to improve heart failure. But this drug is actually given so that if the body is not able to produce nitric oxide, this will give. And that is why the benefit of this drug comes in. It leads to cyclic GMP pathways activation. So the benefits of this drug has been seen from the Victoria trial. So because every drug has to be tested. So what was the main study, which was the Victoria study, where drug was given in a dose of 2.5 milligram, and every 2 weeks it was increased. So after 2 weeks, go to 5 milligram. Then you go to 10 milligram, which is the maximum dose to be given for the benefit of this therapy. And what it led to is this. It led to decreased CV death and first hospitalization for heart failure, which means worsening heart failure gets controlled. So you can give this therapy to these patients. And this is again the charts showing that those patients, when you compare with vericiguat versus placebo, there is an increased benefit in terms of probability of primary endpoints. And here you see that the CV death benefit was seen with vericiguat compared to placebo in patients who have high NT-proBNP level. So if a patient has high NT-proBNP, he needs this therapy. And so now people will ask, how many patients need this therapy? So here you can see all patients, almost all patients who are on outpatient with previous worsening heart failure episode and NT-proBNP levels high, they need this therapy. It's a very good treatment because the side effect profile is very low, and that is why we can initiate this therapy in those patients who already are on the 4 pillars of therapy. And this is the consensus document which was generated in India only, that early upfront use of vericiguat should be done in more than 80% patients. So here is the benefit. We should start very early. So in our patient, which I showed you earlier, vericiguat was initiated and titrated. The dose was titrated, and the current medication she was getting was Arni, dapagliflozin, vericiguat, bisoprolol, and torsemide, and her improvement started happening, and that is how we measure the improvement, by the NT-proBNP levels and her symptoms. So everything improved. So this is the clinical scenarios for implementation of vericiguat. Once the worsening heart failure happens, you can start as soon as possible or as soon as you have decreased the dose of IV diuretics. Once the patient is decongested, you can start it as soon as possible. And here there are certain articles which have already been published, so many of them. And this is the real world therapeutic intensification, that you can increase the dose very quickly in these patients and get the benefit. And this is the guideline. So now the last step towards any drug is whether it is in the guideline or not. So now it is in the guideline. It's a class 1B indication for pre-discharge and early post-discharge follow-up of patients of heart failure, acute heart failure. So there you can start them. And this is the study which was done and showed that quintuple therapy. So now, earlier it was quadruple therapy, now it is quintuple therapy with vericiguat to be given. And this is the Indian study, Varina, which was done in India, and again showed, this was done in 13 study sites, 200 participants, showed the similar outcomes in our Indian patients also. So it has been studied in Indian patients also, and the results were equally effective and equally good. And most of these patients also were taking the other 4 drugs which I already discussed. So the effectiveness was consistent, as was seen in the Victoria study, which was the initial study to establish the role. So with this, I will come to the key takeaways of my presentation, that intensify diuretics when there is heart failure, but add vericiguat as soon as the patient is stabilized. You can start it in hospital or out hospital also. And if the patient is in OPD, having high NT-proBNP levels, start this therapy as soon as possible and titrate it at 2 weeks intervals. So with this, I will stop here. Thank you very much.
Cost of the medicine.
Okay, the cost, I think the cost of this therapy is now, because there are many companies which are making it, so it must be ranging somewhere between 30 to 50 rupees, because most of the drugs the new drugs come in this range. Earlier, I think it was about 100 rupees, but now it has come down. Many companies are making it, yeah.
Dr. Praveen Chandra. Dr. Praveen, you are always at the best with your deliberations. I must appreciate your agility in the subject. Thank you very much.
Thank you.
And you have given a very good message that if we are not on those drugs, suppose SGLT2, bisoprolol, or any MRMA, and still we want to go for straight away to vericiguat. What is your take?
Yeah. So as I said, that it is a good drug, but certainly it does not need to surpass, you cannot replace the other drugs. But definitely there are indications where you will give vericiguat and we are not able to give other drugs. Like, for example, if a patient who has GFR is very low, okay? In those patients, you are not able to give Arni. or a patient of renal failure where you are not able to start upfront ARNI, then you can start this therapy because it can be given up to GFR of 15. So that means it is one of the first drugs many times we do. In many patients who are admitted in heart failure, urine is not coming, the creatinine is high, etc. Then we start this therapy.
Is it must to have an anti-pro-BNP before we start that?
I mean, not really. I mean, as a clinician, we all know that these investigations help us. But if you are clinically sure, go ahead, no problem. It's okay. Anti-proBNP is just a marker to assess, prognose these patients. Yeah.
At times we find the blood pressure is hovering around 90 systolic. So does it have any effect on blood pressure?
Yeah, it does have some effect on blood pressure, but not that profound. And that is why we have to titrate this slowly. So when you titrate this slowly, the effect is very minimal. Yeah. If you give 10 milligrams straight away, it will come down. Yeah.
Dr. Parveen, congratulations. One question. Can we call it one time, this could be the fifth pillar of a heart failure?
Can you put the mic a little closer?
Can we call it one time that could be a fifth pillar of a heart failure management in due course of time?
No, I didn't get your question. What is that?
Next pillar.
Oh, yeah. So we can, to a certain extent, say that it can be one of the fifth pillars, but there are now many drugs which are add-on, like I will say ivabradine is another one. Then giving iron, intravenous iron therapy is another one. But definitely vericiguat is slightly above that. So that is why we are saying this is the fifth drug. So, fifth drug in addition to the fourth. So we are not replacing any, but if you are not able to give any other drug, like for example, patient has recurrent UTI, okay, in a heart failure patients, and you are not able to give dapagliflozin, okay, then in this patient, I think this is a very good add-on. Then in those patients who you cannot give ARNI as a starting point, then again, this is a very good drug. So it is very good neutral drug. The side effect profile is very low. So that is why I think it's okay. The only problem was it was also expensive to start with, but I think now the cost has come down. I do not know the minimum cost of this, but yeah, okay.
Thank you, Dr.
Thank you.
Have a nice to listen to you always.
Thank you very much.
Thank you. So we have to wait for the declaration for the fifth pillar. Now I request all the chairperson and the speaker for the felicitation and over to organizer for the proceeding.
Yeah, I will request the chairpersons and our speaker, please, for the moment of presentation. So, moving forward, our next topic is again related to cardiac diseases, and this is on echocardiography. How echocardiography is helpful for physicians in day-to-day clinical practice. And for this, we have an eminent speaker, Dr. Rakesh Gupta, who is a clinical and non-invasive cardiologist. And all over India, he is well known for his echocardiographic classes. He is a great academician, and he is running his Drop Healthcare Private Limited in Ashok Vihar. And for this session, I'll invite the chairpersons, Dr. B.B. Rewari, Dr. Rajnish Sharma, Dr. Nityanand Tripathi, Dr. Vikas Maurya, and Dr. Rashi Khare. Please come on the dais. Dr. Sandeep Miglani, Dr. Anil Gombar, Dr. J.K. Sharma, Dr. Rakesh Gupta, sir.
लगा लो बेटा It's it. गोमर जी परमिशन हैगी?
Dr. Rakesh is always at his best in the morning. Good morning to everybody.
Night also, man.
And I know your topic is one of the very interesting topic today. So we would like to be enlightened by you. Thank you very much.
Thank you, chairpersons. Let's get going. Dr. Parveen was talking about absolutely something where some heart failure has already happened. Let me in 12 minutes tell you about a normal person who's carrying a heart failure along with him with the aid of echocardiography and NT-proBNP. That's what our take-home message would be. I belong to this particular place where I work dedicatedly. This is a teaching institute. We are not only doing echocardiography, but we are teaching echocardiography for the physicians at large, cardiologists to an extent, and that's what R is. If you look at our views on the Google YouTube is, more than 9 lakh views are there, 14,000 subscribers, and 263 videos are there. And that's what we talk about echocardiography. 25 years down the line, when I started doing echo, everybody said, what is echo? Is it what? Just ejection fraction. In next 12 minutes, I'll show you it's not ejection fraction which makes a difference. Something more than that which makes a difference. And I have given this topic something, a dil mange more, the giraffe way. That's what my talk is. Let's start with this first patient. Hypertensive, irregular medicines, BP appears to be uncontrolled, presented for routine echo evaluation. Well, if you look at his BP is high, nothing like features of heart failure, but if his cholesterol was definitely on the higher side, his XHS was normal, and look at his ECG. And all of you agree, the patient has got, some people will say infralateral wall ischemia, some people will say it's a LVH which is happening. And when we look at this presentation in this particular part, we can appreciate that there's a significant left ventricular hypertrophy in this patient. I know like this is going a little bit beyond for our physicians, but definitely a left ventricular hypertrophy. And look at the LA size, which is more than 22 millimeter per meter body surface area. So two important factors, LVH as well as dilated LA size. And this is what 2016 guidelines of JAS, American Society of Echocardiography is. We have to classify these people as concentric LVH, eccentric hypertrophy, concentric remodeling, or normal. And this patient belongs to concentric hypertrophy, JAS 2016 guideline. Look at the function of heart, absolutely normal. And that's what we always ask is, what is my ejection fraction, man? And we always say my ejection fraction is 66%. Nobody emphasizes on diastology. What is diastology is how my LV is filling from LA. If my LA pressures are high, LV will take longer time to fill, it will be stiff, and it will reflect to back pressure changes. And that's what we evaluate by looking at these various parameters. And the diagnosis comes out to be, this patient has got a dilated LA, concentric left ventricular hypertrophy, normal LV systolic function, grade 2 diastolic dysfunction, mild MR, normal pulmonary artery pressure. And that's what exactly we get a report everywhere. Look, this is what my diagnosis is. Do this diagnosis give you an adequate treatment management issues? Does it guide you? Where are you standing? Is it going to have some prognostic value? That's not. So let's look at what is important in this subsequent echo is. This is the one modality which is known as global longitudinal strain. And the most important part of this global longitudinal strain is it tells you about, despite normal ejection fraction, you have got a reduced LV systolic function. And look at this slide. This is a GLS module talking of a bullseye pattern comparable to MRI, and it's taking you that various contraction modules are present. This part is normal. This is negative, which is part is going out, and this part, which is pink in color, is contracting less. The person whose ejection fraction is almost 66%. But it is not true that his ejection fraction is normal. It means this heart has already started failing. And that's what depicted by this particular phenomena. And 2009 to 2016 guidelines, we look at it. We went on to look at diastolic function, that is filling pressures. If this filling pressures, which were abnormal, has become normal now, and look at this diagnosis is modified with use of further modalities. Dilated LA, concentric LVH, and reduced LV systolic function. Normal LV systolic function is gone. And then the most important thing is his filling pressures are normal. Mild MR, pulmonary artery hypertension. This is JAC 2021 guidelines. What does this tell you? Look, if I have got a hypertension, if I've got a structural heart disease, if I've got an abnormal cardiac function, and Dr. Praveen Chandra was talking about anti-proBNP levels. If out of these three, if two are positive in my patient, I've got a structural heart disease, my LV hypertrophy is present, my cardiac function is reduced already. It means I belong to stage B heart failure. And what exactly this stage B heart failure? Despite the fact that I'm normal, despite the fact I'm hypertensive, but I'm already gone to stage B heart failure. Stage B heart failure is when I'm in heart failure, but I'm asymptomatic. And not only that, look at this pattern of, this is what we saw in this pattern of echocardiography. This is a hypertensive heart disease with variability. This is hypertensive heart disease. And this pattern tells you something more. And this pattern tells you that possibly we are dealing with a case of amyloidosis. So what exactly echo has changed? Echo has changed virtually the complete diagnostic parameters. It's now starting telling you my patient is in concentric LVH with amyloidosis. LV function has started reducing. It is a grade 1 diastolic dysfunction, means normal LV filling pressure, and my stage B heart failure. Yes, I'm in stage B heart failure. Now, management changes completely. What is that? We not only control blood pressure for this patient, we have to look for amyloidosis investigations and treat them as aggressively as possible. Otherwise, this patient is certainly going to stage C heart failure. And that's what we were talking about. Heart failure with preserved ejection fraction, heart failure with reduced ejection fraction over a period of time. And then we start talking of 4 pillars of medicines of heart failures. Why these people have gone? Because this is one patient which did not have a control of a blood pressure. Not only that, if this patient has got a hypertrophy, this hypertrophy tells you the higher the hypertrophy amount is, more is a cumulative mortality. So we have to control blood pressure and look at his hypertrophy, whether it is regressing over a period of time or not. And that's what can be done by this particular slide, which I showed you a few minutes back. Looking at the JACE 2016 guidelines, look how we can see assessment of the follow-up of a hypertrophy. Now, many people say, look, echo is just a modality for talking of a diagnosis. Do I still say that echo is just a modality of talking a diagnosis? No, it tells you a cause. It tells you a treatment options. It tells you a prognostication of a patient. And that's what it makes a difference. And look, this is stage B heart failure, which was published recently, only about 2 weeks down the line. And what does it talks about? It talks about, look, structural abnormality, abnormal cardiac function, elevated proBNP levels. So good echo with elevated proBNP level will really tell you, look, this patient has really gone to stage B heart failure. And this is just published about in June 18 or June 26 in the latest literatures. Not going to talk of something this, we did the same thing in our center. We looked at 600 cases visiting our center. We looked at incidence of stage B heart failure. Can you believe it? 52% of these patients having LA volume index, E to E prime ratio, LV GLS, and when we classify them, these were the people who had almost 52% incidence in stage B heart failure. And why is it important for our country? We have a hypertensive, we are diabetic, we have metabolic syndromes, we have atherosclerotic cardiovascular disease, we have a genetic variations, we have a family history of a cardiomyopathy, and those who are exposed to cardiotoxic agent. Tell me, is it important for our country or not? It's virtually everything is in our country if you look at from top to bottom. And population, 150 crores of a population in our country. Let's move further. This is a patient who's hypertensive again, regular medicines, there is systolic and diastolic murmur, heard about it. Nothing significant, occasional crepes are present in the chest, borderline raised urea creatinine levels, and this is one single finding which makes a tons of a difference. Aortic knuckle. Do we promote aortic knuckle? Do we look for anything else? We do not just walk in. And X-ray chest, normal, and same patient when we looked at ejection fraction, this looks to be fairly fine. But the crux of this patient was, when we looked for echocardiography, there's a calcification across all valves. Look at the calcification in mitral valve. Look at the calcification of the aortic valve. And these calcifications, when we looked at, apart from a calcification, we looked at diastology. Diastology again said the normal diastolic function is present. But why systolic and diastolic murmur? Because the patient, the flow velocity across mitral and aortic valve was significantly increased. And again, can we manage this patient with this particular phenomena? And we routinely pass off these patients as normal subjects of echocardiography. It's not only that. The important thing is, when we went on to look the literature, the importance of atherosclerotic calcification. Importance is, if you have a calcification across valves, you have very high incidence of a coronary artery disease. What is calcification? Calcification is fibrosis. Fibrosis leading to calcification. And this is one paper which classically says that 0 is a score with no calcification. More than 0 is calcification. And look at the cumulative mortality of these subjects if you have a calcification on your valves. Aortic knuckle, we don't talk about it. We say normal phenomena, we are aging. Aortic thickening of a walls of a calcification, we say it's normal phenomena. No, it's not that. And the second part, it says 50% of these people, if you have a calcification of valve, their coronary artery disease is already established. And that's what makes a difference in people looking at echo and interpreting these echo over a period of time. Last quickly case, diabetic, very common phenomena. BP is borderline high. The patient is in congestive heart failure. Nothing significant in investigations. The most important thing is, well, look at this LV function, which is fairly normal. The important point is about diastology. What is diastole? With rate with which the LV fills from LA. If my LA pressures are high, it will reflect to RVRA, it will reflect to heart failures. And this patient who was a diabetic, his grade 1 diastolic dysfunction with raised LA volume index, we call this people, look, there's a grade 2 diastolic dysfunction. If we move further, we went on to do a LA stain for this patient, which was reasonably lower side. And GLS for RV and GLS for LV was normal. And most important thing was LA volume index. Normal LA volume index in a diabetic person should be less than 34 cc per meter body surface area. My patient had an LA volume index of almost 37 mil per meter body surface area. Look at this paper published in JACC 2013. It says, to determine the prognostic importance of LA dilatation in patient with type 2 diabetes with no history of a cardiovascular disease. Majority of these people, they do not have a history of a cardiovascular disease. And we understand diabetes is a surrogate marker for a cardiovascular disease. And 13 years down the line, it says that it is an independent prognostic parameter for cardiovascular mortality and morbidity. A normal looking echo, just a raised LA volume index suggestive of filling pressures, is an indicator for higher cumulative mortality and morbidity. And look at this paper published in JACC 2021. If you put this paper together, enlarged LA, impaired myocardial relaxations, elevated filling pressure, impaired GLS. We had elevated filling pressure, we have an enlarged LA, and these two modalities, they are surrogate markers for diabetic cardiomyopathy. So if you do an echo, if you interpret an echo, that really tells you, look, this is how we are going to manage this patient over a period of time. Most important thing is, we always talk of a GLP-1 agonist because we are dictated by industry. I'm sorry for my words. Look at this paper. It says if you use metformin, you will reduce their LV filling pressures. Your diastology will improve and the patient will feel better. And that's what I mean to say is, this patient is again, who is a diabetic, looks innocuous, is in stage B heart failure already. Management issue, I'm not going to talk about all this. Lot has been dealt, and all of you are much better intelligent than me, and only can say that these are the people who classify them in heart failure with preserved ejection fraction as on today. Important prognostic parameter is LA volume index, which helps you in making a diagnosis, and that's what I would like to pay thanks for your patience hearing.
Thank you, Dr. Rakesh. Very well highlighted his points, and he has really enlightened us for pre-heart failure problems. Now, in all diabetics, I must say that with this message, all diabetics should have an echo. Should have an echo, because pre-heart failure is another risk factor. This all amyloidosis, and he is saying about diastolic function. And diastolic functions are very important now. And I think we should realize that in all diabetic people, we do have 1 degree to 2nd degree diastolic dysfunctions.
We have a grade 3 type of a diastolic dysfunction. Grade 1 is normal, which is virtually seen in every subject of us. If 60 people are sitting over here, believe my words, 55 people will have a grade 1 diastolic dysfunction. It's nothing. It's a normal phenomena. When the diastolic dysfunction is associated with heart failure, it becomes diastolic heart failures. And in echo, we don't look at an ejection fraction today. We look at how my ejection fraction is, any subclinical LV dysfunction is present or not, like by GLS. We look for LA volume index. We look for LA stain. This is what is another modality apart from GLS, and just a global longitudinal stain and LA stain. We assess whether this patient is already having a diastolic heart failure. And it's a very simple thing. If my LA pressures are high, I have to increase my diuretics, I have to increase my ACE inhibitor, I have to increase my ARBs. I have to reduce my beta blockers. Very simple answer. If somebody walks in emergency with a tachycardia with high blood pressure, in a heart failure, acute left ventricular failure, what do? We give Lasix. The tachycardia starts settling down. The BP starts settling down. And then we add ACE inhibitor to reduce his blood pressure further. So that's what is like looking at echocardiography with the detailed one, look at a GLS, look at an LA stain, will help you making a diagnosis, prognosis, and treatment. That's what the take-home message is.
Thank you, Dr. Rakesh. Wonderful presentation. Last question. So the aortic knuckle calcification, should we take it as a surrogate marker of coronary calcification and coronary artery disease, number 1? And number 2, any patient, even if the patient is not diabetic, and if there is preserved ejection fraction, like heart failure with preserved ejection fraction, should we treat that patient?
First is aortic knuckle, aortic valve calcification. Take my words, make a registry, investigate them further. 50% of these people have a positive stress echocardiography test. Heart failure with preserved ejection fraction, we can talk on that later on. It is more common than heart failure with reduced ejection fraction. You have a treatment for heart failure with reduced ejection fraction. You don't have any treatment for heart failure with preserved ejection fraction. 4 drugs, out of them, grade 1 or like class 1 indication drug is diuretics as on today. The 4 other drugs which make a difference is sacubitril/valsartan, dapagliflozin, finerenone, which has come up very well over a period of time. So these 3 drugs helps you in making a treatment, but they still classify in 2A or 2B. And it is more dangerous than reduced ejection fractions.
Sir, in diastolic dysfunction, especially because of hypertension, the drug of choice may be a ARB or ACE inhibitor, but sometimes the practical problem is that it's a beta blocker just because of tachycardia or because of anxiety, the high blood pressure. And you have to put beta blocker, and sometimes you ignore ACE or ARB inhibitor. And how much it is reversible with echo? How frequently you see?
I'm giving you an exact answer. If I'm a hypertensive, suppose my BP is 210 by 110 millimeters of mercury. If I do an echo for that patient, first of all, look at an IVC. If IVC is dilated, drug of choice is diuretics. Then I look at my LA pressures. I use ACE inhibitor versus ARB. I always prefer ACE inhibitors for their quick corrections. If my BP is still high, my LA pressures are becoming normal, then I use amlodipine or calcium channel blockers. If my still problem is there, then I'll start thinking of a beta blockers. Not as the first line of drug as a beta blockers.
I don't think we have time for questions from audience, but thank you, Dr. Rakesh, for a very enlightening session.
Thank you very much.
Thank you, Dr. Rakesh Gupta, for highlighting the importance of echo in day-to-day diagnosis of heart failure. And we have to prevent people in stage B going into further heart failure. And he has suggested so many newer metrics for looking in all those reports of echo we used to see only LVEF fine is fine. Now he says, no, we must look for other things. Moving forward, I will request Dr. Rakesh Gupta and our chairpersons for this presentation ceremony on the right side of the podium. Moving forward, now from cardiology to we are moving towards respiratory medicine, and we'll be having a talk on EBUS, use of endobronchial ultrasound in diagnosis and management of respiratory diseases, case-based learning. And for this, I invite our senior chest specialist, Dr. Inder Mohan Chugh, who is Vice Chairman and HOD Pulmonology Department, Yatharth Hospital, Model Town. Dr. Chugh, please. And for this session, our chairpersons are Dr. B.K. Agarwal, Dr. Rajiv Arora, Dr. Sanjeev Jain, Dr. Sunil Mangla, and Dr. Adit Chawla. All are requested to be present at the stage, please. Dr. Inder Mohan Chugh.
ब्राइटनेस फुल कर दियो फुल कर दे ब्राइटनेस
Hello. Dr. Chugh, please. He's going to present few cases on IBUS with demonstration.
ये तो नॉर्मली चल जाता है ये क्या कर रहे हो खाली टाप लगाने से चल जाता है
सर लगी हुई है ये रही सी टाइप
सुनो ये लगा लो
इसमें
ये लगा तो मेरे पास भी पता नहीं इनका क्या इशू है वो तो सिंपल तार लगानी होती है इसमें आईफोन है ना एप्पल है अरे इसमें लगा ले ये लगा ले भाई सिंपल एचडीएमआई केबल ये निकाल दे ये मैं लाया हूँ साथ
यहाँ क्यों नहीं रहा?
आएगा सर अभी। So, वहाँ पे सर एक्चुअली
नेक्स्ट स्पीकर बोलो।
यहाँ से सर
ये चल क्यों नहीं रहा?
मैक्स और सपोर्ट
हाँ?
मैक्स सपोर्ट नहीं है
क्यों?
मैक की जो सपोर्टिंग कनेक्टिविटी है ना सर वो नहीं है।
तो ये चलेगा नहीं?
आपका मैक एलईडी की स्क्रीन की साइज
तो ये तो सब जगह तो चलता है।
कभी कभी होता है सर कुछ एलईडी की स्क्रीन की रेजोल्यूशन होती है ना वहाँ पे
देखो
सर वहाँ पे नहीं आ रहा ना।
तो क्या करें फिर अब?
जो भी आप दो ना बताएगा ठीक है उसी को रख लेते उसमें।
हाँ हाँ
नहीं तो आप उसको ट्रांसफर करते हैं।
हाँ ट्रांसफर कर देते हैं।
चलो इसको ले
ले रहा हूँ ना। चल चल उधर ले ले। नेक्स्ट ले लो।
ये चेयरपर्सन रहने दो।
हाँ
उधर ले ले।
एक मिनट एक
लेकर आ रहा है। प्ले करते हैं ना।
आ गया
देख देख उसको बोलना हवाले में
डाल
आ गया
चल
ठीक है।
So, good morning, everyone, and I appreciate your patience for the technological glitches. Still, we have a long way in our country for the technology to adapt. So, I would like to thank the organizer, Dr. R.M. Chabda, Dr. Mundra sir, Dr. Anand Jha, and the chairpersons for giving me this opportunity to present my work and clinical experience and share with all of you. So thank you. So we will be talking about few cases which we are dealing in our day-to-day clinical practice. So endobronchial ultrasound, all of you are well aware, it is a tube which has a ultrasound and white light bronchoscopy in it, and it's a bronchoscopy technique that visualizes structures around the airways. With white light bronchoscopy, we can see inside the airways and the walls and the mucosa. But we know sometimes that the structures are adjoining the trachea or the main bronchi and they are not visible to the white light bronchoscope. So with that, we can see the lymph nodes and the glands around the airways. So endobronchial ultrasound is one of the latest diagnostic tools in the diagnosis of lungs and mediastinal masses. It has a Doppler, so we can differentiate between the blood vessels and the mediastinal glands. All of you are well aware that doing any procedure in the mediastinum, it is very dangerous and risky. High risk is involved. All the blood vessels and the heart is around the glands. The procedure is daycare like a bronchoscopy, and it differentiates between the glands and the vessels. Main diagnosis is TB, sarcoidosis, and malignancy. So this is the EBUS bronchoscope. All of you can see this. This is the needle, this is the ultrasound probe, and this is the whole assembly. So advantages, it is minimally invasive, can be done in daycare procedure, real-time imaging. Indications are staging of small cell lung cancer, evaluation of peripheral pulmonary nodules. Okay. Evaluation of peripheral pulmonary nodules and guidance of endobronchial therapy, sarcoid, TB, mediastinal masses, and suspected masses. So these are the nodes which are amenable to mediastenoscopy on yellow. These are the high stations to EBUS and mediastenoscopy. These hilar nodes, double digit, are amenable only to endobronchial ultrasound, and the blue one are through the EUS. So now mediastenoscopy is practically out. We have EBUS and EUS. To summarize, standard bronchoscopy and EBUS are probably the initial diagnostic test for lung staging. Nodal sonographic characteristics are important, and role of cytology is important. So first case, patient is 28-year female, very common scenario, cough, fever, physical exam normal, blood report normal. Patient was treated with routine antibiotic, cough syrup and supportive treatment. All of you and including me, we are doing the same. This is the X-ray. If patient is not relieved, and you can see the hilar fullness. So we got a CT. In the CT, you can see these big nodes, such a big 4R, paratracheal node and the hilar nodes. So what is the diagnosis? Common diagnosis, we all know TB, sarcoid lymphoma or malignancy. So this is the endobronchial ultrasound. This is the Doppler. This is the picture-in-picture view. And this is the needle which is going in and out. So we do 15 to 20 to and fro motions. From a single lymph node, we take 3 samples under vision. So this is the Doppler so that you can differentiate between the blood vessel and the node. So you can see the needle is moving in and out. This is the cytopathology, non-caseating granulomas, granulomatous lesion suggestive of sarcoid. Patient was given simple steroids for 4 to 6 weeks, improved dramatically, and this is the X-ray. Case study 2, again common situation, low-grade fever, dry cough. All of you are seeing these patients. 40 to 50% patients in general practice is of respiratory patient. Chest X-ray, right pericardic consolidation. So MON2 was positive, CECT chest and abdomen showed lymphadenopathy, planned for EBUS. So this is always do white light bronchoscopy as a dictum. This is a rule. Before and after the procedure must be done. Many doctors do directly EBUS, they don't do white light bronchoscopy. It must be done before EBUS and after the procedure. Right upper lobe bronchus, this is an anthragotic pigment. This is the normal bronchoscopy. You can see right upper lobe. This is the posterior segment. This is an anthragotic pigment. And this is the biopsy we have taken for this. These are the EBUS images, and this is the EBUS video. As you can see, the needle is there. So it has special marking so that it is visible in the ultrasound. And this is superior vena cava. This is the to and fro movements, which we do 15 to 20 to and fro movements and take the biopsy. These are the samples which have come out. You can see this blackish pigment, and this is the biopsy, and these are the snake-like threads which are visible on EBUS needle. So it shows necrotizing granuloma. This is the histobiopsy, cytology. This is necrotizing inflammation suggestive of COX. This is the histopath. Diagnosis is pulmonary TB, endobronchial and mediastinal lymph node with anthracosis. Anthracosis is very common. Case study 3, 32-year-old male, more marked pain is on deglutination, nausea and vomiting. Patient had taken oral medicine for cough and URI, but main symptom was pain on swallowing. So upper GI endoscopy was done. A large ulcer in the esophagus and pus was pouring out. So fistula is visible in the base of the ulcer. So it may be pulmonology consultation was asked in view of tracheoesophageal fistula. This is the upper GI slide in which you can see this large ulcer and a fistula is visible here. You can see here. So hospital course, patient admitted in ICU, all routine antibiotics, IV antibiotics, CT thorax was done, which showed a large mediastinal abscess. This is the CT. As you can appreciate, the esophagus is bigger than the trachea. You can see normally a chink is seen on the CT. Now you see esophagus is how much bigger? It is bigger than trachea or almost similar size. Now this is the fistula coming in and this is the mediastinal abscess. This is the abscess, this is the air. So this patient needs certainly surgery, thoracic surgery. But with the advantage of EBUS, this patient was saved of surgery. Now you can see appreciate the esophagus. Dilated esophagus is always pathological. On CT scan, it should be a chink of air should be seen. Now you can see this abscess and a communication, fistulous communication going into the mediastinal abscess. Now bronchoscopy and EBUS was done. Large mediastinal abscess was there at station 7, that is subcarina, and 15 ml pus was aspirated. Now you can see this needle is going in and this is the pus, large pus. Aspirated white purulent pus was aspirated from this and the cavity collapsed after aspiration. Syringe was filled. Upper GI endoscopy was done, clipping at the esophageal rent was done, and patient gastrographin study was done, which showed a fistulous communication. Endoscopy again done, mediastinal abscess showed Mycobacterium tuberculosis abscess on a culture and gene expert also. Patient started on ATT, and this is the cell block histopathology report which shows caseating necrosis. Now, what we learn from this case? Keep all possibilities open. Multidisciplinary team approach is better and beneficial in management. EBUS is minimally invasive technique, useful in diagnosis and management. EBUS averted the need for thoracic surgery in this patient. Upper GI endoscopy patient managed with gastroenterologist in close association. Now, sometimes we have peripheral pulmonary lesions. Peripheral pulmonary lesion is less than 3 cm in size on CT and more than 3 cm is masses. On white light bronchoscopy, we see the lumen of the airways and we know the mass is there, but it is not visible. It is beyond the vision of the normal bronchoscopic limits of vision. So we have got radial ultrasound for this, in which a probe is inserted and it can penetrate 5 cm beyond the airways. This is the whole assembly. You can see this is the probe, this is the probe, these are the various kind of masses which we can see, guide sheath, brush, biopsy. This is for normal biopsy and this is the radial image. So we have two type of EBUS, linear EBUS. Earlier 3 cases which I have shown you are of linear EBUS, with which we take needle biopsies, and this is radial EBUS for peripheral pulmonary lesions. So bronchoscopic biopsy we can take blind, we can take under C-arm with fluoroscopy. It has diagnostic sensitivity of 33 to 60 and may not visualize small lesions. Then we have transthoracic CT guided biopsy. Then we have radial probe EBUS guided transbronchial lung biopsies, which we do under C-arm or fluoroscopy, and it gives us around 3/4, 75% of lesions. Case study 4, we have 58-year-old female, recurrent episodes of abdominal pain, past history of pancreatitis, follow-up case of carcinoma endometrium. This is the chest X-ray, right pericardic shadow you can appreciate. CT chest, 2 well-defined lesions. This is the CT video. Right lung, left lung, trachea and the blood vessels. Main pulmonary artery, aorta. This is the lesion and this is the lesion. These 2 lesions are visible on CT chest. This is lung window. You can appreciate better on lung window. This is the lesion. Now, these lesions were not visible on white light bronchoscopy. So, you know the mass is there. Now, this is the picture in picture view, and this is how, see, normal lung will be snowstorm. Now, see the lesion has come. You can see this round image. Very good. Beautiful image. So, you have localized the tumor or the mass or the nodule, lung nodule, you have localized. So, you can mark it, and once you remove the ultrasound probe, we do brush, X-ray, biopsy, X-ray. So, that is the sequence we do. So this is under CM, radial EBUS with CM. These are the masses which we have taken. Pathology report, BAL was positive. In malignancy or carcinoma lung, rule is tissue is important. Tissue is an issue. Take all the possible samples, BAL, biopsy, EBUS, brush, whatever is possible, so that you must get a diagnosis. So BAL is positive, brush biopsy is positive, histopath is adenocarcinoma. IHC shows metastatic adenocarcinoma deposits from female genital tract over primary lung cancer. So this is a case of metastasis of endometrial carcinoma, and these are the histopath slides. You can see IHC was done. So EBUS is safe. So radial EBUS conclusion, it is an excellent tool to visualize and sample peripheral pulmonary lesions with a pickup rate of 75%, which is more than any other modality available. The size or location has no bearing on the yield. Position of probe in relation to the lesion does not affect yield. Safe procedure. To conclude, carry home message, EBUS or endobronchial ultrasound is minimally invasive and daycare procedure. Peripheral pulmonary nodule biopsy sensitivity up to 75%. Mediastinal lesion can be diagnosed with sensitivity of 95 to 100%. Sampling of high mediastinal paratracheal subcarinal hilar nodes is possible, replacing mediastinoscopy. Sarcoidosis, TB, mediastinal masses, lung cancer are the common diagnosis. It is a standard and established technique for staging of non-small cell lung cancer. Evaluation of peripheral pulmonary nodule and mediastinal abnormalities is possible. So thank you very much for your patience hearing. Thank you, sir.
Hello. Thank you, sir. The latest EBUS technique in chest diagnosis. Any queries from the audience, please?
Yes, sir. The cost of EBUS varies from hospital to outpatient. For linear EBUS, it is 50 to 70,000 rupees. The main cost is needle, which cost disposable needle is used in every patient. That costs around 15,000 rupees per case. We do not use, and it is not recommended to reuse the needle. Many centers use single needle for 2-3 patients, but since last 10 years, we have not used. Every patient, we use a new needle.
Sir, what is the percentage of, what are the complications in the radial EBUS?
Yes, sir.
Radial EBUS complications, like is there any?
Sir, complications of radial EBUS, it is simply a transbronchial biopsy that we do generally with a normal white light bronchoscope. So any biopsy you are taking, the common complications are bleeding, cough, and pneumothorax is very rare since we are doing it under CM after localizing the lesion. And after every pass we do, the crux is localize the lesion, brush, X-ray, biopsy, X-ray. So we take 3 to 4 biopsies. And generally it is EBUS, radial EBUS is only to localize the lesion. Then the transbronchial biopsy is done in a normal way, that is done without radial EBUS. So localization is important because sometimes we know the lesion is there. Something is there beyond the wall. You need to create a window to see beyond the wall. You cannot see what is there outside the wall. I cannot see. How will you see? X-ray, CT scan, imaging. These are our eyes and ears which open the windows to see the pathology inside the patient.
Any comments, queries from the house?
Thank you, sir. Thank you very much.
Thank you.
Wonderful talk, Dr. Chug. Thank you very much. Please come here for momentous honor. All chairpersons are requested to come here. Next one.
ये सब चुप से दे दे चल रख ले बट नीचे रख ले हाँ
Moving forward, our next topic again is interesting on adult immunization. We realize the importance of adult immunization and prevention of diseases, vaccine. So vaccines, what are we going to do with this? For this, we have an eminent speaker, Dr. Manoj Arora, who is Senior Director and HOD, Department of Nephrology and Renal Transplant Medicine, Max Hospital, Shalimar Bagh. I welcome Dr. Manoj Arora, please. And for the chairperson for this session are Dr. Rajni Sharma, Dr. Nityanand Tripathi, Dr. Vikas Maurya, Dr. Rashi Khare, Dr. Amit Jindal. I request them to please be on the dais. Dr. A.K. Singhal, Dr. Anita Tiwari, please come on the dais. Dr. Amit, please. First half. आ रहा है? नहीं चला? पॉइंटर नहीं चल रहा है? अच्छा स्लाइड हो रही है ना? Oh yes, ठीक है.
Good morning, everyone. Good morning, everyone. So, as we all know that we are very much careful for our children. When it comes to our child, then everybody is ready to maintain their schedule for the immunization and prevent them from diseases. But when it comes to adults, I think we all are practicing a lot. But how much time we give for our patients to see whether they are well immunized or not, how much we are working on the prevention of disease rather than only treating. Because we are busy in treating. That's why we usually forget because of our busy schedule. But I think now it is a time to be aware. And I think
Dr. Shashank Bharadwaj. Dr. Shashank, please come for the chairperson.
Right. So it's a high time that we should be aware. And as a general practitioner, as a physician, as a diabetologist, cardiologist, as well as nephrologist, pulmonologist, all have a responsibilities that your patient should do well in life and there should be preventive from the diseases rather than only treatment. So why there is no data from the India or anywhere how much immunization is being done in the adults? Only one study they found it at the AIM Center at Jodhpur 2018 that only post-exposure prophylaxis was in 42% for tetanus and 20% for anti-rabies vaccine. And the pre-exposure was very, very less. You can see it's a very, very low percentage the immunization occurs. Why? The barriers are lack of surveillance, lack of national guidelines for the adult vaccination, lack of coordinated adult vaccination programs, treatment taking precedence over prevention. I think this is the main important where we have to act all together. Lack of provider recommendations, cost, and the lack of recognition of benefits, efficacy, and the safety. So these are the adult immunization schedule which we can do. That influenza should be given annually. TDP or TD should be given one dose and every 10 years. MMR, usually in adults, you have to find whether the immunity is there or not. Only then you have to immunize the adults. Otherwise, it is done in the children. And varicella, 2 doses. If it were born in 1980, and 2 doses can be given. But only when you find the immunity is not there. So there are IgG antibodies available for that where you can find that the patient has a pre-exposure or not. And then you can plan for them if the patient is high risk. Now, zoster recommendation, we will go in detail. HPV, for all females, I think less than 15 years, there is 2 doses and above 23 years to 45, there is 3 doses. It is a preventable disease. So we have to act and think about adult patients, whether how we can prevent them. Even the adult masses also, who are at risk, we have to protect them from the diseases. Pneumococcal conjugate, now we know that we have a Prevnar 20, so which is very, very good. It's a single dose vaccine rather than giving Prevnar 13, then after 2 months giving pneumococcal. So we are in era, we are actually progressing, and definitely when the burden of vaccination becomes lesser, it is easy to administer. Hepatitis A, B vaccine, meningococcal and meningococcal B in the target population. Now, influenza for healthy aging, why it is important? We have 2 type influenza A, B, and C. We all know there are subtypes and there are lineages in the influenza B. Now, the clinical symptoms, many are very, very mild. So it can cause sudden onset of fever, running nose, non-productive cough, headache, mild GI symptom or myalgias. But what happens if it goes into serious infections? And we all have documented and seen many patients developing like ARDS, like picture, florid lung lesions, then they're having myocarditis, then they have encephalitis, rhabdomyolysis, multi-organ failure, and it can lead to death. So a simple influenza can be so dangerous in our clinical practice. So what is the best method? Not to treat, rather to prevent. So for prevention, we know that we have the vaccination available, and we have a quadrivalent vaccine which works for influenza A and as well as influenza B. So why not to prevent our patients from influenza? Who are the high-risk influenza patients? The pregnant women, young adult children aged 6 to 59 months, healthcare workers. They are very much exposed because we keep on seeing the patients and we don't recognize the importance that we have to protect ourselves also. And individuals with the chronic medical conditions, we all know, like chronic lung diseases like COPD, asthma, CKD, even diabetic, I will recommend, because diabetics are always immunocompromised. So all diabetics should be prevented. Then the dialysis patients, then pre-renal transplant patients, even post-renal transplant we give because it is not a live vaccine. So patients on chemotherapy, patients having on steroids, malignancies, they are the patients who are always at high risk. So we must involve the vaccination schedule in these patients. Now, it is found that the diabetics are always at very high risk, even if they develop influenza. They have 3 to 6 times risk of hospitalization, 4 times risk of ICU admissions, and the risk of death from pneumonia. So we have to prevent them. Now, the recommendations, we all know that annual influenza vaccination is recommended. Pneumococcal. How recognize this problem is the pneumonia is not an uncommon problem we see in adults, and the annual incidence of pneumococcal disease is 4 times than of younger population. So they have a higher rate of hospitalization and mortality, but this can also be prevented. So the invasive disease continue to be major global cause of morbidity and mortality in adult patients more than 65 or age. The overall fatality case rate reported is 17.8%, which is not a lesser percentage. Now, whom to vaccinate? One, all patients above 50 years, you should vaccinate the patients. Then age from 18 to 49 years. Who are the patients who can develop pneumonia and we have to treat them or prevent them? It is pregnancy, immunocompromised, HIV infection patient, asplenia, CKD, even CKD 3 to 5, and a dialysis patient. But it is always good to prevent them even CKD 1 and 2 because their immunity is more. The moment you give vaccination at an early stage, it mounts the immune response in a better way rather than at a later stage of CKD. Heart and lung diseases, CLD, alcoholism, diabetic, hospital care personnel, all of hospital care personnel should be vaccinated well. Frequent travelers and the mass gathering, where the patient is more exposed to the mass gathering all the time, then they can also be prevented. We all know earlier we used to give 2 vaccines, first Prevnar 13, that is PCV 13. Then after 1 year, we used to give PPSV 23. And in patients where we have to go for transplant or the very high risk, then we give this vaccine 2 months after the PCV 13. Now, we are more dependent on PCV 20 because I have started giving this vaccination. So because it covers more valence and the more valence and it's a single dose vaccine. So you don't have to remember whether you have given PCV 13 and then later on PPV SV 23. So one dose works for the lifelong and it is a one-time vaccine. Give it and then forget it. Shingles. This is also very, very unrecognized. As a nephrologist, we see herpes zoster very common because our dialysis patients, because of our transplant patients, because of nephrotic patients who are on steroids. And I think many of us treat patients with immunosuppression, but we never give importance to shingles because when the patient develops herpes zoster, we try to treat it and then we forget. But patient never forgets because the post-herpetic neuralgia keeps on chasing the patient and disturbing him. I think most of the neurologists who are saying they also see so many patients of trigeminal neuralgia, and even the skin specialists, they keep on giving gabapentin, then the triptomer, then carbapenem. There are whole lot of medicines and many times the combinations, but still the patients say one thing, that my pain is still there. It has reduced, but it has not gone. So it can be so devastating. Then why not we prevent this? So it is the responsibility at the, I think, all physicians levels rather than any super specialization, how to prevent the old age patients. And then if we can prevent this post-herpetic neuralgia, we can prevent the even herpes zoster, then why not? So we have to be aware, and why it is important, let's go through it. We all know that 99.5% of adults have the chickenpox, and they are immunity, there is a natural immunity towards the varicella zoster. But there is a reactivation of this virus later. Why it happens? Let's see. It is age and the immunocompromising conditions which are well-recognized factors. Why? Because one, we all know that there is a dermatomal distribution. Thoracic is more common, then lumbar, then sacral, cranial, and cervical. And I think cranial disturbs the most, because then there's a lot of post-herpetic neuralgia around the eyes, around the brain, and they keep on having headaches, which is really taking the quality of their life. But what is the basic why it happens? Because as the patient is immunocompromised, or as the patient reaches more than 50 years, the varicella zoster specific cellular immunity declines with age. And this decline in cellular immunity is associated with increased risk of shingles. Not all the patients or all the older adults will develop, but those who develop, they suffer it very much. So Shingrix design and efficacy data, where we stand today with this vaccine. This is an inactive vaccine. It's a killed vaccine. So there is an antigen and there is an adjuvant system. So it comes in 2 vials. You have to mix them and you have to give 2 doses. Now, this was an experimental design. What is the data which supports why should we vaccinate the patient with the shingles? They found the primary objective was efficacy in more than 50 years, and primary objective herpes zoster vaccine efficacy in more than 70 years. They enrolled the patient and they divided into placebo as well as the vaccinated group. And finally, the dosing schedule was 0.5 ml of IM at 0 and 2 months, but it can be given between 2 to 6 months anytime. And they found that the patients who were vaccinated, when they were followed over the mean period of, I think, 3.2 years, and here in the 70 years, 3.7 years, the efficacy was 97.4%, and here it was 91.4%. What actually happened? The Shingrix cases was 6, then 3 and 2 when they were vaccinated, and the placebo cases there were 210, 87, and 75. So how much difference is there in these data? And secondly, over the 70 years, there were slightly more patients who developed Shingrix despite having vaccination, but it was still less than 10% to who are not vaccinated. So the efficacy remains around more than 90% at 4 years of time also. Similarly, they found that by preventing the Shingrix, they decrease the risk of post-herpetic neuralgia also. So the patients who developed Shingrix despite having vaccinated, but the post-herpetic neuralgia was very, very less, and the efficacy was more than 90% in preventing those symptoms. So both way it benefited. One, if it prevents, that is the best. If it does not prevent and it reduces the post-herpetic neuralgia, still it is a win-win option for all of the patients who develop this. And they found that at even 6 years of that, the efficacy remains. And even the 70 year, they've studied the cohort, the overall efficacy, at 11 years they studied, and it was still 87.73%, which is good. Now, these were all patients where the vaccination was given: hypertension, osteoarthritis, dyslipidemia, diabetic, osteopenia, GARD, sleep disorder, the various gamut of diseases, respiratory, renal disorders, and the efficacy remains the same. Similarly, what were the side effects? The side effects were mild, the pain at the site, redness and swelling, which subsided in 2 to 3 days. And there was mild fatigue, fever, some diarrhea, headache, myalgia, and shivering, which also remained for 2 to 3 days. And with a simple symptomatic treatment, it resolved. Now, it was comparable in measure of the side effects. There were no major side effects reported by Shingrix. Administration, we all know that first dose and then the second dose between 2 to 6 months. If we are planning for transplant, we try to give it in 2 months. If you find that the patient is high risk and can take in 2 months, then 0 month and the 2 month, but it can be given up to 6 months. So you can plan anything from 0 to 0 month and second dose from 2 to 6 months. Now, whom not to vaccinate? If the patient is on high dose steroids, more than 20 milligram, it finds that because he will not mount the immune response. So better that once your prednisolone dose is less than 20 milligram per day, you should vaccinate the patient, but do give this vaccine. And the patient is on rituximab, then preferably defer it for more than 5 months before the last dose. If you are planning rituximab, then it should be given at least 4 weeks prior to the scheduled next therapy so that the patient can mount the response. Otherwise, this vaccine will be wasted. Now, can it be co-administered? Yes. It was studied and they found that it can be co-administered with the influenza, pneumococcal and Tdap. What is the advantage of co-administration? Because the patient has come to you, he will not visit you again and again, and you will also forget. So it is better to co-administer the two vaccine if the patient is not vaccinated. So that will save your time, that will save patient time, and the compliance will be much better. But in one study, they found when they gave pneumococcal vaccine along with the Shingrix, there were more chances of fever and chills, and then that resolved with giving the paracetamol and the simple symptomatic treatment. So that has to be taken care. Otherwise, they can be co-administered safely, and there is no interference with the immunity mounting with the 2 or 3 vaccines. It is indicated for prevention of herpes zoster. Right now, the guidelines say more than 50 years. But then I was going through that our transplant patients are of 20 years, 25 years, 30 years. Then shall we prevent them, or shall we go with the guideline where the Indian data says that more than 50 years it is recommended? So between 19 years to 50 years, if the patient is high risk, I think still Shingrix can be given. Especially we also prefer in patients who are on dialysis, because we see herpes zoster very frequently in our dialysis patient. And secondly, CKD4/5 and prior to kidney transplant. Usually I try to give it within 2 months before that, so that 4 weeks before the transplant, all vaccination should be completed so that we can start our immunosuppression well in time, and that does not interfere with the immunogenicity or the immune mount response with the immunosuppression. And we have to give high dose steroids initially, and then we taper it off. So definitely we try to do all the vaccination before 4 weeks. So it should be refrigerated 2 to 8 degree, but then there are 2 vials which should be mixed, and then it should be given intramuscularly. It should not be given IV, subcutaneous, intradermal. Only recommendation is intramuscular. So what is the advantage is that this is more than 90% efficacy, 11 years long-term protection, around 87%. Recombinant vaccine, so nothing much, because there is no risk of, it's not a live vaccine. Approved for adults in more than 50 years. But yes, we are using it in a kidney for CKD4/5 as well as dialysis patient and the pre-transplant before even the one study they have done post-transplant. Can we give this vaccine because it's an inactive vaccine? So yes, after at least 4 months of kidney transplant, we can administer it, because that time the steroids has been on the reduced dose, I think at around 5 to 10 milligram per day, and our immunosuppression is very low. Then it was given, the efficacy was still around more than 80%. So it is a good option for post-renal transplant, but after 4 months of stabilization of transplant. Thank you so much for your kind listening. And if there are any questions, I think I'll be more than happy to answer.
Very inclusive talk, Dr. Vinod. I think if a pediatrician is seeing a child and he does not vaccinate them, I think it will become a big scandal. But for adults, we are still lagging behind. I think it should become the norm that every one of our prescriptions should contain the vaccination schedule for adults. I've made it a part of my practice, and even at Fortis, we are giving the vaccination schedule to everybody. And I think all physicians should follow it.
I think the best thing is you make a printed schedule and give to the patient and label him and put the date. That is the only way you can vaccinate. Otherwise, you will definitely tend to forget because of the busy schedule. I have made a small prescriptions of vaccination, and the moment patient enters, on the first visit, I just ask what vaccination you have taken, hepatitis B, pneumonia, what I want to prevent them, and usually I tick. If he has taken and he is not remembering, I just ask them to bring the data or a history or your records. Otherwise, I just keep putting the dates, and next time he keeps and just put it on the file. There is no other way we can remember, because the same patient will come maybe after 6 months, sometimes lost to follow up, sometimes he come frequent visit, but because of uncontrolled diabetes, you will forget vaccination because you will keep on thinking of blood pressure, diabetes, fever, everything. But you will definitely try to forget because you have to see 100 patients in a day, then definitely how can. But it is so important and underutilized in adults. We all will agree who are sitting in this, definitely despite being awareness, we don't pay much attention for the vaccination. So today I chose this because we always talk about kidney, but why not we prevent the adults like our children? Because why not have a vaccination schedule and prevent the older age population rather than focusing on our child? One study was there where what they did for their children, they used to buy a high branded drugs, and for themselves, the parent used to buy a generic drug. So that is the bias which has been seen. I think that is a very, very real term data. And that is what we do to the vaccination also, because if it comes to your children, you will take the schedule and you will, even if you forget, next day you are leaving your job and going to the pediatrician, yeah, please vaccinate karo mere bete ko, kal main bhul gaya tha. Even to me, it happened that I wanted to Gardasil because of this HPV vaccine to my daughter, and I forgot. I left that hospital and first I went there, bought that, and then gave her vaccine and came back, because no, that was very important. But when it comes to adults, see how much unaware and we remain. So only take home message is just be aware and then start doing in your practice, and then you will feel so much satisfied that you are now preventing the adults and the old age population from the diseases. Thank you so much. Right, sir.
And many autoimmune encephalitis, you have to reuse it, or in patients with demyelinating disease, you have time.
Right.
So as regards Shingrix, what is your recommendation? Because you say 2 doses are required. And how about it? Like in emergency, we give rituximab in autoimmune encephalitis. After
Then I think once you have given rituximab, wait for 5 months, and then you have to vaccinate. That is now God will take care whether in 5 months he develops the herpes or not. But definitely the recommendation, because he will not mount the response. So there is no point. Or if you are planning that after 2 months, I am going to give this, then definitely 4 weeks prior to the next rituximab, you can plan it. Because rituximab is an elective therapy. You can plan whether 2 weeks apart, whether monthly, whether you want to give 6 months. So every disease has a different protocols for rituximab administration.
Excuse me, sir.
Yes, ma'am.
Sir, it reduces the intensity of.
Sorry, ma'am.
Post-herpetic immunization, do you
Not
advise?
able to
Few
get you,
years,
ma'am.
lifelong immunity remains once a person gets herpes zoster?
Yes. The recommendation are two different. One says that once the acute symptom has resolved, there is no, the febrile illness, the lesions have healed, you can administer. The another data, the Canadian, they say 1 year, you wait for 1 year and then you administer. So I think in Indian, the scenario is that at least 3 to 4 months you should wait. That is in middle path, but both have the given. But once the acute phase is over, don't give in that sense. There is no point. Because then at least wait. And the two different theories are there. One say that minimum 1 year you wait, and then after you give, it will be more effective, because there is some natural immunity which has been boosted up by that, and you can prevent them. But another says that, once it has healed, maybe a month later, you can give it easily 2 doses. But we have to choose in between. But I think 3-4 months is fine after that.
Thank you.
Thank you, ma'am.
Dr. Arora has wonderfully highlighted the importance of adult vaccination, which again, till now we are lacking in our efforts of recommending adult immunization. I'll request our chairpersons and Dr. Arora to please come on the right side of the dais for felicitation ceremony. Moving forward to neurology, our next topic is really very important. In fact, many a time when we cannot diagnose a patient, a disease, we label them as a functional disease, refer them to psychiatrist, or start antipsychotic medication. So here, Dr. Jaideep Bansal, who is senior neurologist from Fortis Shalimar Bagh, will be talking us about this. When worry is not just anxiety, an important and rare disease like Creutzfeldt-Jakob disease masquerading as hypochondriasis. I invite Dr. Jaideep Bansal for his talk, and the chairpersons are Dr. B.K. Gupta, senior neurologist from East Delhi, Dr. Amit Jindal, Dr. Hemant Sharma, Dr. Sanjay Dhal, Dr. S.K. Agarwal, Dr. Niti Parves, Dr. Sasank Bhardwaj, Dr. Sandeep Miglani, Dr. Praveen Bhatia, Dr. Ram Babu,
उस भेजो यार उसको कनेक्ट करो आ तो गया सर कनेक्ट हो गया अच्छा there is an announcement there will be a lucky draw just before lunch from the company Systopic. There will be 5 prizes, so just wait for the moment So 5 lucky prizes just before lunch by the Systopic Drug Company. Thank you.
Good morning, everyone. Thanks to the organizer for giving me this opportunity to present a rare case. It was really a very interesting case where the patient was presented with very subtle signs and the serious disease like CGD was masqueraded by hypochondriasis. And this is the title I just chose just because when worry isn't just anxiety. Most of the time we just pass it on as anxiety, but that may masquerade the serious condition. So this was a journey of the case where the patient was presented, 50-year-old female was presented with certain subtle symptoms of neuropsychiatric manifestations. And then we worked it up and the immunotherapy was given, the patient was continuously deteriorating. And once it was deteriorating, then we changed our line of treatment and investigation. And the patient CSA was 14-33 protein, which was the white pivotal protein, and that was positive. And that confirmation was done by MRI and other findings. And then I will just describe all these things. Basically, this was the patient, 50-year-old female, who was right-handed, graduate and homemaker, was presented with the subtle signs of behavior changes in the form of restlessness, disproportionate anxiety for her college-going healthy son, who was otherwise normal, but she was having a lot of anxiety for her. And subtle visual symptom in the form of occipital, there was fixation difficulty in vision. That was very subtle. And the gait ataxia was also the history-wise, and the patient was otherwise hale and hearty, and there was no history of headache, memory loss, any jerky movement or seizures or sleep disorders or any convulsions or any speech disturbances. And the patient was not having any history of fever, headache, vomiting, and there was no history of toxins and the drug exposure. There was no history of smoking and alcohol consumption. The family history was also non-contributory. On examination, the patient was otherwise largely the examination was unremarkable except certain subtle cerebellar signs. The patient was fully conscious, oriented, alert, and fully cooperative throughout the examination. And her MMSE scale was 30 out of 30, and cranial nerve examination was normal. Motor and sensory system examination was normal, except these subtle cerebellar sign in the form of mild impairment of the tandem walking. That was the only sign on examination. Otherwise, patient was not having any deficit. So for this clinical history and examination, the first diagnosis which I could make was maybe the anxiety or postmenopausal syndrome. But as there was a subtle ataxia which was on clinical examination, it was observed. So I also kept the possibility of CNS demyelination, autoimmune encephalitis, and the infective encephalitis also. She had a history of spells of blankness. That was the key for which I just advised for EEG. And EEG was really abnormal, and that could not be ignored because it was showing generalized periodic discharges. And this was the key. And I just asked the patient to get admitted. The moment, when the patient was admitted, I got the MRI done. After getting the MRI, it was surprising to see the patient was having this subtle frontoparietal frontoparietal flare hyperintensity. And the cortical ribbing was also seen. That was also very, very subtle. The radiologist was not very convinced with that, but the only finding which he described was the subtle cerebral, the frontoparietal hyperintensity on the flare. And the post-contrast enhancement was not seen, and unilateral focal findings were suggestive of demyelinating or inflammatory disease. These findings are not typical of autoimmune encephalitis as well, but as these findings were there, we further investigated the patient in the form of all routine investigations were normal. The TLC, CBC, KFTA, and LFT were normal. EEG was showing the periodic discharges. MRI was showing subtle frontoparietal hyperintensities and cortical ribbing. CSF was also normal, and the CSF, Bacterial and viral panel were also negative. And the serum NMO, MOG, anti-TPO, paraneoplastic vasculitis profiles were also normal. She was thoroughly investigated for the lesion in the brain, which was frontoparietal hyperintensities, to rule out the vasculitis and other demyelinating disease. All investigations were done, which were normal. And then the CSF autoimmune panel was also sent. The report came for Casper-2 positive. This was the encephalitis which is treatable, and it may have some underlying malignancy also. So we got the whole body PET scan, which was also normal. A single positive Casper-2 result was only finding which we got and we started the immunotherapy. Immunotherapy in the form of methylpenicillin and IVIG. Autoimmune encephalitis, why we had an initial diagnosis was reasonable, because autoimmune encephalitis is an inflammation of the brain driven by the antibodies against the neuronal surface and synaptic proteins, and rather than any infective etiology. As the patient was not having any fever or other things, the inflammatory etiology seems to be the reason. And it typically present with subacute presentation with the behavior and the psychiatric manifestations, which she had. And seizures, memory disturbances, and other movement disorders, they are also part of autoimmune encephalitis, but initially it may not be there as in our patient. The picture was, this picture may be there with other closely resembling other encephalopathies as well. So this was the initial presentation of the patient, and most of the important thing for the autoimmune encephalitis is that this responds very well to immunotherapy, and at least for partially it responds. But in our case, the patient was not responding to autoimmune the immunotherapy. The most common autoimmune encephalitis is the NMDA receptor antibody encephalitis, and the LGI1 and the Casper-2. The Casper-2 is having more prevalent in the male, but in our case it was female. So, but still it can be there in the female as well. And normally the treatment for the autoimmune encephalitis is the first line immunotherapy in the form of steroid, IVIG, and plasma exchange. And then if patient is refractory, then the rituximab and cyclophosphamide may be given. In this patient, we gave methylpenicillin and IVIG, and patient had some improvement, but still the patient was having the symptoms, and the symptoms were so subtle that they improved to some extent. So we discharged the patient, and patient went home. And 2 weeks after the discharge, that is 8 to 9 weeks after the onset of symptoms, the patient came to my OPD, and she was really having gross ataxia. She was not able to walk independently, and her husband and son was holding her, and she was brought to me. And then when I saw her, she was having a brainstem signs in the form of bilateral ptosis and ophthalmoplegia and the downward gaze. These were the findings which were suggesting there was serious deterioration, neurological deterioration, and this was suggesting that patient may have a extension to the brainstem. And but she was immediately admitted, and we got the CSF and EEG done. The CSF was normal. They were not showing any abnormality. Proteins were normal. CSF was also normal, and the EEG was also same as previously. And the discharges were less. But the MRI was done that showed a subtle increase in the same changes which were there previously also. So this was the MRI, and you can see the basal ganglia. Now the basal ganglia was also involved to some extent. These are very subtle, and we have discussed with the radiologists. They were not very much convinced, but saying yes, something is there. But the cortical ribbing was on the both sides. Initially it was on the one side, now it became into the bilateral. That was also very subtle. So these subtle findings with worsening was really worrisome for us. So we escalated the immunotherapy aggressively, and we treated the patient with plasma exchange. The patient was not showing much of the improvement, and then we repeated the methylpenicillin. Sometimes in autoimmune encephalitis, patient do very well with the methylpenicillin itself. So that was given, but the patient was not showing any sign of improvement. That was really worrisome, and we were thinking, okay, what exactly we are dealing? Are we dealing something else? than the autoimmune encephalitis, because autoimmune encephalitis usually respond at least partially to the immunotherapy, and the aggressive immunotherapy was the thing which we did. And then the patient was taking a lot of second opinions and other things, and we were not very keen to give the rituximab as the patient was not responding to initial therapy. But we gave the rituximab also. But after that also, patient was not improving, and they continued to deteriorate. So yet the clinical status continued to decline through the everyday escalation. The first real sign that was working diagnosis to be relooked. And we got the MRI done, which again showed the more prominent basal ganglia changes, hyperintensities, and the ribbing was also more prominent. This is basically very sensitive for the prion disease. It is the time when we thought it may be a prion disease, because in prion disease, the basal ganglia involvement and the cortical ribbing is the classical sign for the MRI. But there was no history initially there was no history of cognitive decline or memory loss that was against that, but still that possibility was kept. And when non-response becomes the diagnostic clue, because in this the Casper2 antibodies were positive, still the patient was not responding to immunotherapy. That was the clue. Okay, we have to think something else, because in encephalitis this is not the classical MRI which shows the hyperintensity in the basal ganglia or the cortical ribbing. Usually the encephalitis the MRI may be normal also, and if abnormal, then it is usually the medial temporal lobe which is involved. So patient was deteriorating, was drowsy, and gaze deviation was there. That was persisting. That was not improving, in hallucinations and focal seizures and focal myoclonus started. This was the first time when the seizures occurred and the myoclonic jerks were there. Before this, there was no jerk or any seizure. So though the EEG was abnormal right from the beginning, but there was no overt jerky movement or myoclonic jerks. That was also not favoring the encephalitis and the CGD as well. But the facial automatism was also there. The patient was bedridden, akinetic state, and the rapidly functional collapse over just weeks. The faster, as in the typically the encephalitis usually takes a slower course, but the patient was deteriorating very fast. So we repeat the CSF, and the CSF was showing the protein which is specific for the CJD, the Creutzfeldt-Jakob disease, the CSF 1433. This came to be positive, and this was the key for the turning point. Because if the CJD is there, then your immunotherapy you have to stop, because the disease is not treatable. And the CJD, the protein 1433 is having sensitivity of 85 to 92% and specificity of 80 to 85%. So this was it may also be falsely positive. Falsely positive may be there, but clinically, radiologically, and EEG finding collectively, if we see, then this is a case of probable sporadic CJD, because the typical MRI shows at the 10 weeks, there was prominent bilateral hyperintensity was noticed, and bilateral cortical ribbing was also noticed, and this EEG was showing continuously 1 Hertz generalized periodic discharges, along with the clinical history of deterioration and the myoclonic jerks. And the CSF 1433 protein, though they all collectively is the diagnosis was probable sporadic CJD. There are 10 weeks, 5 turning points. And for provisional autoimmune encephalitis to escalating the treatment refractory CJD. And the initially 1 to 4 weeks patient was presented with the symptoms, and they were diagnosed, and the CSF Casper2 antibodies were positive. And 4 to 6 week initial treatment was given with slight improvement with the condition, the patient was discharged. And readmission on 8 to 9 weeks, the patient was clinically deteriorated very significantly, but patient's radiological and CSF and other findings were not very significantly deteriorated. So all the aggressive immunotherapy was given in view of the fact that the patient may have the refractory autoimmune encephalitis. So, but the patient's condition doesn't improve. And on week 10 of the onset of symptoms, the patient was the typical MRI finding, EEG and protein C, CSF protein 1433, which was positive, that was highly suggestive, and the diagnosis was confirmed. So, what is sporadic CJD? It is a rare disease and hiding behind a treatable condition of autoimmune encephalitis. The estimated global incidence of CJD, is Creutzfeldt-Jakob disease, is 1 to 2 per million per year. This is very, very rare, but it is the most common human prion disease. And the median survival for the CJD is 4 to 6 months, and from the onset of symptoms. And the patient died typically within a year. And the 85% of the patients are sporadic cases, and rest of the 15% of the patients may be familial, or it may be iatrogenic, or it may be variant CJDs. And the non-disease, this disease is not having any disease-modifying therapy, is not a treatable condition, but still we have to treat diagnose this disease early, because if we are not diagnosing disease early, we are exposing the patient for the unnecessary escalation of the immunotherapy, and infection control also should be taken care. The prion mechanism is the prion disease caused not by the pathogens with the genetic material, but by a misfold of normal protein. This is a prion protein. This misfolded prion protein acts as a template, converting normal protein into the abnormal form in the self-propagating chain reaction. That is the pathology, and this is a normal protein which is misfolded. And this drives a progressive neuronal loss, and the spongiform changes, which is a characteristic of the CJD. And the progression is rapid and relentless, and decline, characteristic of the sporadic CJD. So there are 4 markers which are validated for the sporadic CJD. One is the CSF 1433, which is having sensitivity of 85 to 92%. And MRI typical findings are the bilateral basal ganglia hyperintensities and bilateral cortical ribbing. If these findings are there in MRI, that is having sensitivity of more than 90%. And the EEG is also characteristic for CJD, that is 1 to 2 hertz, and which was there in our patient. And the artery Quell's test is also very sensitive, that is 87 to 97% sensitivity, and specificity is 100%. In our case, we have not done it because it was not available. Where this case sits on the CDC criteria, it is a probable case because the clinical picture, the CSF and EEG and MRI was all typical, so it was the probable CJD. And the rare disease hiding behind a treatable one is the CJD is a rare and fatal disease, and overlap may occur. In CJD patient, the Caspr-2 the autoantibodies may be positive, and the pitfall is when autoimmune panel returns falsely positive in CJD patient, it often triggers the unnecessary immunotherapy. This is basically the message is, whenever we are having any disease which is treatable, we have to treat. But simultaneously, we have to see if it is not responding. Autoimmune encephalitis is not responding to immunotherapy. That means it is very, very unlikely that it is autoimmune disease. And why Caspr-2 positive antibodies are positive? Because the prion-mediated injury, that also releases certain neuronal destruction and causes the CJD, the antibodies to be positive. And non-specific immune reaction will also may cause a false positive autoantibody, which are all described in different cases where, though it is not very common, but they are all described. The autoimmune antibodies positivity in probable CJD cases, a mini review literature. And again, CJD patient mimicking the autoimmune encephalitis with Caspr-2 antibodies. There are anecdotal reports which are there, but they are present. Means the markers, the autoimmune antibodies, or autoimmune panels, they are not very specific for it. They are suggestive of certain disease, autoimmune encephalitis. But if there is a neuronal damage, that also will cause the false positivity of the autoantibodies. So whenever the antibodies are positive, we have to always see the other findings, including the clinical, radiological, and the EEG picture. In our patient had ophthalmoplegia and the downward gaze was there. This is also very rare in CJD. And there are case reports where patient was presented with supranuclear vertical gaze palsy, but that is also very rare. So the message is the antibody positivity is not equivalent to the autoimmunity, and the positive autoimmune panel should not exclude the CJD from the differential, especially when patient is having progressive course and declining. And the serial imaging is decisive because in initial MRI, the findings were very, very subtle and that was not ignorable. But as we did the third MRI, that was showing bilateral and significant bilateral basal ganglia involvement and cortical ribbing, that was also bilateral. And the weighing the escalation, whenever the disease is treatable, that should be, the immunotherapy should be done aggressively. But with the thought that if it is not responding, then we have to rethink. And early diagnosis still matter because as there is no disease modifying treatment is there. And the goal is for care and avoiding the futile intervention and the enable infection control precautions, because in this infection control precaution is also very important. Thank you.
Thank you, Dr. Bansal. Any questions, queries from the audience?
Dr. Bansal, it's an excellent presentation. I think this autoimmune encephalitis and CJD is a very rare disease.
Yeah.
You require high index of suspicion, and most of the time it is a diagnosis of exclusion.
Right.
And most of the time the tests are not available.
Yes.
Like specific antibody tests are not available in most of the setting. How frequently this autoimmune encephalitis associated with autoimmune pancreatitis or autoimmune hepatitis? Is there any relation?
Yeah, basically these all antibodies are whenever the antibodies are present, it is not just localizing to one area, though the clinical presentation and that may be different, but autoimmune disease is in fact involving all the different areas in a different part, and pancreatitis, and they're all well described.
How frequently we must give this steroids or immunosuppressant therapy? Because most of the time it's 6 weeks or 8 weeks. But in this case, encephalitis, you said that patient may have seizures,
Yeah,
or
usually-
patient may have
usually-
other long-term complications.
Yeah. Most of the time, the autoimmune encephalitis, they respond very well to this immunotherapy, that is methylprednisolone and IVIG or plasma exchange. And after that, the maintenance course of steroids are given to 4 to 8 weeks. And then the patient is closely observed. It may require to give for 1 to 2 years also. Sometimes steroids are given for 1 to 1.5 years or 2 years.
Would you like to summarize the thing for the audience, because audience is MD medicine, most of the people, like what are the salient points for the diagnosis between a chronic demyelinating disease and autoimmune disease, so that they remain alert? Basically, treatment will maybe same in almost both the cases.
Yeah, basically thing is why I just chose this case, because patient was having very, very subtle sign. When she came to me, 50-year-old female at the postmenopausal age, and healthy son, college going healthy son, unnecessarily taking, means worrying for her health is a normal phenomena. The mother may feel anxious about the health of a child, but that sometimes may indicate you have to just correlate other things. Subtle signs means the patient was giving history that she is having difficulty in fixing, and also in sometimes she becomes unsteady, and that was not a normal phenomena. And when I examined, this was a subtle impaired tandem walking was there, but that was definitely there. So in initial phases, whenever the subtle signs are there, that should not be ignored, and it should not be taken as a functional or postmenopausal syndrome. And it's better to get certain tests done to confirm it. As in this patient came to the OPD, and I was just writing medicine for anxiety, but I opted for EEG, and EEG was abnormal. One test abnormal means you should never ignore it. Whenever the patient said to be anxiety or postmenopausal syndrome or any anxiety neurosis or functional, in any test which is positive or any positive clinical finding, that should never be ignored, because that may be the starting of the underlying dangerous disease. If treated, that it can be prevented. But in this case, it was CJD, which is not treatable. That is fine, but still the disease was there.
So my last comment is that message for all is all symptoms of subacute onset less than 3 months. If there are new findings, whether it's behavior, confusion, eye symptoms, imbalance, or any memory loss, they should be thoroughly investigated, just not sparse as a psychiatric or a functional illness. So you can find one treatable disorder, maybe autoimmune encephalitis. In this case, the CJD was, some pointers were there as the EEG and some subtle signs. But of course, if you miss one autoimmune encephalitis, which is treatable, so we are committing a lot of blunder. And we, as we know that CJD doesn't have any treatment, but it is an eye-opener and, for lesson for all, to investigate all these patients and rule out autoimmune process. I think that is
normally
the message.
CSF 1433 is not available readily, and we sent the sample to Hyderabad, and the sample was in Kochi. It was sent to Kochi and it was positive. So it was high suspicion when the MRI was showing bilateral basal ganglia hyperintensity and cortical ribboning, which was bilateral. This was the high index of suspicion, and patient was not responding to immunotherapy and deteriorating gradually. And EEG was also showing 1 Hz spike, which was also characteristic of CJD. This was the clinical diagnosis, which were very, very clinical and radiological and investigational point of view. So we proceed for the 1433 and to confirm it. This was the case, basically. Thank you.
Thank you, Dr. Bansal, for nice elaboration. And I request chairpersons to honor our speaker. And in the continuation of the neurology sessions, the next topic is acute ischemic stroke from ER to angiosuit, and the discussant or the learned speaker is Dr. Shailesh Jain, Director, Department of Neurosurgery, Max Shalimar Bagh. And for this session, I request Dr. Sunil Bakshi, Dr. Amit Singhal, Dr. Manoj Khanal, and Dr. Sunil Attari to chair the session. I request Dr. Girish Tyagi to chair the session. Dr. A.P. Mishra, if he is here. Dr. A.P. Mishra, please welcome. Over to Dr. Shailesh.
Thank you, sir. Very good morning. It's my pleasure to be here in front of all the stalwarts of the society. You are the basic pillars of the society, because most of the patients have full belief, and you are the family physicians. So whole family have a total faith on you guys. So it's my pleasure to be here again. So this is a very common topic, actually, everyone knows. But this is a very touching topic to me. I'm a neurointerventionist. So there are a lot of things, upcoming technical things, which are advances in management of a stroke. These are the things I want to emphasize today, because most of the things you guys already know. So this is a common platform for sharing knowledge, experiences. I'm a new learner, definitely you are the senior persons, but still I want to show something. Basically, stroke means ischemic strokes. I want to emphasize here. Ischemic stroke is more common. Third leading cause of death and disability worldwide. Because of the morbidity and mortality associated with this disease, the latest techniques are coming in the management. So initially, it depends which vessels of the brain are involved that causes ischemia. If it is a small or medium size, we definitely know the treatment. It could be given dual antiplatelets, anticoagulants, or even IV thrombolysis. But what to do with the large vessel occlusions? Large vessels means the diameter of the vessels more than 2 mm, or the large vessels means internal carotid artery, middle cerebral artery, basilar artery. These arteries have a diameter more than 2 mm. So my today's topic is why to emphasize time is brain. Definitely for every stroke, time is brain. But why to emphasize more time is brain important matters in large vessel occlusion, large vessel LVO. So brain, everyone knows if after a blockage, after a stroke, roughly 2 million neurons die every minute. That means after an hour, if you lost that time, after an hour, your brain ages 3.6 years more than your normal age. And large vessel occlusions, they compromise about 3 to 4 cases out of 10. So that's a big number. Why 3 to 4 out of 10? Means 6 or 7 patients may not require the latest treatment, which I'm going to mention, that is called as mechanical thrombectomy. So 3 to 4 patients, if at all we give dual antiplatelets, IV thrombolytics, it is not going to work in them. And the mortality is very high, 90% mortality. And the studies are showing if we treat those patients on time, 3 out of 1 patient can be saved easily with morbidity and mortality. So before going to details, everything, this is just a normal slide showing the lobar areas of the brain. This is called as MCA. This is major, orange color is showing MCA. This is a major territory of the brain. Basically, most of the strokes of large vessel occurs in this area. Rest is ACA, basilar artery, brain stems. So basically the signs and symptoms, if patient come to you, most of the time we have seen like patient come with paralysis. So we think it is a stroke only. Is there any other signs or symptoms do we recognize? This could be a sign of a stroke also. Definitely there are 1/3 cases of stroke mimics also. Migraine, functional, seizures, with Todd's paralysis, they can mimic as a stroke. But there are definitely certain signs by which we can see, we can retrospectively analyze this could be the large vessel occlusion. So basically in MCA, we have seen contralateral weakness, gaze fixation, aphasia, speech difficulty. In ACA, leg weakness. In basilar artery, mostly patients come in respiratory failure, lower cranial nerve palsies, and mostly in comatose condition. So this is the diagram showing various circle of Willis arterial distribution. We must understand basic things. I'm not going to explain each and everything, but the larger vessel. If we see some signs, that basically the middle cerebral artery supply 2/3 of the half of the brain, basilar artery supply brain stem. And so these two territories, MCA and basilar, basically they are the more leading territories supplying the brain. So most of the strokes happen in MCA, rest in ICA and basilar for the large vessels. So we have to treat them urgently because these are the major vessels. If half of the brain or brainstem get involved, patient will remain paralyzed or bedridden for lifelong. Because IV thrombolysis even is not going to work in clot burden because these vessels carries heavy clot burden. Thrombolytic drugs most of the times are not working in them. In that case, we have to go ahead for advanced treatment, that is mechanical thrombectomy. But how we approach them, if we doesn't know them, we cannot explain to the patient. So these are the various names we use in stroke cases. I'm just mentioning these things. LVO is large vessel, BFAST are the symptoms to recognize balance, arm weakness, facial weakness, speech recognition, aspects score. It is given here, aspect score. Aspect score basically is a CT-based score to judge how much area of the brain has been involved. NIHS score. NIHS is national score which we normally do in emergency or by a neuro team or an emergency person to grade how much severe stroke it is there. It could be mild, it could be moderate, it could be severe. There are certain points. Everyone should carry a chart or a card or can see in phone. It's hardly 5 to 10 minutes job. Race is a score which is important for a clinician if patient come to your clinic. RACE is rapid arterial occlusion evaluation. Most of the patient give a phone call to you, sir, I am having this problem, what could be then? So if you ask the history, if you examine, if the patient comes to your clinic, you can rapidly evaluate this could be large vessel occlusion. So it includes a point, facial, arm weakness, leg weakness. If you score it accordingly, there is a score of 0 to 9. If you score more than 5, that's a suspicious look of patient may having a large vessel occlusion. So this is the role of mechanical thrombectomy. Why it is important? Mechanical thrombectomy basics, I just want to show one thing. It is a simple procedure just like we do in cardiac lab. There's a simple cardiac angiography, we do the brain angiography. The same route, radial route or femoral artery route, we put a sheath, we do a angiography, we see the sheath is going up. So these are the three techniques. We normally do angiography, we see whether the large vessel, which large vessel gets occluded. We put a catheter, we aspirate the clot inside, we put a stent, we let it be there for a few minutes, clot get engaged in that stent, and we don't put a stent there. We retrieve that back under constant aspiration. So the clot which has blocked that artery, middle cerebral, ICA or whatever, I'm going to show the few cases just to better understand. So this is one of the cases. Sorry, I have placed one of my case which was atypical at your table. You can see that case also. I'm just mentioning the one of the first earlier case. This was a female, 73 years. She was a diabetic hypertensive patient. She came to LKW, means last non-well. That is more important in history taking. When patient was diagnosed was normal, and after that patient started having symptoms. Because golden hour is important if you have to give thrombolytic drugs. 4.5 hours are the golden hours. Golden hours, why it is golden? Golden means, to me it seems like as early as possible. If patient come within 4.5 hours, first hour is major important. As the time passes by, brain cells start dying and the infarct portion can progress. So this patient came in emergency after 2 hours of her last known well. She was having left side upper limb 0/5 power, lower limb 3/5. She was having left side weakness and she was dysarthric, unable to speak properly, and she had right side gaze deviation. So these clinical symptoms can give you a rough idea: gaze deviation, weakness, speech. That means patient is having large vessel occlusion. So based on that, what we have to do? After this, normally what we do? We normally do for the imaging. What image we have to do first? Basic first image is CT scan. Why CT scan? Because CT scan rules out first basic thing, bleeding. If at all it is a bleed, we should not thrombolize the patient. If it is bleeding, we should refer a neurosurgeon. I am a neurosurgeon. I will see. If at all a small bleeding is there, we can manage conservatively. If it is a major bleed, we can operate that thing also. But if CT scan doesn't show any bleed, then what to do next? We have to do angiography. So this is the angiography. Sorry. The upper one, sorry, the pointer is not working properly. Oh, sorry. Okay. So this is the angiography which is showing the right MCA is sudden cutoff. MCA is not visible from here. That means, and this is the angiography which we did in the cath lab. This is also showing the same thing. This is the internal carotid artery which becomes bifurcated into anterior cerebral and MCA. MCA is not visible. This is the major artery, large vessel occlusion is there. So we did mechanical thrombectomy considering major vessel, because her MRI was showing right MCA, small, white, you are seeing these are the patchy infarcts. That means patients still have some window period to salvage that whole MCA territory. Because MCA is just like from here till here. If whole MCA gets involved, patient will remain hemiplegic throughout her life. So the time window is still there. So for mechanical thrombectomy, the guidelines were for IV thrombolysis, the time window is 4.5 hours. So this patient also received the IV thrombolysis, but we have to drip and ship. We can't wait. We gave bolus dose and we ship the patient directly to the cath lab after because after this CT angio, which has ruled out, and we did the mechanical thrombectomy. It is showing this, the MCA territory start getting its blood supply back. So this is the video second post-op day, and this is the scan. The CT scan next day suggestive of this is the residual contrast, and we have salvaged most of the MCA. And patient start walking even. Second post-op day, and patient got discharged on 4th day. So this is the beauty of these procedures. Patient's stay is very less. It is less invasive, and the results are wonderful for such large vessel occlusions. Second case, this is the typical atypical case, which I have shown the images at your tables. So please go through this. Why it is important, this case, I am just emphasizing. Sometimes we have seen wake-up strokes. Patient slept well last night, morning wake up and see one half of the body is not working. Then what to do in such cases? Window is already out, IV thrombolysis cannot be given. So initially, what we used to give only dual antiplatelets. That is all we had initially. Nowadays, what to do? The spectrum has increased for mechanical thrombectomy. Initially, mechanical thrombectomy was to be done initially for 8 hours, 6 hours, 8 hours. Now with the different diffuse 3 Dawn criteria have come, they have expanded the spectrum window of mechanical thrombectomy up to 24 hours. For anterior circulation stroke like MCA or ICA territory, or posterior circulation strokes also. Posterior circulation, we have done cases up to 48 hours also. If not every case, but definitely we have to do certain more investigation like perfusion scans just to see how much area still is there to salvage. Basically, salvageable area we have to see. This is called as penumbra. Core means stroke was what has happened, that is stroke. In fact, rest surrounding area, we have to salvage that area. That area is important. Sorry, I have to be fast. So this case is a male, 66 years, diabetic hypertensive. He had a wake-up stroke, last known well time, nobody knows. So he came with the slurred speech, facial weakness, and ataxia. So NIHS score was, at the time of presentation, was very less, 5. So guideline says NIHS should be more than 6 for any thrombectomy. But we have to select the patient according to the deficits. We got done his angiography. Angiography at 2 marker levels are showing ICA is totally blocked from here. And second, MCA is not getting supply collaterals from opposite side that much. But still patient was having multiple shower of strokes. That means initially could be this one, the initial patient may be having the ICA stenosis, but suddenly patient may have collapsed this one. Or some thrombus or some stenosis must be inside the ICA, which causes embolic showers to the upside of brain. So in such case, we got done perfusion scan. This is the perfusion, CT perfusion. Now we can see here, this blue is showing hypoperfusion. That means this left half of MCA is not getting supply. And brain is still having lot of salvageable area, lot of penumbra area. So what we did, we got done, it took up the patient to the cath lab. We see this the opposite side carotid supply. This is showing supply to the initial ACA territory, but MCA is subtle collaterals, but there are not that much collaterals which can supply later on also. So on left side, this is ICA, which is totally occluded. We put a catheter, we aspirated, which we have seen there's a critical stenosis in the ICA. We did a minimal angioplasty and we took up the catheter up, we removed this clot. You can see the shape of the clot also, it is showing the bifurcation type of clot. That means it has blocked the ICA bifurcation and the clot has been formed from here and is migrated upside. And post-op scan is showing wonderful result. Patient score, patient maintained this thing, and patient discharged on 5th day. And considering the age factor, you can understand if we don't operate such patient, these patients may have stuttering strokes. Matlab, they can have strokes in later life, like in a day or 2 or 5 days. So this case shows the out of window for thrombolytic drugs. Mostly we refer the patient to take the IV thrombolytics and go and get the same patient would be all right. But such cases are out of window for IV thrombolytics. Definitely, if the post-op scan is okay, we can put the patient on dual antiplatelets after that. So next case is also same ICA bifurcation. Lot of clot burden. No IV thrombolytics will work in that because patient was already out of window period. We did the thrombectomy. This is the clot. And this is the stent which we normally put. This is the stent retriever, we say. This is the aspiration catheter. We normally put at the face of the clot. And we retrieve this catheter along with the aspiration, continuous aspiration, and we can see the clots are still there. One last case I want to show. Posterior circulation strokes. These are very misleading. Patient usually come with dizziness, ataxia, or locked-in syndrome, respiratory failure, lower cranial nerves involvement. So this was the male, 78 years, acute basilar artery occlusion. So this patient came in emergency after 6:30 hours of his last known well. He woke up in the morning. He was all right. He's told the relatives that he was having some aphasia difficulty. The relative says, it's okay, your age is that much, nothing would happen. But after watching for 6 hours, patient deteriorated. They came in emergency, patient went into respiratory failure and got intubated in emergency only. So his MRI was showing these patchy posterior circulation strokes. It is a cerebellar strokes. Patient, there was initially development in the one image was showing a little left side pontine infarct. It is also evolving little bit. That was early. So we took the patient to the cath lab, and cath lab angiography is showing total cutoff of basilar artery from the origin. This is the vertebral artery run. We can see basilar artery from proximal origins not showing. We took up the catheter. We did aspiration. Partial opening was there, but still there was a stenosis. We have seen in basilar artery, most of them, they are atherosclerotic diseases. If at all, we see the proximal occlusion. If at all the distal basilar artery is there, mostly it is embolic from the heart or vertebral artery. So considering the stenosis part, we put a stent here and we opened the vessel because we did 2 passes. It was partially opening, again recollapsing. So we have to put a stent. We normally put a coronary stent here. I did angioplasty, I put a coronary stent, and you can see the distal vessels were very well defined. One last case. This was a policeman who was working in our Rohini branch. He went to a holiday to Chennai. He's a South Indian, obese patient. He developed a stroke there. He became ataxic, difficulty in walking. So he went to Apollo Hospital, Chennai, where he took the thrombolytic drugs. He became all right. He was there for a day. Then because of the personal thing, financial issues, he came back here. When he came to our emergency next day, he became more drowsy. We got his scan. It was showing total basilar artery occlusion. It was just a faint on angiography, but on CT angiography, it was not visible distally. But definitely upper basilar artery was getting supply from anterior side. But still, you can see it's a very thread-like structure. So how can you leave this thing? If patient is deteriorating, multiple strokes in the posterior territory. So we took again the patient, and this was critical stenosis. We put a stent here. We did angioplasty, put a stent. This is a very critical area to put a stent, no doubt, because there are multiple perforators to the brainstem. So we do submaximal angioplasty and put a stent here. You can see the stent. It is a stent, and these are the stents on the CT. It is very well opened, and patient is still coming to my OPD. He is on diet plan now. He is doing his routines very well now. So I'm just emphasizing one thing. These all things we know, acute stroke management and everything. We also know the mimics. What are the stroke mimics? We have to judge accordingly, rule out hypoglycemia, rule out the history by taking seizures, migraine, if at all it is there. Or when in doubt, always do a scan. Sometimes I can say over
Dr. Jain,
investigation.
I think you overshot time a lot. Kindly wind up.
Yeah, sure. Sure, sir. So when in doubt, over investigate, because under investigation costs brain. So in last slide, I want to say, sorry. In a stroke, you are not just referring a patient, you are saving a brain. Every minute counts. It's you guys, you are the first and foremost critical person who remain in contact to the patients or families. So when in doubt, you feel such symptoms are there, refer patient to a stroke comprehensive care hospital. In Max, we have total stroke unit. We are doing mechanical thrombectomy, neurologist, neurosurgeons. I'm an interventionist, neurosurgeon too. So it's my request, and thank you.
Thank you, Dr.
Thank you,
Shailesh.
Dr. Shailesh, for excellent talk. Since we are running short of time,
sorry.
Question hour to be taken during the lunchtime. Anybody can ask you the question. With this, we close this session. Thank you so much.
Thank you.
Thank you, Dr. Shailesh, and I request chairpersons to facilitate our speaker, Dr. Shailesh, please. And the next topic is the metalless PCI, the role of DEB. And for this, I request Dr. P.K. Rastogi to deliver the talk, and I request Professor M.D. Gupta to chair the session, along with Dr. Ajay Agarwal, Dr. Vinod Mittal, Dr. Sumit Sahni, Dr. Alok Goyal, Dr. Mahesh Garg, Dr. V.K. Rastogi, and Dr. Jaideep Chugh. Welcome.
Good morning. This is a very interesting topic. We have been using a lot of stunts for almost 30 years now. Just to illustrate how we can lessen the burden of metal in PCI. It's a new concept. So drug-eluting balloon or sterilized angioplastic catheter coated with the anti-proliferative medication, paclitaxel or sirolimus, to treat cardiovascular disease by opening narrowed arteries while delivering drugs to prevent re-narrowing. The DAB, as is popularly called, leave no permanent implant behind, reducing long-term risk and effective for instant restenosis and small vessel disease. So what are the advantages? There is no permanent implant, leaves no metal scaffold, reducing the risk of late-stent thrombosis, the absence of polymer, resulting in absence of chronic inflammation. So we have two things in a stent, what we call as a scaffold, and other thing is the what we call as a polymer. So both the things are not there in a drug-eluting balloon. So there's a reduced DAPT require typically shorter periods of dual antiplatelet therapy because of the absence of polymer and the scaffold. Uniform delivery provides homogeneous drug distribution across the affected area, preservation of original coronary anatomy, particularly in small vessels and bifurcation lesion, does not distort the vessel per se, but there are limitations. There is no mechanical support, no scaffold, can lead to acute vessel recoil and requires a thorough preparation of the artery. So, drug-eluting balloon represent an enhancement of therapeutic repertoire of interventional cardiologists. Instant restenosis is a major limitation of balloon angioplasty. In plain old balloon angioplasty, which we call as popularly as POBA, restenosis occurred as a result of elastic recoil, ragged remodeling, and a new intimal proliferation. The proliferation and migration of vascular smooth muscle cells and myofibroblasts together with production of extracellular matrix resulted in instant restenosis. Drug-eluting stent reduce the rate of ISR, but stent thrombosis, restenosis do occur up to 5 to 10%, and it is up to 20% in long restenotic lesions. Okay. Sorry. Yeah. Sorry. Yeah. Sorry. So we have a patient, 57-year male, post PTCA to RC and LAD, acute inferior wall MI, presenting with the chest pain for last 6 hours. And we have ECG and echo evidence to reveal evolved inferior wall MI. Loading dose of Disprin, ticagrelor, atorvastatin was given. CAG revealed there's a mid-stent thrombosis 100%. The plan is to do PTCA to RCA. So mid RCA was 100% stent thrombosis. Pre-dilated with a 2 into 10 balloon, and we did POVA with the 2.5 15 NC balloon. And finally, we did a drug-eluting balloon 3.5 30 millimeter. So we have a successful stenting with a drug-eluting balloon and to RCA stent and almost a normal-looking vessel. So we have another patient, 48-year male, presenting with acute anterior wall MI with a very high blood pressure of 240, 130 millimeter. ECG has shown evidence to show infralateral wall MI. Patient was given a loading dose of aspirin, ticagrelor, and atorvastatin. BP was controlled with the metoprolol, amlodipine, IV, nitroglycerin. Patient has dyslipidemia, and ECG, we did a angio. LAD was 100% thrombotic occlusion. We did a pre-dilatation with 1.5, with a very small balloon 1.5, followed by a larger balloon of 2.5 millimeter, and finally we did a drug-eluting balloon of 2.5 millimeter, and you can appreciate is almost a normal-looking vessel, without using any stent. We have another patient, 78-year female patient, presenting very late, delayed presentation, anterior wall MI, non-diabetic and hypertension. Patient was in acute LVI. We stabilized the patient with IV furosemide and nitroglycerin, gave loading dose of Disprin, ticagrelor, atorvastatin. And we did angiography. Patient has critical disease of proximal LAD. Patient has critical disease of LAD and diagonal D2. And we did a sequential dilatation of LAD and D2 with smaller balloons, 1.5 and 2 millimeter. And did stenting of LADs and followed by drug-eluting balloon to side branch. So instead of using two stunts, we use a stunt in the main vessel and did drug-eluting balloon to the side branch. And we have a very good result, successful PTCA and stunt to LED and drug-eluting balloon to D2, which is a very large branch. So we have another patient, 67-year female, post PCI to LED almost 4 years back, non-diabetic and hypertension, presenting with unstable angina, symptomatic for last 10 days. Patient had a drug default for last 3 months, and again loaded with ecosprin, clopidogrel, and atorvastatin, and the angiography revealed very tight stenosis, almost 99% stenosis of the mid-LED TIMI2 flow. So we did a pre-dilatation of 2.7 millimeter with NC balloon followed by drug-eluting balloon. This is the drug-eluting balloon 2.5, 2.75, 20 millimeter, and you can appreciate there's a very good result without you putting another stunt again. We achieved the result of drug-eluting balloon. So we have another patient, 64-year male, old PCI to LED, and patient presented with a shock, had a heart rate of 40 beats per minute and 80 millimeter systolic. So patient has evidence of inferior wall MI with AV dissociation. So we preloaded the patient again with Disprin, ticagrelor, atorvastatin, and we have, to our surprise, a complete occlusion of RCA. And there's a large branch OM1 which is 99% stenosis. So we did a primary PTCA to RCA and stage PTCA to OM1. So with TPI we put and RCA closed with a whisper wire, proximal and mid RCA pre-dilated with 2 and 2.5 millimeter balloon. So the flow achieved in the RCA, and we put 2 stents in the RCA. And but you can appreciate this is a very large branch OM1, which was almost 99% stenosis. After pre-dilatation of the OM1, we did drug-eluting balloon to OM1 with 2.5 and 30 millimeter. And you can appreciate there is a very successful PTCA to drug-eluting balloon. So the OM1 is originating very close to left main, very close to left circumflex and LED. So we get a very good result without putting a stent to OM1. So another patient, 53-year female, 53-year male, post PCI to RCA and presented with acute coronary shunt. And patient had significant disease in LED and left circumflex, and RCA was 100% thrombotic occlusion. So this you can appreciate the stent was 100% blocked, and we did pre-dilatation of the 1.52 millimeter balloon and did a POBA with the plain balloon followed by drug-eluting balloon. And what we achieved is a beautiful result, almost TIMI3 without putting another stent in the RCA. And we have another patient, 45-year male, female, CAD, anterior wall MI, double vessel disease. This patient presented very late, almost 4 days after the MI, but patient continues to have VT and shock. So the continuous pain, VT, systolic blood pressure, 80, that is almost cardiogenic shock. So we decided to do what we call as a rescue PTCA in order to save the life of the patient. We did angiography. To our surprise, the LED was 100% thrombotic occlusion, and there is a very diffuse disease of D1, LCX, and RCA was non-dominant. So you can appreciate the size of the vessels, very small vessels, almost 1.5 to 2 millimeter. And the patient was very young, almost less than 50 years. So you can appreciate the LED is 100% thrombotic occlusion. Diagonal one is diffuse disease. Circ is also disease. So we did pre-dilation of 1.52 millimeter PTCA balloon, followed by drug-eluting balloon to LED without putting a stent, because the size of the vessel was very small, almost 2.5 millimeter. If you would have put a stent, it would have re-occluded. So this what we achieved. See, we achieved a TIMI3 flow. The patient blood pressure increased. We tapered the dose of non-adrenaline. The patient recovered, and patient is still attending to our OPD, recovering well. So we have a few trials, what we call as to support our drug-eluting stent. This is the first what we call as a PACOT ISR trial, paclitaxel drug-coated balloon in bare metal stent instant restenosis. It shows a significant reduction in late lumen loss as compared to POVA first, and the difference was alarming. Late lumen of 5 to 6 in comparison to 40. The demonstrated drug-eluting balloon leaves without leaving a stent. Effective superiority of drug-eluting balloon over POVA established concept leave nothing behind strategy. And what we have few more trials known as the PAPCAT trials. So we have another very famous trial known as the BALLO trial, which shows a prospective randomized comparing drug-eluting balloon with a drug-eluting stent in small vessel disease, which showed late lumen loss. DAB showed significantly lower late lumen loss as compared to drug-eluting stent. And Bell established DAB as an alternative to DAS in small vessel disease. We have another trial known as the basket trial, which shows that de novo lesions in small vessels can be used drug-eluting in small vessels. Yes. The key result, drug-coated balloon has a late lumen loss 7.5 as compared to 7.3 is a non-inferior to drug-eluting stent. So it confirms drug-coated balloon is equivocal to drug-eluting stent small vessel disease. Supports leave nothing behind strategy useful in small vessels, high bleeding risk, shorter DAPT. Paclitaxel coated balloons are non-inferior to second generation DAS for a de novo small vessel coronary artery disease at 12 months. So we have known as the SABRI trial. That is the role of SAB in PCI. Only 2-3 more slides. So that shows sirolimus angioplasty balloon for coronary instant results. Late lumen loss is 0.2, 0.3. And has a high device and procedural success. The clinical interpretation confirms sirolimus can be effectively delivered by a balloon technology, supports sirolimus eluting balloon in instant restenosis, small vessels, where stent avoidance is preferred, a high bleeding risk, shorter DAPT. So we have another trial, role of sirolimus eluting balloon in instant restenosis, again supports SAB in instant restenosis. So PAB versus SAB, mechanism and drug differences. So PAB, paclitaxel eluting balloon, is highly lipophilic, rapid uptake into vessel wall, but has a shorter drug residence time, strong antiprotective effect, but narrow therapeutic window. Sirolimus eluting balloon in comparison has a more sustained drug release, wider therapeutic window, potentially safer. Evidence in PCI instant restenosis. The PAB established evidence from trials like PACOCAT and PAPCAT trials, comparable to DAS in instant restenosis. SABRI trial and solution, ISR 4 trial, non-inferior late lumen loss versus PAB. De novo small vessel disease, PAB supported by basket small 2 trial and BALLO trial, non-inferior to drug-eluting in selected cases. So this is the last slide. So where do the drug-eluting balloons stand for? So instant restenosis is a gold standard used for drug-eluting balloon. It shines the most. Strong evidence from trials like PACOCAT and PAPCAT trial and SABRI trial. Why drug-eluting balloon? Because it avoids another metal layer, homogeneous drug delivery and late lumen loss. Small vessel disease from trials like BALLO and basket small 2 trial and prestige trial, rationale stunts in smaller vessels had a higher restenosis risk. DAB avoids another chronic inflammation and metal burden. So there's our advantage. De novo lesions, not routine but selected cases, best suited for non-calcified lesions. Good lesion preparation is required, but it is important there should be no dissection post-preparation. And there is a concept like leave nothing behind. High bleeding risk patients, like patients already on anticoagulation, patients already on mechanical valves, patients on thrombopulmonary embolism, or patients have a bleeding diathesis, or hemophilic patients which require a shorter DAPT. The answer is drug-eluting balloon, useful in recent bleeding and no need for anticoagulation. Bifurcation lesions is a very important concept. Stent for the main vessel and drug-eluting balloon for the side branch. And another important advantage, where you don't want to put in a long lesions, diffuse disease, long lesions, avoids what we call as the metal jacket of the vessel, and that's the advantage of the drug-eluting balloon. Thank you.
Thank you, Dr. Rastogi. Although we are running late, just one question from the audience, just one question. Any question? There is no question. Thank you, Dr. Rastogi. We'll wind up the session.
Thank you, Dr. Rastogi, for nice talk. And I request chairpersons to honor our speaker. And for the next session, I would like to invite Dr. Rahul Arora, Senior Consultant, Derma, for the guidelines on the management of the cutaneous allergy. And the chairpersons for these sessions are Dr. A.K. Sureka, Dr. Anupam Prakash, Dr. B.R. Chawda, Dr. Deepak Kothari, and Dr. Pritam Gupta. I request Dr. Pritam Gupta to chair the session. Dr. A.K. Sureka, Dr. A.K. Sureka, Dr. B.R. Chabda. Welcome, Dr. Rahul.
Thank you very much, sir. So from the most important organ of our body, the heart, now we move to the most beautiful organ of our body and the largest organ of our body, the skin. So I'm Dr. Rahul Arora, consultant dermatologist at Max Shalimar Bagh, and I'll be speaking on guidelines on management of cutaneous allergies. So allergies is a very broad term, and anything which presents with itchy, with rash, we consider that as allergy. And it may be exposure to the outside or something gone inside. And they are one of the most common conditions presenting in all our OPDs and are very, very troublesome to our patients as they affect the quality of life, their productivity. They lead to absenteeism from their, from their jobs. It may not be life-threatening, but it is, giving a high cost to our society and can be caused by multiple things. So the basket of cutaneous allergies is a complex immunological response. It's a hypersensitivity response to multiple things which may present as atopic eczema, urticaria, allergic contact dermatitis, airborne contact dermatitis. Even drug-induced allergies are part of all the broad spectrum of cutaneous allergies. And it is a global crisis, as you would have seen a lot of in all our OPDs. Be it any branch, the patient does present to you with some sort of skin allergy. Maybe it might be related to the drugs we have given or any other sort of infective process. And we are seeing year on year 18% rise in the level of skin allergies that we are seeing. And it could be attributed to overall change in our dietary patterns, the way we are living, the way we are polluting our environment, urbanization, industrialization. All these are contributing to the rise in allergies. So I've been asked to stick to my time. So these are the two Jay and Virus of the allergies panel, but we should not exclude the other ones, which is the drug rash and the contact dermatitis, which are as important as the first two. So urticaria and atopic dermatitis, these are the commonest presenters in our OPDs, and they are clinically differentiable very easily. As one would present like simple wheals, and the other would present like patches which are more persistent. So talking about urticaria, the typical presentation is a hive or an angioedema. So what is a hive? So hive is a clinical presentation which is typically characterized like this. There is a central swelling and there may be a central wheal surrounded by an erythema. Typically, they don't last more than 24 hours. So when we are confused about our diagnosis, if I ask the patient if it is lasting more than 24 hours, then it may not be urticaria. On the other hand, angioedema is presenting with swelling of any part of the body. It can be lip, it can be hand, it can be even say earlobe angioedema, or a penile angioedema can also occur. And usually they last more than 72 hours, a spot for spontaneous resolution. And they're usually associated along with itching, along with some that pain is also there. So there are some patients who will present only with angioedema, which is very rare, or it usually we get patients who have urticaria as well as angioedema or only urticaria. So we do classify it into acute urticaria, which is presenting less than 6 weeks. The importance is that this is sudden episode and mostly associated with infections or certain medications and generally have a good prognosis. And on the other hand, there is chronic urticaria, which is the history is usually more than 6 weeks. And it is associated with something gone wrong inside the body, which may be due to some sort of systemic exposure or some sort of autoimmune issue. So this is the main division between acute and chronic urticaria. Then the other division is the spontaneous urticaria, which may occur without any identified trigger and is usually associated with some sort of autoallergic or an autoimmune pathway gone wrong. Whereas inducible urticaria, patient will typically give some history, like when he scratches, there is a wheal, or when he takes bath, there is a wheal, or there is a cold exposure, there is a wheal. So the overall prognosis and the management of the two remains different, although we see in up to 30 to 40% patients, there is a coexistence of both inducible as well as chronic urticaria. A detailed medical history is what we start with the overall assessment of individual wheels, their diurnal patterns, there any history of food intake, any history of any sort of changes, recent changes, and the the lesions are very easy to diagnose on cutaneous examination, but need to ensure the
particularly as it's very usual किसी केस पे अगर आप relate करें तो easier to explain. देखिए, over the years fundamentals have changed. Fundamentals have totally changed over the years because किसी जमाने में था adipose tissue inert माना जाता था, but आज जैसे आपको अभी बताया गया, adipose tissue is a very active hormone, secretor. जो inflammatory cytokines बनती हैं adipose tissue में, they are very important for lot of things and they are very deleterious to the body. So adiposity is not only fat tissue, it is lot of other things coming along with it, and that is in vital the missing link in all the puzzles today. तो ये सारी चीजें जो हैं adiposity के साथ साथ आती हैं. Bad quality of life, bad everything, bad cardiac risk, bad everything comes along with adiposity. So adiposity is something which is very bad, and we must really understand कि कोई भी काम अगर अच्छा आपको achieve करना है तो सबसे पहले adiposity को tackle करना पड़ेगा. So any drug which tackles adiposity is really a wonderful drug, and adiposity comes along with various bad things. They are in combination. जैसे एक पुरानी कहावत है कि beauty and brains don't come together. एक आदमी था, बल्कि उसकी एक ही वेरी ब्यूटीफुल वाइफ, एक्सेप्शनली अट्रैक्टिव वाइफ. तो एक बार वाइफ ने उससे पूछा, भाई उसकी वाइफ जो अट्रैक्टिव तो थी लेकिन उसका अपर स्टोरी खाली था, नो ब्रेन्स नहीं थे, खाली थी, बिल्कुल डल थी. तो एक बार उसने पूछा, भाई तुमने ऊपर वाले ने तुम्हें इतना अट्रैक्टिव बनाया लेकिन तुम्हारे ब्रेन्स तो है नहीं, ऊपर तो खाली है फर्स्ट स्टोरी. तो वाइफ बोली, अगर मेरे ब्रेन्स होती मैं तुमसे शादी नहीं करती. So it's a combination. Beauty, brains usually don't come together. Exceptions are there of course, but ज्यादातर ऐसा होता है. तो एक केस के बारे में हम लोग बात करते हैं. This case, Mr. Kumar, hypothetical case, 60 years, HbA1c baseline 8.3, BP 140/86, fasting sugar 150, postprandial 238, weight 86, and mean duration of diabetes is 12 years. So आप देख सकते हैं कि इस 60-year-old male with history of diabetes since 12 years, and he is on metformin 500 BD, DEPA 10, glimepiride 2 BD, and basal insulin 38 units basal insulin. So now you can see why ABC is so important. ABC is adiposity-based chronic disease. Today I told you that we consider adiposity as a disease. किसी ज़माने में adiposity was a cosmetic problem, but today, you know, in later textbooks now we are going to have a chapter on adiposity. Because adiposity, our textbooks don't cover normal things; they only cover diseases. So in times to come, we are going to have a separate chapter on adiposity, because adiposity today is definitely a disease. So in this particular case, we are talking of chronic diabetes for 12 years. He is on multiple OHAs, basal insulin. This just indicates difficult to control progressive disease, and it shows beta cell failure. You know, over the years, beta cell always fails. Presence of hypertension and dyslipidemia further complicates the case and is high risk of cardiovascular complications. And challenges in glycemic control are due to insulin resistance, progressive beta cell failure, and limited physical activity due to osteoarthritis. Risk of hypoglycemia due to insulin and sulfonylurea limits dose titration. If uncontrolled, you're going to have risk of MI, stroke, microvascular complications, and you have a lot of morbidity and mortality. So, you know, today obesity, I told you, is very, very important. Today, obesity is a disease. We live in a strange world today. You know, the poor walk miles in search of food. They're hungry, they want food. They're walking miles in search of food, while the overfed, they're walking miles to get rid of obesity. So it's a paradox today. Now, what are the medications available? What are the options we have now? First, we can increase the basal insulin doses. This you can increase the glycemic control, but when you increase the basal insulin, you're going to have a chance of taking the hypo. You take a risk of hypo. And plus more insulin means more weight gain. And often that will limit your problem. Another option is to add bolus insulin. This can improve the post-meal sugars, but again, you raise the chances of weight gain and hypo. You can switch to premix, but premix has its own problems. It's very difficult to titrate premix to the accurate standards we really want. The standards of fasting and PP we want, it's not so easy to control on premix. Another option today we have in hand is tirzepatide. What happens when you give tirzepatide? It's a once weekly injection that lowers HbA1c. It also lowers the body weight. It lowers the blood pressure, and you hardly have any no kind of hypoglycemic risk. That is very great that all these things you're getting the cake and eating the icing also, everything is there. And this is a great drug. This can be used. Okay. Why tirzepatide? Another. See, when tirzepatide was added to insulin glargine in patients with type 2 diabetes with inadequate glycemic control, patients achieved HbA1c reduction of nearly 2.23 to 2.59 with 5 and 15 milligram in 40 weeks. A great percentage of patients receiving 5, 10, 15 met the HbA1c target of less than 7. Patient also achieved a significant body weight reduction. With 5 mg, it was minus 6.2 kg. With 10 milligram tirzepatide, it was 8.2 kg. And 15 mg tirzepatide gave minus 10.9 kg compared to placebo. There were significantly improved fasting lipid profiles, decreased TGs and VLDL, and increased HDL, suggesting amelioration of overall cardiometabolic risk. So what is important is we want to improve the quality of life and we want to make the patient a better cardiovascular risk. I mean, that's very important. And unless we do that, there is no point, beating about the bush. The journey so far, you can see when he was put on tirzepatide, you can see very clearly what is happening here. And things were improving very fast. And patient continued with insulin glargine and sulfonylurea. But when you start tirzepatide, you may have to reduce the dose of these sulfonylurea and insulin later on. But he didn't achieve a target of, less than 7, what we really wanted. So treatment plan was, our target was to achieve HbA1c of less than 7. Patient was initiated on tirzepatide 2.5 subcutaneous once a week for 4 weeks. So dose of 2.5 is the treatment initiation and not intended for chronic benefit. You have to start to sensitize the patient. You have to start with 2.5 milligram once a week. After 4 weeks, the dose was escalated to 5 milligram once weekly. And further escalation to higher doses depends on the treatment response and how the patient tolerates the drugs. Maybe in some cases, we may have to escalate very slowly. Maybe we have to go one step in between 5 and 10. There's another dose, we go for that. We go for 7.5 maybe. Recommended maintenance dose are 5, 10, and 15, but this is not mandatory. You can, depending on the patient's, what the patient tolerates and what the experience of the doctor is, all depends on the patient's tolerability and the doctor's experience. You can change the dose accordingly. Other adjustments of doses, if you get hypos, then you have to reduce the dose of basal insulin or sulfonylureas. Drugs which can cause hypo, their dose may have to be reduced. Nothing has to be done with tirzepatide, that continues with the same dose. Lifestyle intervention, of course, there are pillars of treatment all the time. They have to be continued all the time. Reduce calorie diet, approximately 500 gram kcal per day, and increase physical activity, minimum 150 minutes per week is recommended. That you all know, nothing great about that. Outcomes, so you can see the graphs, you can see the weight coming down right from 86 to 77, and you can see the HbA1c coming down from 8.3 to 6.4. So he had fantastic results all over, and lab parameters changed drastically. You can see HbA1c changed from less 6.5, and the ideal one 8.3 to 6.4, and fasting sugar came down to 116, postprandial came down to 146, LDL was down to 76, HDL got raised to 45, TGs were now 131, and blood pressure was 134/82, very nice, and glargine dosage was down to 26, right from 38, and glimepiride doses were down from 2 milligram BD to just 2 milligram OD. So weight was also down from 86 to 77. So all things said and done, you can see the patient is doing very well and everything good. And the main thing I told you today is weight is very, very important. And if you can control the weight, it's you can do a lot of miracles in one day. Weight was underestimated. Over the years, weight, of course, was a problem. But today, notice the weight is, obesity is the root of everything. If you can get rid of this obesity and weight, we can control a lot of things. In fact, there are more than 200 parameters in the body which can change if you reduce the weight. So over the years, मतलब अब ज्ञान बढ़ते बढ़ते तो आया है, मतलब पहले जमाने में वेट तो खराब माना जाता था, लेकिन इट इज ए हेल्दी साइन. पहले तो कहते थे खाया पिया घर का है, बड़ा अच्छा है, हेल्दी है, अच्छा माना जाता था. बट नाउ वेट इज वेरी बैड, सो ओवर द इयर्स ज्ञान हैज मेटामॉर्फोज्ड. जैसे कि आपको पुरानी कहावत चलती थी, तो एक बच्चा कह रहा था स्कूल में कि बचपन में जाना था कि गर्मी ऊन में होती है, स्कूल में जाना कि गर्मी जून में होती है, पापा ने कहा कि गर्मी खून में होती है, लेकिन बाद में पता लगा तो गर्मी तो पैसों की जुनून में होती है। एटीएम के उसमें एसी लगा होता है हर समय, जहाँ पैसे होते हैं वहाँ गर्मी होती है। तो बच्चे का भी फंडा बदल गया ओवर द इयर्स, क्या क्या कैसे कैसे। तो इस तरह ओबेसिटी का फंडा भी चेंज हो गया ओवर द इयर्स। एंड टुडे वी नो ओबेसिटी इज द रूट ऑफ एवरीथिंग। बिना ओबेसिटी अगर कंट्रोल कर लीजिए, एनी ड्रग विच कैन कंट्रोल एंड लिमिट ओबेसिटी, दैट इज अ वंडरफुल ड्रग, एंड उससे बढ़िया कोई चीज नहीं हो सकती। एंड अपार्ट फ्रॉम ओबेसिटी, tirzepatide controls the sugars also, HbA1c also, lipids also, everything it is controlling all over. The fatty liver also, all the things it's controlling. The microvascular changes, the complications. So what that is the main thing which is happening. So you can see the summary results of Mr. Kumar. Tirzepatide, you had a wonderful HbA1c from 8.3 to 6.4. Weight was a wonderful 77 kg now from 86. Triglyceride again very desirable. Blood pressure again down to very reasonable limits. Okay, so this was very nice. And we conclude that the patient achieved substantial reduction in HbA1c and blood sugar levels, indicating improvement in glycemic control, significant reduction in body weight, decreasing from 86 to 77, improvement in lipid profiles and blood pressure indicated low risk of cardiovascular complications, and all the cardiometabolic improvements were associated with enhanced physical activity and good quality. So main thing was the reduction in weight was a turning point to change everything. So in fact, tirzepatide is a one-stop solution and very simple solution to a complex problem. So how can you give simple solutions? मैं आपको उदाहरण बताऊं, एक डॉक्टर कपल था, दोनों वर्किंग थे, उनके एक मेड काम करती थी। द मेड वाज वेरी इंपॉर्टेंट, सारा काम करती थी वो। तो एक बार मेड ने छुट्टी के लिए बोला कि मैं जाना चाहती हूँ 5 दिन की छुट्टी के लिए। तो वाइफ बोली, भाई तुम 1 हफ्ते के लिए जाओगे तो काम कौन करेगा? डॉक्टर साहब को नाश्ता कौन देगा? उनके कपड़े प्रेस कौन करेगा? उनको कौन सफाई करेगा? कौन करेगा? तो मेड बोली, भाई ये तो बड़ा मुश्किल काम है, मुझे तो जाना है। तो बोले, मैं सोल्यूशन बताऊं, मैं डॉक्टर साहब को अपने साथ ले जाती हूँ वेकेशन पे। सो शी वाज अ ब्यूटीफुल मेड, तो यंग थी। तो मतलब इट्स अ सोल्यूशन। तो आप सोल्यूशन क्या है? आपको बढ़िया सोल्यूशन दीजिए, एंड कॉम्प्लेक्स प्रॉब्लम का सिंपल सोल्यूशन। तो एक ओबेसिटी इज अ वेरी कॉम्प्लेक्स प्रॉब्लम, एंड कपल्ड विद ओबेसिटी, कपल्ड विद डायबिटीज, कपल्ड विद डिस्लिपिडीमिया, कपल्ड विद एवरीथिंग, इट बिकम्स इवन मोर कॉम्प्लेक्स। अगर उसको एक सिंपल सोल्यूशन एक कॉम्प्लेक्स प्रॉब्लम को निकालना है, सो दैट वन वर्ड इज tirzepatide. I think that's it.
Thank you, Dr. Rajiv Kishore. One point of information, and I must tell you, Dr. Rajiv Kishore is the son of leading #1 male gynecologist of India, Professor Naval Kishore at Agra. Give him a big hand. I request our chairpersons to honor our speaker. And for the next session, in the meantime, I invite Dr. Manish Agarwal, Director, Chest Diseases and Intervention. Dr. Manish Agarwal, Principal Director, Chest Diseases and Intervention, Pulmonologist, for the next session on diagnostic dilemma in recurrent pleural effusion, the case discussion. And for this, I invite Dr. Manish Prabhakar, Dr. Sanjay Raina, Dr. S.K. Nagrani, Dr. S.K. Bansal, and Dr. Sunil Masan to chair the session, please. सब बाहर है, सब लोग बाहर खा। आपका डॉक्टर राजीव दीवान, डॉक्टर राजीव दीवान, डॉक्टर आई.एम. चुग, ठीक है, करेगा चाहिए, and Dr. Bakshi, please.
So, very good afternoon. I know it's the food is served, and probably we are all hungry and want to go to have our lunch. So, well, I'll try to finish it as soon as possible, and consider this as an appetizer. I could have bring a more, complex case like a airway stenting or probably tumor debulking, but then I thought why not discuss something which is as common as a pleural effusion, and probably it can invoke more questions and more, thought-provoking things. So this is a 73-year-old man who is a moderately built, never smoker, has diabetes and hypertensive, and he was admitted to hospital on 3 occasions, starting from mid of May to the mid of June. All 3 admissions were like they were of 7 days, and the difference between each admission was roughly around 7 days. So on first presentation, he had fever and he had cough with expectoration, shortness of breath, decreased oral or intake, but there was no night sweats, no weight loss. Vitals were more or less okay, except for that there were diminished breath sounds on the right side, and chest X-ray was suggestive of right pleural effusion. My apologies, I could not procure that film, but yeah, so it had right pleural effusion, and relevant investigations were echo were normal, and ultrasound whole abdomen showed hepatomegaly with grade 1 fatty liver, cholelithiasis, mild prostomegaly, and moderate right pleural effusion. So a CT chest was, ordered, and it revealed a large multiloculated right pleural effusion with associated compressive atelectasis and lobar collapse, right parahilar lung mass, encasing the intermediate bronchus, highly suspicious for primary bronchogenic carcinoma. And then there were some mediastinal, hilar, and supraclavicular lymph node, suspicious for nodal metastasis, and a right upper lobe subpleural nodule. So this was the CT scan. Primarily, it had a right pleural effusion with a right intermediate compressive lesion. So what could be the provisional diagnosis? Right pleural effusion, elderly male, non-smoker, with fever and cough. So probably TB would be the first thing that would come in mind, if at all. So next step would be to aspirate the fluid. But when you look at the CT scan, it says suspicious for malignancy. So that was the whole crux why this patient become important and a little exciting. So next step could have been doing a bronchoscopy, or should we do a pleural aspiration, which may be diagnostic or therapeutic, or should we directly go for EBUS, or should we directly go for thoracoscopy? So we thought of doing a bronchoscopy first. Bronchoscopy would rule out any endobronchial growth. In case you want to put a pigtail, if there is an endobronchial growth, so it would be a trap lung, because you're not addressing the endobronchial growth, you have taken out the fluid from the pleural cavity. So there is a space which is there, and then it would be occupied by, if you, air, because वहाँ पे एक vacuum create हो गया. So we did a bronchoscopy first, and it showed no endobronchial growth. Right intermediate bronchus was compressed, but it was extrinsic compression. So next choice was a diagnostic pleural tap, and we took out only 100 ml, although he was dyspneic. But then the thought process was, since the CECT was suggestive of malignancy, in case it does not turn out to be, tubercular, I mean, the clinical history was more in favor of TB. There was fever, non-smoker patient. So we did just 100 ml of tap to see if it is non-tubercular, then we can plan for thoracoscopy to see if we can find some malignancy. But, as expected, the ADA turned out to be 50. It was exudative lymphocytic, and all, cell block cytology for malignant cell was negative. And even the microbiology for TB was negative in terms of his gene expert in pleural fluid or AFB direct smear. Anyway, so lymphocytic exudative, high ADA, TB microbiology negative, cytology cell block again negative. But is high ADA good enough to start with ATT? And I would probably say most of us would agree for that. Anybody who does not agree? So anyway, so in a high prevalent TB states like India, lymphocytic exudative, high ADA, negative malignancy workup, probably we are justified in giving TB treatment, especially if somebody is running fever. So we did a pigtail to relieve the shortness of breath, and the patient was discharged on ATT. But again, he presented 7 days later with his second admission. Again, he had breathlessness, severe abdominal pain, recurrent vomiting, cough, and probably he had some cholelithiasis as well, because bilirubin was little raised, but this transaminitis was not very significant. But anyway, we got the X-ray done. Again, it had right-sided effusion. Again, a CT scan was requested because it's generally little rare that you drain a tubercular fluid and then it come back again in a 7 days time. And if we consider our previous CT, it had suggested some sort of a malignancy. So again, a CT test was done, which shows new right side hydropneumothorax compared to previous CT. Probably the hydropneumothorax was because we took out the pigtail, some air might have just tracked into the pleural cavity. And then there was persistently heterogeneous enhancing right parahilar mass, encasing and narrowing the intermediate bronchus, persistent mediastinal and right hilar lymph node, and imaging findings were highly suspicious for malignant etiology. Although if you see previous, pleural fluid, that was absolutely negative for your malignancy, and it was more in favor of TB as the ADA was very high. So with malignancy, your ADA is generally around 10 to 12 unit per liter. And it says no significant interval change in the size of primary mass or lymph node compared with the previous scan. I will not go into the CT pictures to save some time. So again, here we have a patient who has had a recurrent pleural effusion on ATT. So the causes could be, it could be a paradoxical response, and patient might not be adherent to treatment. We probably is dealing with a drug resistance tuberculosis, or it could be different etiology. As I said, probably we are dealing with a coexisting disease in terms of malignancy. But the dilemma was whether to continue same or advanced workup is needed in terms of thoracoscopy or EBUS. But then it was decided, let's not do much. Patient was 73-year-old, and he was happy कि भाई मेरे को TB है और let's go ahead with TB. So we decided to aspirate to relieve him of his shortness of breath. And again, we sent pleural fluid for cytology and other workup. Again, ADA was high. It was lymphocytic exudative with high ADA. Again, the microbiological, for TB was negative. Cell block cytology was again negative for malignancy. So at least we were little sure कि well, it's again high ADA. So probably we are dealing with TB. So this is pre and post therapeutic tap X-rays. And again, patient was discharged on ATT. He presented again in a short span of 3 to 5 days. Again, he had cough, dyspnea, shortness of breath, generalized body ache. And relevant investigation shows again right-sided pleural effusion, which is again a very rarity in cases of TB, where you have drained it twice and then they keep on repairing, and especially in a very short span of 4 to 7 days. So recurrent pleural effusion. What next? Should we go ahead with thoracoscopy or EBUS? We thought probably the larger, etiology was pleural effusion, and it's better to do thoracoscopy where we can see directly at the pleura. If there is some nodules, we can do biopsy, and simultaneously we can put a ICD tube to relieve him of his shortness of breath. So thoracoscopy was planned in view of undiagnosed recurrent lymphocytic exudative pleural effusion, though the ADA was high. We generally, with high ADA, we don't do thoracoscopy. We directly put them on ATT, as we have a high TB index here in India. So thoracoscopic parietal pleural biopsies were taken, and it was sent for histopathology, imprint smear, AFB smear, gene expert culture, etc. Post thoracoscopy, we inserted a 28 French ICD tube, and around 2 liters of pleural fluid was drained. But when we did thoracoscopy, we actually could see some nodules on the parietal pleura, and we were like very happy कि भाई इस बार तो diagnosis मिल ही गया है. We have been running around TB and giving him ATT, और समझ आ नहीं रहा था शायद पक्का ही हमें मिल गया है. So we took biopsies of these nodules, and we generally, what we do when we take biopsies, we just scrap it over a slide so that the cells falls on the slide. Biopsy will take 3 to 5 days to come. Slides को तो आप immediately stain करके देख सकते हो. So imprint cytology was done, and it comprises of sheets of lymphocytes along with few atypical cells with high NC ratio. reactive neoplastic necrosis present. So the suspicious was more now कि भाई अब तो malignancy मिल गई, imprint cytology भी atypical आ गई. और मैं इसी एक्साइटमेंट में पेशेंट के पास गया और कहा कि भाई अभी तक हम एटीटी दे रहे थे, आल्दो हमें लग रहा था कि शायद मेलिग्नेंसी है, और पर आपका हर बार एडीए पॉजिटिव आ रहा था, पर इस बार तो मिल गया, तो अब हम पेट करा लेते हैं. तो वी गॉट अ पेट डन, बट पेट में अगेन वी हैड अ प्राइमरी राइट पैराहाइलर मास कॉजिंग ब्रोंकियल ऑब्स्ट्रक्शन विद रीजनल lymph node metastasis, query involvement, and there was some suspicious right pleural involvement and post-obstructive collapse or consolidation. But can PET differentiate malignancy from TB? Probably not, because दोनों के दोनों uptake FDG के होते हैं, and it is very, very difficult to differentiate malignancy with TB. But the surprising and the good thing was there was no other, distant metastasis. But if it's a malignancy, we are dealing with malignancy, if this effusion is malignant, well, probably it is, stage 4 malignancy. But that was our early enthusiasm. We did not wait for the histopathology. And when the pleural biopsy histopathology came, it turned out to be granulomatous lesion. Section consists of well-formed and merging epithelioid granulomas along with Langerhans giant cell with scanty caseating necrosis, suggestive of TB. And again, AFB smear tissue was negative, gene expert was negative. So जो हमें नोड्यूल देख के एक्साइटमेंट हो रहा था कि इस बार तो हमने malignancy पकड़ ली है, it falls on its foot and it turned out to be granulomatous lesion. But again, CT was, the parahilar shadows, it remained there. तो हमारे मन में था यार कहीं ना कुछ तो मिस हो रहा है. और मतलब आप टेरिटरी केयर हॉस्पिटल में बैठे और मिस कर जाए और अगली बार पेशेंट आए और कहे कि डॉक्टर साहब आपने वर्कअप पूरी मेहनत नहीं की, तो हमने उससे ईबस के बारे में डिस्कस किया. It was discussed with the patient and family. We also explained them कि radiologically, PET-wise, it seems more like a malignancy than TB. But जितनी बार भी हमने आपकी biopsies भेजी हैं और कम से कम 3 times we sent his, pleural fluid for cytology malignant cell. Every time it was negative, and it was more in favor of, TB. ADA was always high on 3 occasions. But microbiologically, we could not, make a firm diagnosis of TB. तो हमने उन्हें कहा भी ईबस हमें करना चाहिए. But then, as I said, they discussed it with me and they said कि डॉक्टर साहब यदि ये malignancy है, कैंसर है, तो फिर क्या, कौन सी स्टेज? So I said, then it should be stage 4. तो उसने कहा डॉक्टर साहब stage 4 73 की एज है, क्या करना है, आप ना टीबी का ट्रीटमेंट दो, we are happy with that. तो so given the lymphocytic exudative effusion, high ADA, negative pleural cytology on repeated occasions, and the high prevalence of TB, in our setting, after detailed counseling and shared decision making, we ended up giving him ATT with a close follow-up and reassessment. So this was post-thoracoscopy. We should discuss the limitation of the case. Again, the microbiology confirmation could not be obtained despite repeated pleural fluid and tissue biopsy. EBUS TBNA could not be performed because of patient preference after informed discussion. Diagnosis relied primarily on a clinico-pathological correlation rather than microbiological correlation. On 3 or 4 occasions, we were not able to grow or see AFB, and even the gene expert was negative. Coexisting malignancy, while considered unlikely, cannot be absolutely excluded without interval imaging, and follow-up CT confirming complete resolution of the hilar mass is still pending. It's been a month only. Learning point were that radiological appearances can strongly mimic bronchogenic carcinoma, especially in pleural TB. Negative pleural fluid cytology, gene expert, AFB smear, they does not exclude pleural TB. ADA and PET-CT are, they are supportive investigation, but neither replaces tissue diagnosis. And the most important lesson from this case is not that the patient had tuberculosis, but that the tissue is the issue. In recurrent undiagnosed exudative pleural effusion, timely pleural biopsy should not be delayed, and early medical thoracoscopy is the investigation with the highest diagnostic yield. At least we were sure कि हमने granulomatous तो मिला ही हुआ है हमें, malignancy तो हम establish नहीं कर पाए. Then I speak to this patient on different occasions. So I asked him to get a X-ray done on 27th of June, and then 18th of July, yesterday itself. And patient is healthy, asymptomatic, tolerating ATT well. And the plan is to get a CT done after a month and see what happened to that parahilar shadow, and then take the case from there. So the case is open for discussion and somebody who wants to roast me first, I'm okay with that.
Thank you, Dr. Manish, for
Sir,
the
we did ask for AFB culture on pleural biopsy. Earlier with pleural fluid, we did get AFB culture. It were all negative, but pleural biopsy में ना सर AFB culture हमारा रह गया. Gene expert और AFB smear हमने करा वो negative था. I asked yesterday कि भाई culture में क्या आया, तो उन्होंने कहा culture तो लगा ही नहीं pleural fluid. No, I am sure. Without any doubt, we should have got a pleural biopsy culture done. But I don't know how it रह गया लिखते हुए. Sorry, sir? Yeah, for all tissue, you have to centrifuge the sample and then only can culture be processed. But I don't know, हमारा हर चीज में ऐसा कि smear gene expert culture जाना ही जाना है. But for some reason, for this patient, I'm not sure. But anyway, we are already in 1 month down the ATT. Probably in next month, we will get a CT done. If there is a right parallel mass, we'll push him for EBUS.
Thank you, Dr. Manish, for an excellent lecture. As a physician, I have one question for you. The physicians face the biggest problem in CKD patients. CKD patients present to us with recurrent pleural effusions. Sometimes the nephrologists say that it is not fluid overload. The fluid is traditionally transudative. All things are negative for TB. And then at the end, when the fluid is not treated, ATT is started. So what should be an approach in a recurrent pleural effusion in the CKD patient?
CKD, most of the time your AD is negative. Most of the time, low AD. But if your clinical matches, but in a right clinical scenario, as I said, in a high TB prevalence country like India, and if your clinical suspicion is high, you probably is justified in giving ATT. Otherwise, you can resort to thoracoscopy. We can do biopsies if something is there, and then we can establish a histopathological diagnosis.
Thank you, Dr. Manish. With the paucity of time, the next question answer can be taken over the lunch time. Thank you so much.
Thank you, sir. Thanks for a patient hearing.
Thank you, Dr. Manish, for a nice talk. And I request Master of Ceremony, Dr. Rakesh Gupta, and our President to take up the stage for inauguration and further proceedings. Thank you.
Thank you, Dr. Malhotra.
And in the meantime, I request our chairpersons to honor our speaker.
Thank you, Dr. Malhotra. The arrangement is going on for the inauguration ceremony. Before that, we want to have some results of the poster presentation and papers and the quiz. So I request Dr. Rupak Wadhwa to name the name and award them the prizes.
Thank you, sir. First of all, a very warm good afternoon to everyone. So first of all, we would like to invite Dr. Suresh Kumar sir on the stage, Dr. Richa Diwan ma'am on the stage, and Dr. Mukesh Bhatia sir on the stage to felicitate the students who have given their valuable insights on various paper presentation, poster presentation and quiz respectively. Please give them a big hand. I want all my PG students to be here. Are they? Yes, they are seated. So, first of all, Dr. Jha, you should felicitate Dr. Richa Diwan ma'am, sir. First of all, we would like to announce the name of students who have won in the best paper category. First prize goes to Dr. Suraj. So he would be receiving a certificate of appreciation as well as a cash prize of rupees 3,100. Maybe. Second prize goes to Dr. Shashank. there is a certificate of appreciation as well as a cash prize of rupees 2100. The third prize, it's a tie between Dr. Mansi and Dr. Sahaj Sethi. So please be on stage, Dr. Mansi and Dr. Sahaj Sethi. Dr. Sahaj Sethi, please. Third prize, there is a tie between both of them in free paper presentation. So around a grand. Now I would like to invite all those who have participated in the quiz. So all the PGs who have participated in the quiz. Please be together on the stage for the quiz. 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 A big hand of applause for all those who have participated in the quiz. A photograph. First, a photograph, please. And now we are going for the poster presentation. Maybe. The first prize goes to Shalini Sharma for poster presentation. Please be on stage. For the poster presentation, I would like to call upon the judges for the poster presentation, Dr. Rajiv Diwan and Dr. Rajiv Gupta, sir. They were the judges for this poster presentation. So the first prize goes to Dr. Shalini Sharma. Second prize goes to first prize, Shalini. Shalini has received the prize for the poster presentation. Thank you. The second prize goes to Dr. Sahaj Singh Sethi for poster presentation. Dr. Sethi, Dr. Sahaj Singh Sethi. Second prize, he will be receiving a certificate of appreciation as well as rupees 2100 in cash. The third prize is again a tie for poster presentation. It's for Dr. Marisa and Dr. Mansi Sharma. They will be receiving a certificate of appreciation as well as a cash prize of rupees 1100 each. Marisa. So please give them a big round of applause. Thank you for participating.
Acha, before the inauguration, there is a lucky draw by the sisterly company. Le aao jaldi. I request Dr. Rakesh Gupta. मैं निकालू लो first prize these are same prizes for all the 5 persons. Dr. Sunil Khetarpal लो सर आगे डॉक्टर छाबड़ा आप दे दो
डॉक्टर छाबड़ा से दिलवाओ डॉक्टर छाबड़ा से
सेकंड निकालो
डॉक्टर बलदेव छाबड़ा
Dr. B.R. Chabra. All right, good, sir.
डॉक्टर परवीन
Dr. Praveen Bhatia.
हाँ जी हाँ जी डॉक्टर परवीन भाटिया इज आल्सो देयर
चौथा
शेक इट
अरे शेक हो गया.
डॉक्टर अशोक गुप्ता
डॉक्टर अशोक गुप्ता आइए. पांच हो गया.
चार एक रह गया लास्ट
अशोक गुप्ता जी कहाँ है?
डॉक्टर राजेंद्र
डॉक्टर अशोक अग्रवाल तो नहीं
बंसल.
है? अशोक अग्रवाल तो
डॉक्टर आर.पी. बंसल आगे आ रहा है. डॉक्टर आर.पी. बंसल नहीं है.
अशोक गुप्ता जी आ जाओ.
चलो
अगला बुलाने का
अगला निकाल लो.
डॉक्टर अनिल हांडा
डॉक्टर अनिल हांडा प्लीज. अच्छा आर.पी. बंसल आ गए. सॉरी.
अच्छा
आइए खाना खा रहे हैं सर. आइए. चलो हो गया. आर.पी. बंसल को दे दो. हांडा साहब को छोड़ दो. पांच है तो दे देना.
मैं दे दूंगा
चलो डॉक्टर हांडा को भी बोनस में मिल जाएगा, कोई दिक्कत नहीं. मिलेगा सर मिलेगा.
ऊपर तो आ जाओ, एक बार ऊपर आ जाओ, पता लगे आपको मिला. आओ मैडम आ जाओ. आप आओ ना वैसे आप वहां से मिलेंगे.
बस नाउ आई हैंड ओवर द माइक टू डॉक्टर राकेश गुप्ता. इज द मास्टर ऑफ सेरेमनी फॉर द इनॉग्रेशन. डॉक्टर राकेश गुप्ता सर. चलो हो गया.
मैं आपको क्लिनिक पे लेके आऊंगा. हाँ जी पक्का पक्का.
Okay, good afternoon, everybody. I'm standing in between the lunch and the inauguration ceremony. I'm absolutely delighted and thrilled to welcome you all to this North Delhi Physician Forum conference, which is unique in its own way. Dr. Anil, which is unique in its own way, connecting people together in a place to meet, greet, and welcome each other. And the best part of these conferences is to remember your past events, which you spent with your colleague way long back. I would like to extend a warm welcome to our guests, speakers, and everyone who traveled here to participate in this particular conference. Before we dive in this inauguration ceremony, I want to take a quick moment to express our deepest gratitude to our sponsors and the team of entire North Delhi Physician Forum who made this event possible. To begin with, let me pleasantly welcome the leader who has redefined what is possible for us, a champion of integrity, resilience, and unwavering dedication. That is none other than Dr. Ashok Taneja, who has been the president-elect of Associations of Physicians of India. And I'll request Dr. Mangla to escort Dr. Ashok Taneja on a dais. Dr. Mangla, can we have the pleasure of escorting Dr. Taneja on a dais? I remember a day with Dr. Taneja in 1992 when we were attending an ECHO conference in Udaipur. Neither me nor Dr. Taneja had the money. We hired a dormitory of 6 beds. 1,200 rupees was the total cost. And a tempo used to ferry us from a venue to that particular guest house. The guest house was full of mosquitoes and only one single toilet over there. You can imagine from where Dr. Taneja has risen to this level of presidency elected. Big round of applause for Dr. Taneja. Next, I would like to call upon on stage a man, a leader who truly embodies what he holds dear: empathy, courage, and excellence. And he's none other than our own friend, philosopher, and dear colleague, Dr. A.P. Mishra. Dr. A.P. Mishra, the Dean of Indian College of Physicians, on the dais. Dr. A.P. Mishra, Dr. Gombar, can have a pleasure of escorting Dr. A.P. Mishra. Come on, Dr. Gombar, we'll do it. Yes, that is right. And a big round of applause for both of them, rather, taking care of each other. Well, every organization has got a leadership at its basis. And we have a leader amongst us, that is Dr. Ghanshyam, a leader who not only navigates challenges, but transforms the team into a stepping stone for progress of API in Delhi chapter. He is a chairman for Delhi AP chapter, Dr. Ghanshyam.
Can I request Dr. Ghanshyam to be on a dais? And very well done, Dr. Ghanshyam, and like transforming the Northeast India into Delhi to be a chairman of API Delhi branch chapter. Let's move on further. That's not the only story is. The story is way more than that. What is that story is? The story is to applaud our leaders, to encourage them to do a good step in a time to come. And the most important thing, we have a leader among us, and who is a legacy of a leader. He's not the leader, he's a legacy of a leader. Our past president of Association of India, President of India, Dr. Pritam Gupta was us. And I'll request Dr. Pritam Gupta to come present a gratitude of appreciation to Dr. Ashok Taneja. And this is a warm moment where the people of two same medical college like Rohtak presenting a gratitude and appreciation to Dr. Ashok Taneja. A big round of applause for both of them, Dr. Pritam Gupta as well as Dr. Ashok Taneja. I'll request all the members of Indian North Delhi Physician Forum to be in a dais. Dr. N.N. Jha, the president of our own North Delhi Physician Forum. Dr. Jha, please come on a stage. Dr. R.M. Chabda, the founder of this particular forum, please be on a stage. I always call Dr. Chabda the Nokia connecting people. Then Dr. Mundra, the honorary secretary and the real behind and hardworking person, be on a stage. Where is Dr. Mundra? Please come on a stage, man. And the last Dr. Ram Babu, जिसके बगैर हम कोई पैसा ही नहीं खर्च कर सकते, सब कुछ इन्हीं के हाथ में है, चेक भी इन्हीं के हाथ में है, डॉलर भी इन्हीं के हाथ में है, यूरो भी इन्हीं के हाथ में है, बस एक आदमी इनके हाथ में नहीं है, वो ट्रम्प इनके हाथ में नहीं है. Next, we'd like to facilitate Dr. A.P. Mishra. Facilitation by our own past president, present inspiration and a future legacy, Dr. Rakesh Sood. Can Dr. Rakesh Sood come on a dais and please facilitate Dr. A.P. Mishra, who is the Dean of Indian College of Physicians. A big round of applause for Dr. A.P. Mishra. I remember Dr. A.P. Mishra when he was working as a delegate, as a principal member of Association of Physicians of India. Big round of applause for Dr. A.P. Mishra for being a Dean of Indian College of Physicians. Next, I'll call upon Dr. A.K. Malhotra. I always call him the champion of all cause problems. Dr. A.K. Malhotra, please come on a dais. He's a champion of all cause problems. When I call him up, Dr. Malhotra, this is a problem. He's always there to solve it. To applaud and to grace this occasion and present a memento to our chairman of API Delhi. Again, a big round of applause for all of them. And with this, let's move on. And I'll request everybody to please sit on our chairs. And can we have a Saraswati Vandana? So let's get up and stand for a Saraswati Vandana today. Every one of us. And now we can move on for lamp lighting ceremony at the same time. I'll request all of you, please get on to lamp lighting.
सूर्य ब्रह्म शिव विष्णु गजानन जन चरणों को सेवते सूर्य ब्रह्म शिव विष्णु गजानन जन चरणों को सेवते हम शिशु है अज्ञानी माता इन चरणों का प्यार दे तेरा पानी तार दे माँ सरस्वती शारदे माँ सरस्वती शारदे मूरख हम नहीं जाने जननी पूजन वंदन ध्यान को मूरख हम नहीं जाने जननी पूजन वंदन ध्यान को आदि शक्ति कर क्षमा हमें आदि शक्ति कर क्षमा हमें पूजा के उद्गार दे तेरा पानी तार दे
Can I have Dr. Jha to say a few words of welcome, the President of North Delhi Physician Forum?
Thank you, Dr. Rakesh Gupta. Distinguished Chief Guest, Dr. Taneja, President-elect API National, our guest of honor, Dr. Pangte, he is the Chairman of API Delhi Chapter, Dr. A.P. Misra, he is the Dean-elect ICP, Indian College of Physicians, very prestigious organization, eminent faculty members, delegates, ladies and gentlemen. It is a pleasure and honor to welcome you all for this 9th annual hybrid conference of North Delhi Physician Forum. First, few words about the North Delhi Physician Forum. North Delhi Physician was formed in 2001 by the three enthusiastic physicians. Dr. R.M. Chawda, give me a big hand. Dr. R.M. Chawda, khade ho jaiye, sir. Dr. R.M. Chawda, khade ho jaiye. Give a big hand. Second is Dr. Gombar. He was one of the instrumental person. And Dr. Rajiv Gupta. They started with 21 members with the CMEs. And it was every second Friday we are doing the CMEs, which gradually increased to more than 200 persons now as a permanent member of this thing. Dr. Rajiv Gupta sir nahi hai kya? Anyway. And after that, in 2015, we got it registered. It was registered in 2015. From 17 onwards, we are having every day and every year annual conference, which is attended by more about 400 to 500 delegates. sometimes 600 also. That's been very, very successful. We are not only academic, we have got social responsibility also, like doing CME, doing conferences, organizing social activities like public lectures, different camps. So we have been doing for the last so many years. This conference is more than an academic event. It is a space to share knowledge, exchange ideas, and renew our commitment to better patient care, which is our prime responsibility. In a time of rapid change in medicine and technology, staying curious, connected, and collaborative matters more than ever. So it's very important. As physicians, our role goes beyond treating illness. We must also uphold compassion, ethics, empathy, and evidence-based practice. Let us learn in this conference from one another and support our younger colleagues and continue working hard towards a healthy society. I thank the faculty, delegates, sponsors, and organizing committee making this conference possible. I will close my lecture with the word of Dr. Sir William Osler: the good physician treat the disease, but the great physician treats the patient who has the disease. I wish you all a productive and successful conference. Thank you. Long live NDPF. Thank you.
Thank you, Dr. Jha, for your presidential welcome. Let's move on to the chairman of API Delhi chapter, Dr. Ghanshyam, to say a few words. Dr. Ghanshyam, can we have your words of wisdom over here?
A very good afternoon to all of you, and I would like to congratulate NDPF and especially NDPF functionaries, Dr. R.M. Chhabra sir, our Dr. N.N. Jha sir, as well as Dr. Mundra sir, for inviting me for this special occasion. And we have been in part of NDPF. I'm also a member here, and I'm seeing that annually a very good conference they organize, and almost every month they organize a CME. And we know that we are all working on betterment of our patients. So therefore, these CMEs play a vital part to improving the knowledge of our physicians. And it's very challenging time now. AI has come, and a lot of important and new developments are there in medicine. For all those, we have to be very, very up to date in our knowledge. For those, these CMEs are very, very helpful. So I congratulate the NDPF team for organizing this whole event, and I wish them best of luck. Thank you.
Thank you, Dr. Ghanshyam. Thank you very much. Let's move on a few word of wisdom from a chairman, Indian College of Physicians, Dr. A.P. Mishra, Dean ICP A.P. Mishra.
Chief guest Dr. Ashok Taneja, Dr. Ghanshyam Pangte, Chairman API Delhi State Chapter, Dr. R.M. Chhabra, founding member NDPF, Dr. N.N. Jha, President NDPF, Dr. S.K. Mundra, Secretary NDPF, Dr. Ram Babu, Treasurer NDPF, API's past President Dr. Pritam Gupta, who has led us so many years and is still, and our very senior member, Dr. I.P.S. Kalra, and so many friends, Dr. Gumar, Dr. J.K. Sharma, Bobby Grewal, etc. NDPF is a vibrant body, and I have been associated with right from the very first beginning because of close association and friendship with Dr. R.M. Chhabra. And every year I see this body scaling greater and greater heights. And they have a wonderful CME. And another thing, another feather in their cap of these founding member is that they involve each and everybody. So nobody feels left out. So that is a very big lesson for all of us. So how to all of us to work together, and so that everybody is happy, and at the same time we are doing a wonderful CME. And I wish NDPF and all you great success. Thank you.
Thank you, Dr. Mishra. एक आदमी जो सबसे बड़ा है, सबसे सीनियर है, सबसे बुजुर्ग है, और जिनकी ब्लेसिंग्स की हम सबको आवश्यकता होती है, Or number of times I've seen, like, he's truly a human being, a devoted legend. He's amongst us and keeps on sitting at one place silently and watching all of us. A few words of wisdom from Dr. IPS Kalra sir. A big round of applause for one man who you'll not believe how saint he is. And with all blessing, wishes and everything, and all grace of a God, he's 92 years of life. We wish him almost 100 years of life in time to come.
Let me tell all of you that every Friday I do a webinar on at 4 o'clock, and Dr. Kalra has been joining the webinar from the streets of New York and never left a single webinar, even though it used to be 6 a.m. in the morning.
ਵਾਹਿਗੁਰੂ ਦੀ ਕਿਰਪਾ ਹੈ ਕਿ ਤੁਸੀਂ ਸਾਰੇ ਮੈਨੂੰ ਇੰਨਾ ਪਿਆਰ ਦਿੰਦੇ ਹੋ। ਇਹ ਸਭ ਉਹਦੀ ਖੇਡ ਹੈ। ਅਸੀਂ ਸਭ ਉਹਦੀਆਂ ਕਠਪੁਤਲੀਆਂ ਔਰ ਇੱਕੋ ਹੀ ਹੈ ਕਿ ਮੇਰੀ ਰਿਕੁਐਸਟ ਸਾਰਿਆਂ ਨੂੰ ਹੀ ਹੈ, ਜੋ ਗੁਰੂ ਨਾਨਕ ਨੇ ਕਿਹਾ ਹੈ, ਕਿਰਤ ਕਰੋ, ਅੱਛੀ ਤਰ੍ਹਾਂ ਮਰੀਜ਼ਾਂ ਨੂੰ ਚੰਗੀ ਤਰ੍ਹਾਂ ਦੇਖੋ, ਨਾਮ ਜਪੋ, ਆਪਣੇ ਧਰਮ ਦੇ ਮੁਤਾਬਕ ਵਾਹਿਗੁਰੂ ਨੂੰ, ਅੱਲਾ ਨੂੰ, ਰਾਮ ਨੂੰ ਯਾਦ ਕਰੋ ਤੇ ਚੜ੍ਹਦੀ ਕਲਾ ਚ ਰਹੋ ਔਰ ਵੰਡ ਕੇ ਛਕੋ। ਆਪਣੀ ਜੋ ਐਕਸਪਰਟਾਈਜ਼ ਹੈ ਉਹਨੂੰ 10% ਗਰੀਬਾਂ ਚ ਵੰਡਦੇ ਹੋ। ਪੈਸੇ ਮਾਇਆ ਤੇ ਵੰਡਣੀ ਹੁੰਦੀ, ਜਿਹੜੀ ਹੁੰਦੀ ਉਹ ਤੇ ਜਾਣੀ ਨਹੀਂ ਨਾਲ, ਲੇਕਿਨ ਔਰ ਨਾਮ ਧਨ ਇਕੱਠਾ ਕਰੋ ਜਿਹੜਾ ਨਾਲ ਜਾਣਾ ਹੈ, ਬਾਕੀ ਦਾ ਸਭ ਇੱਥੇ ਰਹਿ ਜਾਣਾ। ਔਰ ਸੀ ਲਵ ਆਲ। ਗੁਰੂ ਗੋਬਿੰਦ ਸਿੰਘ ਨੇ ਕਿਹਾ, ਜਿਨ ਪ੍ਰੇਮ ਕੀਓ ਤਿਨ ਹੀ ਪ੍ਰਭ ਪਾਇਓ। ਤੁਸੀਂ ਵਾਹਿਗੁਰੂ ਗੋਡ ਆਲਮਾਈਟੀ ਦੀ ਜਿਹੜੀ ਕਾਇਨਾਤ ਹੈ ਉਹ ਸਭ ਦੇ ਵਿੱਚ ਹੈ, ਤੁਹਾਡੇ ਵਿੱਚ ਸਾਰੇ 'ਚ ਹੈ। ਸੋ मेरे यही रिक्वेस्ट है और मैं आई एम ओवरवेल्म्ड बाय योर लव एंड अफेक्शन। गॉड ब्लेस यू।
Thank you, sir. Thank you very much, sir. Thank you. Can I have a release of a directive from the North Delhi Physician Forum? Dr. Taneja, they have done a lot of good job by collecting everybody's data, 24/7. If somebody is not responding, believe my words, they were calling me at 10 o'clock night. Are you apni photo bhej de? And that's hard work done by NDPF. Not one person, all of them together, they were doing a big work all together. I'll request you to, Hindi भाषा में कहते हैं विमोचन करना। इसको पैक करने में ज्यादा कम टाइम लगता है, खोलने में ज्यादा टाइम लगता है। Mayank Saxena. And all work of this NDPF directory word goes to Dr. Mayank Saxena. Mr. Mayank Saxena. Mayank Sharma is over here. हाथ की हाथ। दोस्तों, उसके बाद सबसे बड़ा इंपॉर्टेंट, सबसे प्यारा दोस्त जिसके साथ हमने एक डॉर्मिटरी में कुछ समय गुजारा, उससे मैं चाहूंगा कुछ शब्द इस सभा को कह के संबोधित करें। डॉक्टर अशोक तनेजा।
Hello. Thank you, Dr. Rakesh, Master of Ceremonies, respected dignitaries on the dais, distinguished faculty, my esteemed colleagues, young friends. Dosto, it is a matter of great pride for me that on the 9th annual conference of NDPF, sometimes I forget NDPF, I call it NDRF. दैट इज ए जोक पार्ट। मुझे जब डॉक्टर छाबड़ा ने बोला कि आपको चीफ गेस्ट बना रहे हैं तो आपको कुछ बोलना भी है, तो मैं थोड़ा सा आई वॉज ए लिटिल बिट परप्लेक्स बिकॉज सो मेनी ऑफ माई सीनियर्स, डॉक्टर कालरा, डॉक्टर प्रीतम गुप्ता इज सिटिंग एंड मेनी अदर फ्रेंड्स, आप सब लोग तो मेरे सेम एज के हैं, फ्रेंड्स हैं, यंगर फ्रेंड्स हैं। तो मुझे एक बात याद आ गई क्योंकि मुझे थोड़ा जल्दी फिनिश करना है। हरियाणा में एक बार मिनिस्टर हैं, नाम नहीं लूंगा, उनको ऐसे ही चीफ गेस्ट बनाया गया, ऐसे ही एनडीपीएफ की शायद कोई कॉन्फ्रेंस थी, उसमें बुलाया गया। उनको बोला गया जी आपने बोलना है परप्लेक्सिटीज इन मेडिसिन, इस सब्जेक्ट के ऊपर बोलना है। अब उन बेचारों को समझ में नहीं आया, हरियाणवी थे, तो वो आए स्टेज पे, बोले कहना जी आप सबको पता है परप्लेक्सिटीज इन मेडिसिन क्या होता है? उन्होंने कहा जी नहीं। तो कहता जी फिर आप समझ के क्या करोगे? जाके बैठ गए। अब डॉक्टर छाबड़ा को बहुत गुस्सा आया, यार चीफ गेस्ट को बुलाया, गाड़ी दी, यहाँ ठहराया और उसके बाद ये हाल। उन्होंने फिर अगले साल फिर बुलाया और पहले ही ऑडियंस को समझा दिया कि आपने बोलना है यस। उन्होंने आते ही फिर वही पूछा, भाई आपको मालूम है इस सब्जेक्ट के बारे में? सबने कहा यस। उनका जब तुम्हें पता है तो मैं समझा के क्या करूंगा, और जाके बैठ गए। अब वो तीसरी बार आई जो 9th कॉन्फ्रेंस है, मुझे बुलाया, तो मेरे को भी यही कहना था कि भाई मुझे तो पता नहीं। तो उन्होंने कहा नहीं नहीं आपको आना जरूर है। इस बार इन्होंने ऑडियंस को समझा दिया कि जो राइट साइड पे बैठे हैं वो यस कहेंगे, उधर वाले नो कहेंगे, ताकि फंस जाए इस बार मिनिस्टर। तो ये तो उन्होंने जैसे ही पूछा कि आपको इस सब्जेक्ट के बारे में मालूम है, तो आधों ने कहा यस, उन्होंने कहा नो। कहता जिनको यस है आप उनको समझा देना, जाके फिर बैठ गए। तो हरियाणवी sometimes is quite rustic as well as interesting, but arranging a conference for colleagues, especially in the medical sciences, bringing in the latest advances is a tricky art. And this art, Dr. Chhabra knows very well. And he has been arranging for the last so many years. I send him the congratulations and to the whole organizing team. Friends, आज का जो दौर है ना मेडिसिन का, many say that it is a challenging time, but I say that it has to be a symbiotic relationship time, because now we are entering into the era of artificial intelligence, digital medicine and precision medicine. दोस्तों इसको चैलेंज मत समझिए, इसको अपना दोस्त बनाइए। Try to utilize as maximum as possible to your advantage. My third thing is, my message to all my friends, which I always say from the stage is, दोस्तों आप सब लोग अपने पेशेंट्स का बहुत अच्छा ध्यान रखते हैं, बट आपका ध्यान कौन रखता है? प्लीज टेक केयर ऑफ योरसेल्फ। अगर आप अच्छे हैं, जिंदा हैं, अच्छी क्वालिटी हैं, you will further take care of patients in life. You will take care of your family, you will take care of your society and nation. But first, as a doctor, heal yourself also at the same time. Thank you very much. Jai Hind.
थैंक यू डॉक्टर तनेजा। हरियाणा में बड़ा कहते हैं कि कल्चर के नाम पे एग्रीकल्चर है। तो एक बार मैं रोहतक के जाने के रास्ते में बहादुरगढ़ पे बैठा हुआ था, तो डॉक्टर तनेजा आए, मेरे से पूछते हैं कि सड़क रोहतक जाएगी? तो मैंने धीरे से जवाब दिया, भाई मैं 50 साल से यहाँ बैठा हूँ, आज तक तो कहीं नहीं। तो दैट्स व्हाट डॉक्टर तनेजा इज। सो नाउ द वोट ऑफ थैंक्स। जिस आदमी ने बहुत सारा काम किया, बहुत मेहनत की, 24/7 काम किया, उसको लास्ट में यही कहा जाता है भैया वोट ऑफ थैंक्स तू दे दे, जबकि हमें उसको वोट ऑफ थैंक्स देने चाहिए। आवर ऑनररी सेक्रेटरी डॉक्टर एस.के. मुंडा, प्लीज over here.
Thank you, Dr. Rakesh Gupta. I thank from the core of my heart and from NDPF side our chief guest, Dr. Taneja, and our colleagues, Dr. A.P. Misra, Dr. Ghanshyam Pangte, our past president API, Dr. Preetam Gupta, all the speakers, chairmen, panelists, and delegates who came here, spent their time, and contributed in disbursing knowledge. And then all my colleagues who supported us, hotel management and staff, the pharma industry, without whom this may not be possible, event management team, Rudraksh, NDPF staff, and all whom I have omitted unconsciously. Now at the end, I'll request all of you to please stand for the national anthem. National anthem, please.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगल दायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Thank you, everybody. Thank you very much. And this is time for, we had a scientific feast. Now the time for a gastronomic feast for all of you. Thank you. And we'll assemble back at 3:30, precisely at 3:30. Sir, एक बार photo ले. Dr. Mundra.
हेलो नहीं डायरेक्टली सॉरी मांगेंगे दो बैल तो बुरा हो गए तो बात में बड़ा भी और किसी का ना अरे और किसी का तो चले जाओ हमको तो देखना पड़ा जो जा रहे हैं कितने गाड़ी बढ़ जाएगी फट जा नंबर आएगा अपने तो चलेगा ठीक है मैसेज आना होगा अच्छा अपने तो चलेगा सेंड लाइक ठीक यार बोले ना तो हां कैंसिल दे दे मेरे कैंसिल नहीं मिलेगा वो हमें क्या आप गए हो ये क्या ऑर्डर किया देखिए अरे बैग कर दो नाम पड़ गया ये तो बिल्कुल
रिक्शा सीटिंग जैसे पहले थी ना वैसे करवा
बिना तेल लगाए पानी देने से अंदर जाएगा।
भाई क्या हो आप लोग? Hello. Dr. Neja is requested to come here. Oh, sada hero te khada hai. All are requested to come in the hall. We are going to start the session. Dr. Mundra, please, you are the backbone of the conference. Come here.
कौन है इसमें इसमें
किसी को उठा ले 5 बंदों को यार
आलोक जोशी एसएस झा ठीक है ये पांचों हैं ठीक है
हेलो जोशी है मैं कुछ
Hello. Hello. Good afternoon, friends. Let us gear up for post-lunch session. And for this, I'll invite Dr. Pankaj Aneja, who has a huge experience with Monjaro, as you know, dual agonist for chronic weight management and diabetes management, type 2 diabetes. Dr. Pankaj Neja is a senior diabetologist and a specialist in metabolic disorders, Max Shalimar Bagh. I invite him for his deliberations on Monjaro, a unified strategy for metabolic disease. And the chairpersons for the session will be Dr. S.K. Arora, Dr. Alok Joshi, Dr. Anand Jha, Dr. Jagdeep Chog, Dr. Avinash Rai, and Dr. R.M. Chhabla. All are welcome to the stage, please.
ये कौन लगाएगा?
अरे उसको बोल, अरे सुनो, चालू करो इधर, आओ, लैपटॉप कनेक्ट करो.
कनेक्ट क्या हमारा लगाना है यार?
प्लीज सर, प्लीज. हाँ हाँ डॉक्टर साहब, सर प्लीज आइए.
Dr. Pankaj Neja doesn't require any introduction. In one leg, he is a gentleman and he is a friend to everyone. Dr. Pankaj.
Good afternoon, friends. Thanks, NDPF, for this opportunity. So today I am here to talk something about Monjaro, the talk of the town, a unified strategy for metabolic disease. These are two females, Anjali and Jahnavi. Both of them are obese. One is diabetic, another is not a diabetic. Anjali happens to be having no diabetes, whereas Jahnavi is obese and is living with diabetes also. Both of them tried multiple number of times to lose their body weight, but they have been unsuccessful. Whatever they lost, they've gained over a period of time. So this is the story you hear day in and day out in your OPDs. So what are the therapies available with us? We have Monjaro, tirzepatide. We have GLP-1RA, semaglutide. What evidence matters the most? What we practice nowadays is the evidence-based medicine. So let's talk about the evidence, and I leave decision to my esteemed audience what to use in what situation. So let's talk of evidences. Let's talk of SURMOUNT-1 trial, which happened with Monjaro, and all those patients were non-diabetic. It demonstrated early onset of weight reduction, and that too sustained. What was seen? 16% weight reduction was seen with only 5 milligram at 72 weeks, and 22.5% average weight reduction was seen with a maximum dose of 15 milligram at 72 weeks. So that's a very significant weight loss of 22%. There was 40% higher mean weight reduction with Monjaro compared with semaglutide maximum tolerated dose. So if you see this graph, what you can appreciate, there is 21.6% reduction. The red line is depicting Monjaro and the black line is depicting semaglutide. So at 72 weeks, participants taking Monjaro 10 or 15 milligram, they experienced a body weight reduction of 21.6% as compared to 15% seen with patient taking semaglutide. Now, what was seen? At 72 weeks, 1 out of 3 participants on Monjaro, they achieved more than 25% weight loss, whereas with semaglutide, it was only 1 in 5. Again, in the same trial, participants taking Monjaro, they experienced superior reduction in waist circumference. So that's expected. Once you lose body weight, your old trousers are going to fit you. So there was a loss of almost 20 centimeter, 8 inches. That's a significant reduction in the waist circumference seen with Monjaro. Now, not only this, now from where is the body weight reducing? Is it the total body fat mass or it is the lean muscle mass? So what was seen, the patients taking Mounjaro experienced a reduction in total body fat mass along with reduction in visceral fat. We all know that visceral fat is the culprit for all CVDs. So it was a total body fatty mass loss and the visceral fat mass, and there was not very significant reduction in the lean mass. So that leads to improvement in the body composition. Again, whenever you lose body weight, there is bound to be some improvement in the cardiometabolic parameters. That's what happened. Systolic, diastolic blood pressure, triglyceride, LDL, everything reduced with increase in HDL. So what more you want? You want a weight loss, you want a reduction in all those parameters which are detrimental to the cardiovascular health. Participants experience a better quality of life. That's expected. Once you lose body weight, you become more confident. You become more confident, you are more presentable, you are more accepted, and you look more smart. So that is what happened. The quality of life also improved. Now, let's talk. So far, we have been talking of a non-diabetic situation. Now, this lady, Janvi, is a diabetic and she is living with obesity. Again, the same question arises. What to use? Whether it's Mounjaro or whether it's a semaglutide. Let's talk again about the evidence-based medicine. We have a trial SURPASS 2 where they had a head-on comparison. So what was seen? A meaningful and dose-dependent HbA1c reduction was observed with Mounjaro. Just see these bar diagrams. So 2.1% reduction in HbA1c was seen with the minimal dose of 5 milligram of Mounjaro as compared to 1.9 with a maximum dose of semaglutide. And once the Mounjaro was given 15 milligram, the reduction in HbA1c was 2.5%. 2.5% vis-a-vis 1.9%. The things are there in front of you. Now, let's talk about how many participants achieved normoglycemia. What do you mean by normoglycemia? That means HbA1c coming less than 5.7. Just imagine a person who has an HbA1c of 12% and he reaches an HbA1c of less than 5.7%. So that's what happened in almost half of the participants who have been taking 15 milligram of Mounjaro. And the good point was there was a sustained weight loss. If you see this diagram, what you can see, the red line is Mounjaro 15 milligram. There was reduction of 12.4 kg as compared to 6.2 kg body weight loss at the 40th week seen with semaglutide. So better HbA1c reduction, better reduction in body weight, more reduction in waist circumference was seen in head-to-head trial in our diabetic population also. So then let's talk about the composite endpoint. What was the composite endpoint? It was HbA1c less than 6.5, weight loss more than 10%, and no significant, clinically significant severe hypoglycemia. Just see this figure. Mounjaro 15 milligram, 60% of patients achieved this, vis-a-vis semaglutide 22%. So what do you see? Mounjaro 15 milligram helped 3 times as many patients achieve a composite endpoint as compared to semaglutide 1 milligram. So you saw the benefits. Now let's talk of the safety. There was, once we compare both the drugs, lesser side effects like nausea, vomiting, constipation, dyspepsia was seen with Mounjaro as compared to semaglutide. And we all know the most common adverse events are all gastrointestinal in nature, and they happen whenever you escalate the dose. So Mounjaro has a well-established and consistent safety profile. So to summarize what we discussed in the last 5 minutes, it's the first, Mounjaro is the first and only GIP-GLP-1 receptor agonist with proven superiority over standard of care. In all those individuals living with obesity, 22.5% mean weight reduction has been seen, 40% greater relative weight loss has been seen. There's improvement in cardiometabolic profiles. In diabetic population living with obesity, superior HbA1c reduction up to 2.5% as compared to semaglutide, and 51% of participants, they did achieve normoglycemia. That means HbA1c less than 5.7. How do you use it? Majority of you must be using it, but I'll just brush your knowledge. Start with 2.5 milligram. After 4 weeks, step it up with 5 milligram once in a week. Again, step it up every 4 weeks to 7.5, 10, 12.5, and 15. But believe me, all patients need not go to the maximum dose of 15 milligram. If I talk of my experience, 40% of patients of mine are doing so well only on 5 milligram, not having significant side effects, and consistently losing their body weight as long as they are sticking to their lifestyle, diet, and exercise program. Let's talk about all those. Minded it is not to be used in individual less than 18 years of age. Otherwise, age, sex does not make any difference as far as dose is concerned. No dosage adjustments are required in hepatic and renal impairment. But word of caution, definitely in severe hepatic impairment, I'm talking of severe, and in end-stage renal disease, preferably not to be used. If patient is already on metformin, SGLT, continue with the same dose. If patient is on sulfonylurea, insulin, you need to reduce the dose. Keep a very careful watch on the blood sugar level. Tell patient to do self-monitoring of blood sugar and titrate the dose. Whenever you start the drug, tell patient about symptoms of acute pancreatitis. If there is a history of pancreatitis in the past, do not use the drug. If there is a history of medullary thyroid carcinoma in the past, in the family only, do not use the drug. Pregnancy, again, lactation, again, not to be used. If a young lady coming to you wants to reduce her body weight, start it, but give a word of caution, contraception to be done, because we want the drug to be stopped at least 4 weeks before the lady gets pregnant. So whenever you start the drug, you have to counsel the patient for 5-10 minutes, tell them what to do, tell them to eat small frequent meals, tell them to hydrate themselves well, tell them when they are eating food, when they are 3/4 full or 2/3 full, stop eating. Tell them that they have to avoid spicy food, high-fat food. Tell them to delete their Swiggy and Zomato app. That's very important. Then alcohol, fizzy drinks again have to be avoided. Now what happens? There are quite a number of patients who take the dose. Suppose they are supposed to take it on Sunday and they skip it. So next 3 days, they can take it on Monday, Tuesday, Wednesday. But if it is beyond that, do not take it. So that means I tell my patient, अब इसका चौथा हो गया इस हफ्ते का, अब तुम अगले हफ्ते लेना दवाई. So that is the easy way to remember कि after 3 days you can take this drug and not after that. Thank you very much for your patient listening.
Thank you, Dr. Pankaj. And I request Dr. Pankaj Aneja, Dr. Rajiv Kishore, and Dr. Saket Kant for panel discussion. I request Dr. Chavda to join with me for panel discussion, and I request the panelists to be crisp and short regarding discussion. Thank you very much.
Rapid fire round. It is rapid fire round. First question to Dr. Saket Kant. सबसे पहले लेक्चर आपने दिया था ना? Answer should be a very rapid fire answer. Yes, no. Okay. What are the metabolic adaptation to weight loss that impends the continuing or the sustaining the weight loss? What is your answer?
Gave that answer in the slides also. The BMR goes down, your energy expenditure goes down, your ghrelin increases, and your leptin goes down. So you will have, that is a perfect state for rapid regain of weight.
Next question to Dr. Pankaj. How do you counsel your patients the need for the pharmacotherapy? How do you consider the patient?
First thing is, counseling is very important. I, in my clinic, do the body composition analysis. We do not talk about our BMI alone. We talk about the total body fat. We talked about them. We talk about the waist circumference. We talk about waist hip ratio. We tell them that this is the distribution of fat in the viscera. We tell them about the visceral fat. So in body scoring of the patient is important. If you have facility of doing it, you will make your patient understand very fast that BMI alone is not the criteria. You have to have the other parameters along with that.
Yes, other parameters are very important, not only the obesity. So, question to Dr. Rajiv. What is your opinion about data of tirzepatide on the patient with the obesity without the diabetes mellitus, if there is no diabetes?
See, as of today, Mounjaro is the best available drug for managing obesity. It is the maximum results, same because it has a double engine ki sarkar hai. It's got GLP-1 plus GIP. So as of today, the most dramatic results in obesity are with this. Although semaglutide has got more proof for the organ damage, but later on I think many trials are underway. We'll get proof when it is reducing weight, and definitely it has got the GLP-1. So all the benefits of SEMA will be there with this also, plus added benefits of additional weight loss. So as of today, this is the most potent drug for weight loss today available to us.
So this is only for the weight loss, not the diabetes. If the patient without the diabetes, so this drug is more important.
No, this is when without comorbidities, you are just tackling obesity. So this is the first choice of drug. But if he has got comorbidities, like he has got MSLD, he has got kidney disease, he has got diabetes, then maybe you can consider semaglutide also. But this will also help the diabetes part also, because it has already got the GLP-1. But approvals for many organ damage has not come. It is on the way. There are many trials underway, and probably very soon next year we'll have the results out, and this will be approved for all the other. Today, now it's there for sleep apnea. It's approved for sleep apnea today.
Dr. Saket, again to you. So dear friends, now we consider it is a disease. It is a chronic disease, obesity. So why the obesity is a chronic disease, and why it should be treated alone? I think obesity is the only culprit for the all diseases.
Obesity is a harbinger for more than 270 diseases, and it is chronic because whenever you lose weight, you can always regain that weight. So it's chronic relapsing disease. So once you lose that weight, you also have to maintain that weight, and that is the reason these drugs are come up. Even after bariatric surgery, after 1 year, your ghrelin will rise. Again, you will need these drugs to maintain that weight.
Good. So now again question to Dr. Pankaj. How do you monitor your patient towards the efficacy of the points like the weight measurement and the BP patients?
See, efficacy, number one, quality of life. Number two, total reduction in the body weight, the waist circumference, periodic doing body composition analysis, because at time you feel the patient has lost body weight, but the body weight loss is not the fat mass they have lost. What they have lost is the muscle mass. Here lies the need to educate the patient to take care of their protein content, emphasizing that they have to have somewhere closer to 1.5 gram of protein per kg body weight, so that they do not lose their skeletal muscle mass. What we aim is that they should lose their fat mass. So that the easy way to do is by doing the body composition analysis, but in-house parameters can vary by doing the BMI, by checking their waist circumference, the quality of life. All these things can be taken into consideration.
Thank you, Pankaj. Again, question to Dr. Rajiv. The very, very important question every patient asks you. How long the tirzepatide be given for the weight loss in the obesity and the overweight if the BMI more than 27, comorbidity with comorbidity?
Basically, these are metabolic drugs. Ideally, these drugs have to be given lifelong. Once you start the drug, it should be given lifelong. But in India, it's not so practical, considering it's not covered by insurance. So maybe you have to give it for a limited period. But after that, you have to follow. Maybe you can go down to the generic brand, or maybe you have more hectic lifestyle management. But if you stop it and you don't have good lifestyle, the 80% weight is going to return. So basically, it has to be given lifelong, unless you have very strong, facilities for lifestyle management.
Okay.
Or maybe today we have generic versions available. You can downscale the dose or shift to a generic version.
So lifestyle management is very, very important along with the treatment. So thank you very much. Doctor, over to Dr. Akya.
Thank you. And Dr. Saket, and what are your criteria for the physical and clinical evaluation of the weight? And what are the consideration while you screen the patient for obesity, and the role of BMI, in just one setup?
Your visceral adiposity is more important. BMI may not be Visceral adiposity is more important, and BMI may not be that criteria. So measuring the waist height circumference, which we rarely do, waist height circumference, waist would be a good option. And if the patient has comorbid conditions with a waist of more than 90 in males and 85 in females, you're good to go to give anti-obesity drugs.
Thank you. And Dr. Pankaj, how do you check the compliance and adherence of your patient, whether they are adherent to the therapy or not? And what expectation do you set to the patient regarding their monitoring?
See, this is a very tricky situation. You have to have a holistic approach for the management of obesity. It's not only the diet counselor, they're important. It's the psychologists, they're also important. So we in-house, what we do is we enroll patient in an obesity program where they are in touch with my diet counselor, where they are in touch with my exercise trainer, and where they are in touch with my clinical psychologist. So it's a teamwork. So we work as a team, and then only we are successful. I can claim it that majority of patients, I have now more data of more than 300 patients who are on GLP. There must be closer to more than 300, 400 patients. And we are following them very, very rigorously. Every patient is just like a baby to us. My counselor will talk to them every week, listen to the problem, give them a solution, counsel them. The counselor will tell them, look, if you have this issue, do this, do that, motivate them. And then again, my exercise trainer once in a month will connect to them virtually, tell them, okay, start doing dumbbells, increase the weight, do the stretching exercises. If they are on this program where everybody is involved, it gives a holistic approach, and believe me, the results are excellent. We have patients who used to weigh 150 kg. I still remember a young boy, 150 kg, coming to me, said, sir, I will not get married. It's not possible for me. I'm 150 kg. He now weighs 90 kg. He got married, and that's a real prize I got from him.
Thank you. Dr. Kishore, what was your idea about the individualized responses to the tirzepatide therapy in patients with overweight, and how some of the people, they are non-responders? How do you find them? What is the reason for being the non-responder? Can you enumerate in short?
See, these GLP-1 incretin-based drugs have two actions. One is the glycemic action, one is the weight-reducing action. So both are independent actually. So some patients you get more of the glycemic action, and in some cases you get more of the weight loss action. It may be dissociated. 10 to 20% of any drug are non-responders. So in this case also, some cases report after 6 months of the therapy, they have gained weight actually. So you have to withdraw the drug, you understand that they are not going to respond to this drug. But it doesn't happen, 80% cases do respond. The quantum of weight loss may be different. And in some cases, there is more response on the glycemic part, in others there is more response on the weight loss part. So, and some cases you have both the things. You have good glycemic response, good weight loss response. So they are two different actions of the same drug, but it varies from patient to patient. And of course, in non-responders, after a fair trial of 3 to 6 months, if it doesn't respond to the weight part, then it's better to withdraw it. No point wasting money.
Dr. Saket, your take on this?
I guess I would agree on that. You may have responders, non-responders. You can always try shifting from one to another, because this is a GLP-1 sub-agonist and a GIP-1 super-agonist. You can always shift to a GLP-1 super-agonist and try and reinforce diet exercise at every visit. And if there is no response even to the maximum dose, probably there is no point. I have a patient did not respond to semaglutide highest dose, did not respond to highest dose of tirzepatide. Probably retatrutide is the drug that we're waiting for then.
And what your take on the patient with the, those who are having more of the side effects like pancreatitis, your take on the retinopathy, and those with the existing care, what hepatic failure, how do you?
I guess pancreatitis, previous pancreatitis with the remediable cause, if it is done for gallbladder stone, it has been removed, you can even give it with caution. No idiopathic pancreatitis, you have to be very careful, don't give it or give it with counseling. And PDR is a contraindication, NPDR requiring therapy is a contraindication, ARMD is a contraindication, neon is no longer a contraindication. So, but you will have to counsel your patient regarding all this, and then probably you can give it safely to your patients.
Dr. Pankaj, one last question. Majority of the patients, they come to the clinics, they say, before you start prescribing them this molecule, you have the counter question that we have heard a lot of side effects, because some patient has lost vision, some patients have gone mad, and this and that, because of the media awareness or whatsoever may be the reason. How do you tackle them?
See, my answer is very simple. I tell them I see, say, 60 patients a day, and out of 60, none of them puts a good review. It's only one will put a good review, the one who is not satisfied with my clinic. So same story happens with Mounjaro, same story happens with semaglutide. See, it's a negative thing which spreads very fast, and positive thing do not. So you have to build the confidence. You have to tell them that it is not the story. These are not the facts. Do not go by this. Go by statistics. Ask your colleagues. Ask your friends who have used it. And patients come from. It's a word say. My patients coming to me. They're the families who are coming to me. My cousin lost this much. My friend lost this much. Why not me? So what is important is counseling. That's very important.
Any question from the audience so that I can sum up?
No question.
Can you be louder, please? Mic, please.
Mic do.
बस खत्म.
Hello. What is the basic difference between Mounjaro and Zepbound, trade names?
Pardon?
Zepbound and Mounjaro difference.
Yerpeak and Mounjaro are same. It is the only difference is the same company is marketing through two different routes. Cipla has been given the rights to market because they have a deeper penetration in tier 2 and tier 3 cities. They have named it Yerpeak. Mounjaro is the original molecule available from Eli Lilly. It's the same manufacturer.
They are the same. Basically, the marketing strategies are there. They have given marketing right to the other company. I think this is the last.
In US, Mounjaro is meant for diabetic patients, while Zepbound is meant for non-diabetic for weight reduction. These are the indications. These are FDA-approved indication. Though both are same, but you can't use Mounjaro, Zepbound in diabetic and Mounjaro in non-diabetic.
But in India, DCG has given approval. India it's only Mounjaro. We don't have Zepbound. India, they have to give approval to both the drugs for both the things.
One point here, I like to ask the panelists. When you start this drug and patient asks you, when I am going to see some response in HbA1c level, at what time? Say after how many days or weeks, the HbA1c response, when will it be there? Because they are worried about it.
Second month to first month, 0.25 is only the sensitizing dose. When you go to 0.5 or above, then you may see results. In rare cases, even in 0.25, you start getting results. But not before the second or third month.
In theory, it's right. But in practice, even 0.25 gives you some response.
Yeah,
you will
give
see
response.
that. You see the fasting sugar, see the PP sugar. They start responding within weeks. Not 4 weeks is needed. Even 2 weeks may be time when you can see the
Depends
response.
on patient to patient.
Thank you very much. We can discuss it later on. And now to sum up 1 or 2 points. So in the nutshell, the obesity comprises the genetic, environmental and behavioral psychological factor, and it is the pathophysiology involves hormonal dysregulation, inflammation and metabolic adaptation, all of which contribute to the insulin resistance and increased risk of chronic disease. The socio-economic status, education, healthcare access, and the community resources significantly improve the dietary choices, physical activity level, and overall health outcomes. So promoting a supportive, non-judgmental environment is essential for the effective obesity management. And we have now a good molecule, and it is the era of this molecule, I suppose, with lot of benefits around, and it demonstrated a clinically significant and statistically significant improvement throughout the various data. And the adverse effect has been discussed are mild, can be tackled with proper counseling. Thank you very much. Dr. Jagdeep Chuk, I request you to further take home and request our panelists and request the earlier chairpersons to honor the panelists, including Dr. Rajiv Gupta.
And Dr. Naresh Chavla to honor our chairpersons. And Dr. Naveen also please come to to other chairpersons.
Good evening. Although everybody must be feeling sleepy, time to wake up. Now we are from diabetes, we are moving to cardiology. Dil ki baat hai. So dil ko tham lijiye. Now we are having our another eminent speaker, Dr. Chandrasekhar from Yatharth Hospital. And chairpersons for this are Dr. Chandrasekhar, please come on the stage. And the chairperson for these sessions are Dr. Yogendra Gupta. Please come. Dr. Nanak Wadhwani, Dr. Suchin Bajaj, Dr. Anil Jain, Dr. Gombar, please come. Dr. Rajneesh Sharma, please chair the session. Dr. Rajneesh Sharma, please come on the stage. Dr. Rashmi, please come on the stage and Dr. Rashmi, please chair the session.
Dr. Chandrasekhar, the chief cardiologist at Yatharth Hospital, Model Town. I've been associated with him from the last many years during CMEs and off the dais and on the dais also. Right. So, and his art of calcium management now, his art of cardiology is different. His art of calcium management is also different, combining advanced hardware for optimal PCI outcomes. I have seen his outcomes. His outcomes are absolutely brilliant. So I would request him to be a little more precise on his results, real issues. Thank you, doctor.
Thank you, sir. Good afternoon. Thank you for being over here. Today I am talking about a very important topic, and the calcific lesion, calcific coronary lesion. Such kind of lesion usually are the reason for failed PCI in current days. So to have a effective and good outcome, one should be very well versed to deal with these calcific lesions. So after a brief introduction of the topic, I would like to share a few cases from our lab at the end. So why we are discussing calcium? Because nowadays we are getting lot of patients who are elderly and diabetic with underlying kidney diseases. Such type of patient tends to have heavily calcific coronary lesions. And calcium, as I said, is the biggest challenge in current PCI, in coronary angioplasty. So for a proper stent deployment, you must have to deal with it and to modify it. It has been seen that 20 to 30% of the PCI lesions shows moderate to severe calcification on coronary angiography. Approximately 1 in every 8 to 10 PCI procedure requires dedicated calcium modification technique. And if you don't modify them, the stent will not open properly. And many a time it is the cause for failed PCI. So what are the problems we usually face when we deal with such calcific lesion? The calcium makes the artery, elastic artery, stiff. cement-like, and it doesn't allow balloon or even a stent to be taken inside for a proper taking care of the lesion. So delivery of the device is difficult. It carries a very high risk of complications. The risk of rupture and other things are always there. So on-table complications are very high in those who are having severely calcific lesion. If you don't modify them appropriately, the chances of re-stenosis is again very high. And stent thrombosis is a real problem, and it carries a very high risk of mortality in such patients. So this slide I have taken just to convey the resolution we tend to get with the normal procedures. Like if you go from left to right, and if you look at the picture of Mona Lisa, you will be able to appreciate that on the far right side, the picture is more clear and bright. So is with the angiography. So CT coronary angiography and conventional coronary angiography gives just a roadmap and an overall picture of the calcium. It is the IVUS and the OCT which gives you more clear picture, the kind of calcium you are going to deal with. The IVUS, the OCT is 10 times more, giving more resolution as compared to IVUS. So for a calcific lesion, you must image them for a proper evaluation. Moreover, with a simple angiography, you won't be able to appreciate the different kind of calcium you are going to deal with. Because all the calcium which we see on coronary angiography is not same. Some of them may be superficial, some of them may be deep. The thickness may vary, and sometimes you get a nodular kind of projection inside, which is the cause for rupture of the balloons, and these are the lesions which is very difficult to treat in day-to-day practice. When we look into the IVUS and OCT, we usually try to see the arc of the calcium, the thickness of the calcium, whether nodule is present or not, or length of the calcium. Based on these parameters, a scoring system is made, and if you have a score more than 3, usually you require some sort of modification techniques to achieve a good end result. So usually the common tools which we use or techniques we use for calcium management in our practice is scoring or cutting balloons, atherectomy device like rotablation or orbital atherectomy, or intravascular lithotripsy. This has made the life simpler in many of the cases. This is again a slide which I just want to convey how they work. So when a road is blocked by a rock, you can deal it with 3 ways. Either you can effortfully grinding them and cutting them from one side. It requires a lot of hard work. Or you can open them by drilling, bringing a drill and debulking the hard rock, making a road inside. Or you can have a targeted release of energy and can burst them into small pieces. So is this is how the newer techniques works. So cutting balloon and the scoring balloon usually cuts down the calcium. Atherectomy devices like rotational or orbitals causes polishing of the calcium or sanding like drilling machine. And with the acoustic pressure waves, the IVL works by giving a controlled crack into the calcium, making it more elastic. This is how orbital atherectomy device works. It polishes from both front, onward and backward motion, and it helps in creating a good luminal area and delivery of the stent. This is the IVL where we gives a lot of acoustic pressures, which produces the cracks inside the calcium, and it helps in delivery of the balloon and stent. This is again a rotational atherectomy device. It helps in taking off the calcium, which helps the balloon to expand it further, and finally you can finish up the procedure by putting a stent. So after having said this, I can say that With a calcific coronary lesion, whenever there is a sense of calcium, and the calcium appears on angiography, the further definition is definitely required to achieve a good end result. This I will highlight in the first case. This is a case of a 70-year-old gentleman, post-CABG patient, came with acute coronary syndrome. The patient was treated somewhere else, was having significant disease on angiography. There was suggestion of calcium on angiography. The patient was subjected to balloon dilatation over there. So this is what it was there with the first attempt. The patient was, the lesion was unyielding. You can see a dog boning effect. The balloons are expanded on both the ends, but the lesion is not giving way. This is all because of you are jumping into the angioplasty without looking into the underlying disease. So patient came to us. We did OCT of this patient. This is the image showing a long complex lesion with areas of calcific nodules with a minimal luminal area of around 1.47. The calcium arc was almost 360 degrees. So what we did in this patient, we took rotational atherectomy device, which polished the lesion, and thereafter did pre-dilatation with balloon and finished off with putting a stent. You can appreciate the gain in luminal length, so stent is well expanded, and on OCT, the luminal area, which was around 1.4, increased to around 7.27 square millimeter. So patient improved and was discharged without any complication. I'm showing you another case. This one is a gentleman. He's a diabetic person, around 55 years of age. He had a previous stent in right coronary artery, came with angina, was having significant long lesion in left anterior descending artery. This is tubular lesion and lot of calcium over there. I don't have the run of the IVUS, but at the point where the lesion was maximum, there was 360-degree arc of calcium on IVUS. This patient the lesion was not negotiable with the balloon, so we started with orbital atherectomy device. We crossed the lesion on glide assist mode and polished the lesion by repeated crossing of the lesion with the burr. Subsequently, stents there was a significant lesion. This lesion was fibrotic lesion. Another stent was put in the distal segment, and this is the final result. You can appreciate the change in the gain in the luminal. Appreciate I'll take few minutes more. So appreciate the artery is now looking well opened up and nicely flowing vessel. So patient gone without any complications and is doing very well. This is the final case. This is a double vessel disease. Patient is having a significant disease in proximal LAD and a CTO of RCA. The angiography was showing a calcific chronic total occlusion of the RCA. RCA was receiving collaterals from the left anterior descending artery. The combined injection showing a lesion a length of around 20 to 30 millimeter length, and it was crossed with the CTO wire, and the distal end of the wire was checked that it is within the lumen, and we started pre-dilating the lesion because the lesion was unyielding. And showing dog boning effects. So we took down IVL balloon and given a 12 cycles of shocks, each of 10, each of consisting of 10 waves. And finally, we finished up with putting a 2 stent, and a very good flow, distal flow achieved. This is, and then we switch over to the left anterior descending artery. And since the lesion was uncrossable with the balloon, so we started with orbital atherectomy device. You can see on the left panel, the guide is coming out of the LMCA. So suggesting that that there is lot of anterior resistance to the passage of the burr. So with repeated effort, we could cross the lesion and finally polished it and given a single stent from proximal to ostial part of the LAD and achieved a very good end result. So you can appreciate that if you image these patients appropriately, if there is a suggestion of coronary calcium on conventional angiogram, and if you take the appropriate modifying tools, you can achieve a very good end result. So the key is to image the lesion whenever there is a suggestion of calcium, plan the modifying techniques, optimize. For optimal result, you have to choose the adequate modifying device. Thank you. After imaging, you can, because the calcium can be superficial or deep. So after imaging, you can, because if you don't do imaging, the first case I showed you, you will end up as a failed PTCA. It will always end up in a failed PTCA. You have to plan it on the table. And if you have all the modifying techniques like ROTA, orbital, or IVL with you in the cath lab, then only you can take up these cases. Or you can plan them after doing imaging for a later date if you don't have these modifying machines with you. So our cath lab is having all the three. So we are privileged to do all these cases in the same setting.
Do you do CT angiography in every patient, or how do you do this calcium evaluation in patients?
In current practices, definitely CT angio has a good role if you are dealing with a chronic total occlusion lesion. It helps you in planning, looking into the occluded part, but it doesn't, because you cannot image them appropriately beforehand. So for planning for the success of the procedure in such cases, definitely CT angio helps a lot.
But in acute cases, you cannot do CT angio, there is no time. So then on table only you have to see the angio and then decide what to do.
Yeah, in CTO, you can plan after
acute MI.
Acute MI patients, usually when the arteries are laden with thrombus, atherectomy and other devices are out of question because it produces more thrombus. So you tend to do, if there is a calcium, tend to do it with mostly with IVL or cutting balloons.
Thank you.
Thank you. Thanks a lot.
Ma'am, we'll have to close the session. We're already late.
Thank you. Thank you. Thanks.
Thank you, Dr. Chandrasekhar. Thank you, the chairpersons. I request chairpersons to please honor Dr. Chandrasekhar. This side, sir. Come, please. Please come this side. Our next speaker is Dr. Saurabh Bagga. He is Additional Director, Cardiology, Fortis Hospital, Shalimar Bagh. Please come on the stage, sir. And the chairpersons for this session are Dr. Rajiv Gupta, Dr. Bhanu Mishra, Dr. Amit Johri, Dr. Naveen Nischal is there, Dr. Nitin Agarwal, Dr. Rakesh Sood. Please come on the stage and chair the session.
Well, here we have Dr. Bagga, who is an excellent cardiologist and intervention cardiologist. Today he will be shifting from invasive cardiology to a very interesting topic of changing paradigm in lipid lowering. A lot of things have changed. A lot of water has flown under the bridge as far as lipid lowering treatment is concerned, from statins to PCSK9 and now other latest drugs. So we'll hopefully listen from our learned Dr. Bagga about this changing paradigm in lipid lowering. Dr. Bagga.
Very good afternoon to everyone. Thank you, NDPF, for inviting me for giving enlightenment on the lipid lowering therapy today in this conference. So we'll discuss about the changing paradigms in the lipid lowering therapy. So we all are talking nowadays of the lipids, to lower the lipids. Now, what is the paradigms to see and treat about the lipid we'll see today. So we'll see in this session about the target LDL level in high risk ASCVD patient. How would you go for that? About the escalation of lipid therapy in post ACS patient, how soon you can do. And what about the novel therapies like inclisiran, whether there is any space in the current lipid lowering therapy of this molecule. The clinical evidence and guideline about this molecule, and about benefit to the patient with the ASCVD, what we have, and about the overcome cost barrier with this newer therapy. So about how would you go with respect to target LDL for your very high risk ASCVD patients. So what are these ASCVD patients? These are the atherosclerotic coronary vascular disease patient, and you start the lipid lowering therapy in this ACS patient. So any patient you come to you, according to guideline, you have to treat that. So if during the admission there is a patient is on prior treatment or not, where we have to see. So if patient is on LTN-NAV therapy, initiate the high potency therapy, that is statin, that is the atorvastatin 80 mg, 40 to 80 mg, or rosuvastatin 20 to 40 mg. This is the class 1 indication. And you can add on the combination therapy of the statin with the ezetimibe. That is the another molecule to lipid lowering. This is a class 2B indication. So if patient is already on statin therapy, then change this to high potency therapy, means high dose, and then you can add the ezetimibe. What about if patient is already in high dose therapy, and if you have, on that, if patient comes to you, you have to see the LDL levels. If it's less than 55, add the ezetimibe. If already on high and the LDL is below above 55 in both therapy, that is the atorvastatin or rosuvastatin plus ezetimibe, then you can add this newer molecule, that is the PCSK9 inhibitors. So here stand the status of this new molecule. If the therapy doesn't down the LDL by combination of statin and ezetimibe, then you have to use this PCSK9 molecule. So this is at present when the patient comes to you. Then you have to follow the patient after 4 to 6 weeks and see if whether the cholesterol gets controlled, that is the LDL gets below 55, not, then add the ezetimibe. If even on both the therapy and even not controlled, then add the PCSK9. So another, if you are on statin plus ezetimibe and that's not controlled after 4 to 8 weeks, then again you have to see the levels. If it's high, then you have to add the PCSK9. So this is a scenario where we can use different kind of therapy at what level and what levels of LDL should be achieved with this therapy. So we know that when the patient comes to you, the levels are high. So we have to reduce this level as early as possible. So we get the best benefits. So hit hard and hit early is the main dictum for the management of LDL cholesterol in ACS patients. So any patient come with you, do the lipid profile at that time within 24 hours of the admission, start the high dose statin therapy with the ezetimibe. If the level is less than 55, and do the follow-up after 3 months. You have to look for the non-HDL cholesterol in those patient also. That it should be below 85. If the patient on then next follow-up should be at 4 weeks. If patient has not controlled his cholesterol, that is LDL is above 55, add the bempedoic acid. If it's controlled, that's okay. If it's not controlled, then you can use the PCSK9, that is the inclisiran molecule. In very high risk patient, the target of LDL will be more than less than 40 mg per deciliter. So you have to come more low in extreme highly patient. So how soon you recommend the escalation therapy for the post-ACS patient? So any patient come to you, we have done the treatment for that is a PCI. First 90 days are very critical because the recurrence of second MI, stroke, CV death occurs in 100 days more, and 1 in 10% report that. So also in the registry, there is high risk, that is 10% risk in 1 year of death, MI, and recurrent ACS in such kind of patient. So we have to hit hard, strike strong, and give the aggressive management dyslipidemia to circumvent this period. So when patient comes to you with the ACS, diagnosis, treat him at the day 1, admission of ACN lipid profile testing done, and reevaluate at 4 to 6 weeks. If not control, increase the full dose plus add the ezetimibe second therapy. If you not control, then add the PCSK9. What about the of this cost of this therapy? So this molecule is costly. So we have to give this therapy at the time of the admission, 3 months and then 6 months. So if you mention in the insurance about the therapy duration, you will get that cost benefit, and the patient can have the initial 2 dose in under the insurance because pre and post are covered in many insurances. So where do this novel therapy fit in current lipid lowering space? So what is this newer molecule? So till now we are studying about the statin, that is atorvastatin, rosuvastatin, then the ezetimibe and the bempedoic acid. Now what if we didn't get control with this therapies? So we have the newer one therapy, that is inclisiran. And what is it? It is a small interfering RNA therapy for lowering the LDL production. So how it acts? This molecule is designed especially that it is attached to GalNAc that specially go to liver because of this GalNAc conjugate, and where it reside in the endosome and slowly release into cytoplasm, where it binds to the silencing RNA into silencing complex, and this complex cleaves the multiple species of PCSK9 mRNA and prevent its production. And this, what is this PCSK9 do actually? PCSK9 degenerates the LDL receptor in the liver. So if the PCSK9 level will reduce, the LDL receptor will be more in the liver, and the more LDL will be absorbed, and more LDL will be removed from the blood, from the hepatocyte. So this inclisiran basic is a RNA therapy which reduces the PCSK9, and this leads to the reduction in the LDL. How we have to give this? So statin we have to take regularly 365 days. The antibody which has been this evolocumab, PCSK9 antibodies, that's 26 days per year. But this small RNA therapies, you have to get 2 days per year, because next on continuation we go to 6 monthly dose. So what are the silence evidence guideline recommendations for this therapy? So till now we have seen that this is a molecule, whatever the evidence. So there was many trials about this drug, that is the Orion series of trial, and the pooled analysis from the Orion 9, 10, 11. This is a trial of inclisiran, which has shown that not only this therapy reduced the LDL by 50.7%, that is effective LDL reduction, but also sustain this reduction till 6 months and later on also. So 50% sustained reduction continued with this therapy. And if you see, there is 75% of the patient who has taken this therapy achieve the goal of less than 50 mg per deciliter of LDL by taking this therapy. What about the other parameters of lipid, whether it's benefit or not in that or not? Yes. So total cholesterol is also reduced by 29%. The non-HDL cholesterol reduced by 42%, and the ApoB also get reduced by the 40%. So it's not only the LDL, other molecules get also reduced. What about the Indian scenarios patients? Whether there is any evidence for Asian people? Yes, we have the trial for that the Orion 18, yes, which has included the Asian patient, Indian patients also. So where also it has shown that the sustained reduction of 56 and effective reduction of 57% with this therapy, and 71.7% has achieved less than 50 LDL cholesterol level in the patient who has the therapy. What about the lipoprotein A? We are talking now next to LDL to lipoprotein A. So this is also a genetic molecule which also increase the atherosclerosis, and it is high thrombogenic and inflammatory. So this also increase the atherosclerosis and MI rates. So there is no newer therapy right now, but this increase also acts on that. And in overall pooled analysis, it showed around 19 to 20% reduction in the lipoprotein A molecules too. Now we has discussed that we have to use this molecule after atorvastatin or rosuvastatin plus ezetimibe plus minus bempedoic, then the inclisiran. So whether we have any data that we can use with the low dose statin and whatever the dose of statin, and then the add-on directly inclisiran. So this trial is for that. That is a Victorian Initiate trial. So any patient who has not reached on LDL less than 70 and despite receiving any maximally tolerated dose of statin plus usual care are enrolled in this trial. And when we give inclisiran to such patient, there is a 53% reduction of LDL cholesterol and 71% achieve the levels of the LDL what we targeted. And also there is a reduction in all other parts of the lipid profile. That is a total cholesterol by 34%, non-HDL by 49%, VLDL reduction, triglyceride reduction, ApoB, LPA, all part of the lipid profile had shown improvement. What about the safety profile of this molecule? Whether there is any major side effect? So that also have been shown in trial. This is Orion 8 trial that has pulled from the all other trials, that is in continuation of additional 3 years of these trials. That is the Orion 3, Orion 9, 10 and 11. So this taken the therapy to a maximum exposure of 7 years data with more than 12,000 of patients were included. And if you see the safety profile, this therapy molecule can be given any kind of renal impairment, that is a mild, moderate or severe, and any kind of mild to moderate hepatic impairment with safety. There is no drug-drug interaction, only the injection sites reaction or some there, and some pharyngitis part is there. There is no off-target effects, means the antibodies against these molecules, even in present, this molecule work properly. So what till now this is a reduction data, means it works. But what about the CV outcome? Whether it's benefit also? So that's till now we know that we reduce the LDL, it will benefit in the atherosclerosis. But we have to give talk scientifically that there is an outcome CV trials is there. So there's our ongoing trials. These are the Victorian 1 prevent and the Victorian 2 prevent. This enrolled the patient who has the LDL more than 70, and there is 3P MACE range, 4P MACE range, major limb adverse effect, CV deaths, and always will calculate it, and soon that result will be come in 2027 and 29, and India is also part of this trial. And what about the plaque reduction is also going? This trial is also going, whether this therapy in non-coronary obstructive disease, that is less than 50% disease, and the LDL levels higher than 55, 150, 100, and the FFR proven more than 0.8 of NCT adapted lean score more than 5, and fasting triglyceride less than 400 was included in this. And we will see that there is any change in total coronary atherosclerosis volume or attenuation plaque or percentage of participation who has the regression or no change or total volume plaque atheroma volume in changes in this patient. So this result will also come soon, and we'll then have a CV outcome trials for this molecule. All guidelines has shown that add the statin, then ezetimibe. If the LDL cholesterol not controlled, add on the bempegaldesleukin or PCSK9, that is the inclisiran. Whether it's CSI, NICE expert, AC expert, ACC expert consensus, ABCD UK guidelines, cardiovascular disease and risk management standard guidelines, this all have shown that after that statin, ezetimibe, we have to use this molecule to control the LDL levels and prevent the atherosclerosis. So now we see
Dr.
the
Bhagat,
case scenario. Which
Dr.
patient will
Bhagat,
benefit? This is the
time is
last one slide. So which patient will benefit from this therapy? So you are seeing nowadays that the young patient with young MI are coming. They have the dyslipidemias. Whether we can control this patient with the only statin or ezetimibe? No. The middle-aged patients, they had a complex PCIs, that is a multiple revascularization or multivessel revascularization, and the patient those have the multiple times MI and they are in multiple ACS. This kind of high-risk patient, if the LDL is not controlled, they have the recurrent events. So this therapy will help them to achieve the target. All patient in this has not achieved the target, but if you add the PCSK9 and you can achieve the goal and prevent the recurrent event and better control on that. So this therapy will reduce the LDL by 50%, the requirement of only 2 doses per year, and where we have the safety profile data and the long-term 7 years data with these molecules. So thank you for listening, Thank you for this molecule.
Thank you for your crisp talk, and because of shortage of time, will not entertain questions as of now. Please contact Dr. Bhagat individually if any questions. Thank you.
थैंक यू डॉक्टर बग्गा. आपने तो सागर को गागर में भर दिया. स्मॉल प्रिसाइज. थैंक यू चेयरपर्सन. प्लीज ऑनर डॉक्टर बग्गा. डॉक्टर अनिल जैन. Our next speaker is Dr. Anil Dhal. He is Senior Director Cardiology, Shelby International Hospital, Gurugram. Please come on the stage. Our chairpersons are Dr. B.K. Singh, Dr. Anish Sharma, Dr. S.K. Mundra, Dr. Mundra, Dr. Jeevan Agarwal is there. Dr. Surekha, please come on the stage. Dr. Naresh Kumar Goel and Dr. Devan. Dr. Devan, please come on the stage. Sir, welcome. Please, sir.
That's okay. Chairpersons, with your permission, I'd just like to tell a story. I know that postprandially, most of our meetings have a shortfall in attendance. And also, even if those who are attendant are also very seriously looking at doing PhDs on their personal phones, which is also interesting because it makes interesting copy. And this percolates to almost every scientific forum because nobody is really truly looking to gain something. So with kind permission of the chair, I would really like to just tell a story. I don't have any conflict of interest, and I think I'll start the story by something which happened over 100 years ago. The Surgeon General of the Russian army was Nikolai Anishkov. And to him it was reported that some soldiers died suddenly. Now that story hasn't changed because even today we have some people who die suddenly, unexpectedly, and when you actually autopsy them, you could find coronary atherosclerosis. 1918, nobody knew what coronary atherosclerosis was. So Nikolai Anishkov fed a lot of egg yellows to rabbits. And he raised their cholesterol. Now, we all know what cholesterol is. Cyclopentanoperhydrophenanthrene ring. He raised their cholesterols to over 1,000, overwhelmed their systems. Please remember, rabbit is a herbivore. Unlike man, who's an omnivore, rabbit is a herbivore. So when the cholesterols were elevated, after some time, he harvested these rabbits. And he found that a lot of their arteries were choked. And he presumed that this waxy substance, which was cholesterol, came from the egg yellow. Now, this started a huge thinking. And we all started thinking that cholesterol is at fault, not realizing that this was probably not entirely true. Why was it not true? Because cholesterol is the store, the carriageway or the truck which carries it is LDL. Thereafter, another thing happened. Roosevelt had, an American president had an MI, playing golf. There were no treatments. And everybody got invested in trying to find out why he had an MI. And there was this guy called Ancel Keys who went around trying to measure how much of fat everybody took and how it correlated with coronary artery disease. And when he did that, he actually conducted a study in 11 or 12 countries, but he presented data only from 7 countries because it was convenient for him. He called it the 7 countries study. He appeared on the first page of Time magazine, got quoted everywhere, and thus was established the lipid hypothesis. In the meantime, the Framingham study started, and we started getting more and more data on how people behave with their lipids. Suffice to know that only 25% of your cholesterol comes from your diet. The rest the body synthesizes. When you were born, you had an LDL cholesterol of 25 milligram percent. And the LDL is actually got no function. We all think of LDL. We were also taught cholesterol is very important. And my friend Jasjit is here. He's an endocrinologist. All steroid hormones, all sex hormones, they all use cholesterol as their substrate. These are locally synthesized. These are locally synthesized. Now, we tried to decrease the amount of cholesterol by decreasing the diet. We started by using bile acid sequestrants. It didn't work. We didn't understand why. One guy working in Japan called Akiro Endo looked at the rate limiting step of the cholesterol biosynthesis, and he discovered statins, HMG coenzyme A reductase inhibition. But even then, it was in 1984 that Goldstein and Brown were awarded the Nobel Prize for elucidating the structure of the LDL receptor. And this receptor sits on the liver. Now, this receptor can, if there is more circulating cholesterol, it will upregulate. If there is less circulating cholesterol, it will downregulate. So keeping the cholesterol almost the same way as it was. So he also, when Goldstein and Brown were awarded this, they did not realize that these LDL receptors have a pathway of their own, that they can break down. And this breakdown happens because of an enzyme called PCSK9. And PCSK9 can be inhibited by either a monoclonal antibody, which is like Repatha or evolocumab, or by a small interfering RNA, which is the topic of my talk today, which is what we have enough and more data that this small interfering RNA, if given twice a year, will have immense therapy intensification. Dr. Jasjit Wazir asked me, what about lipoprotein little a? Lipoprotein little a carries 6 times the amount of ApoB than LDL. And this lipoprotein little a is an amplifier of LDL. So it is not only, it has got kringles in its surface. And these kringles have thrombogenic influence as well as atherogenic influence. But today we don't have drugs which actually lower lipoprotein